Okay, we are going to get started. Just really wanted to thank you all for coming. We are so excited to get to present the spotlight on stomach cancer. This has been 2 years in the making. If you've been following us at all, we tried to first put this event on in May 2020, and we got a little distracted the last 2 years. So we're so glad to be here. Thank you to everyone who's watching the streaming. This is the first time I believe we're offering it streaming so we could accommodate as many people as possible. So we're really happy about that. For the folks in the room, the restrooms are to your left. Please feel free to help yourself to any breakfast items throughout the morning. At some point, they will be cleared away, and lunch will be out there for you as well. And you're welcome to eat in here or take it upstairs and outside. If there's any special concerns you have or needs, our fantastic Aretha and Amanda are at the registration table, and they can help you with anything. So big shout out to Aretha, who has worked so hard and done a lovely, lovely job today. So I am delighted to have our opening speakers, and we're going to start with Dr. Steve Paterno. He is the Deputy Director of the Duke Cancer Institute, my boss, and we're delighted to have you here. So, Steve.
Thank you, Mara. Welcome, everyone. Welcome to Durham, North Carolina. Welcome to Duke, and welcome to the Duke Cancer Institute. And I'd also like to just take a moment to give some thanks first to our partner and sponsor, No Stomach for Cancer, represented here by multiple people. And I just met Dylan this morning, so welcome to all of you. Thanks to our co-sponsors, the UNC Lineberger Cancer Center. For those of you who know about the Duke-UNC rivalry, we actually do collaborate. We're actually friendly, maybe a little less in March. We do have a saying that we try to remind people that in basketball, we kill each other on a basketball court, but in cancer, we're on the same team, and the enemy is cancer. So thanks to UNC for being here. And thank you to our title sponsor, Red Hill Biopharma, and our bronze sponsor, Centrex. Especially grateful to the hard work done by Mara Epplane and all of her crew, and Aretha and Sydney. Thank you for all you've done to put this great conference on. Listen, as most of you here know, gastric cancer is highly fatal, with 5-year survival rates at 30%, which frankly is terrible. We all know some of the reasons for that. Early detection is very, very difficult. People remain asymptomatic for long periods of time and are oftentimes diagnosed at late stages. But there's another aspect of gastric cancer that makes it even more tragic for us. Here in North Carolina, in what the National Cancer Institute refers to for comprehensive cancer centers as a catchment area, that's their word for where most of our patients come from. For both Duke and UNC, that is most of North Carolina, some of Southern Virginia, and some of the northern part of South Carolina. Gastric cancer disparity is dramatic. There are 2 to 3-fold differences in the incidence and mortality rates of gastric cancer between Black patients and white patients. We don't understand why that is. It's a complex mixture of social and societal elements of health, of biological elements of health, of access to care and things like that. But what is central to all of these things? Number one, just understanding gastric cancer better so that we can diagnose it earlier and treat it better, and then provide better services to survivors, as well as the research that's needed to understand why do these disparities exist, and how can we intervene to mitigate those disparities and achieve health achieve health equity, all of that requires research. And that research needs to be informed by the communities that are most affected, including the patients and caregivers and patient advocates. And we're so glad that so many advocates and caregivers are here and survivors are here. We need everyone's voice to come together to help us fight this battle and to win this battle. I'm actually encouraged. Dr. Epplane and Dr. Garman, who you'll hear from later today, just finished writing a massive grant to the National Cancer Institute. We were just joking this morning that on Tuesday morning we got an email from Duke Research saying that the 1,121-page grant application is ready for your final review. Please review every page. Like 1,000 pages? Are you kidding me? And when do you need it? By noon. Okay, so listen, we need all of you. We need all of your voices. For those of you who are online as well, we need to do this as a community, and I'm encouraged that we're going to be able to make progress. Today you're going to hear from experts from both Duke and UNC, from caregivers and from advocates who are going to be talking about prevention, a new word you might hear called interception, detecting cancers very, very early at very early stages and intervening before they become full-blown cancers, treatment and survivorship. And we're so excited for all of you to be here and to be streaming and to be watching online. So welcome again, welcome to Duke. I hope you have a great and productive day today. Thanks.
Thank you so much, Steve, and thank you for being here. Okay, and next I just would like to invite Dylan Davison. He is the board chair for No Stomach for Cancer and also a CDH1 carrier.
Good morning. My name is Dylan Davison. I'm the board chair of No Stomach for Cancer. I'm really honored and thrilled to be in person after 2 years of making this event happen. And thank you for all those joining virtually. I find this is my fourth No Stomach for Cancer Spotlight event, and I find them to be educational, inspiring, also emotional, but very life-giving. So it's truly an honor to be here with you all. I'm here specifically to hopefully inspire you, energize you, motivate you, and hopefully educate you and call you to action. It takes a lot of selfless people to bring together some of the best in the world with stomach cancer research, and it's a true delight and honor to share the microphone with those people today. No Stomach for Cancer is a nonprofit with the mission to support research and unite the caring power of people worldwide affected by stomach cancer. We were founded 13 years ago. We have one employee, John Florin, and we have a working board that volunteers our time to try to help fund research and care for patients and caregivers. And we've funded over $750,000 in 13 years for stomach cancer research. I joined the board 4 years ago because my family carries a CDH1 gene mutation, which you'll hear more about later today from a patient. For me, they found stage 1 cancer, had a total gastrectomy in 2018. As you can imagine, it was really challenging trying to figure out how to live without a stomach, but I worked really hard to get back to full strength. Could not have done it without the stomachless community and expert medical professionals in the field. So now it's my personal mission as a board member to help others find encouragement and get inspiration to fight their own battles. I'd love to meet with you and hear your stories and collaborate. That's one of the things I love about these spotlight events. We get patients, caregivers, medical professionals all to work together. And we can do that during lunch or during any breaks. We also have a reception tonight at the JB Duke Hotel, which is walking distance from here, from 5:30 to 8:30. Pool table, drinks, and appetizers. We welcome you. It's a free event. And so hopefully we have some time to chat there as well. Thank you for the incredible people for making this happen. I already mentioned the sponsors, Syntrac, Red Hill Biopharma. Thank you for your sponsorship. Kermit, Suzanne, Stacy, and Anissa, thank you for sharing your stories today. And Duke and UNC, thanks for putting the war weapons aside and coming together and making this event happen and collaborating. I'm really excited for this event. So it's my pleasure now to turn the microphone over to Mira. Thank you.
Thank you so much, Dylan. All right, so we are going to start with session 1. We are going to proceed as the agenda shows. We'll give presentations and take questions and answers at the end. So I will start. I'm an epidemiologist and I focus on prevention of cancer. So I wanted to talk a little bit about best prevention strategies for stomach cancer. So I think we say this a lot. I think everyone I talked to last night knows this. Maybe the folks who are zooming in don't. It is the 5th most common cancer in the world and the 3rd most common cause of death from cancer. So currently in the US, the average age of diagnosis is 68, and about 27,000 cases will be diagnosed each year, 11,000 deaths. And the risks are higher in men than women. As we've mentioned before, the 5-year survival rate, unfortunately, is rather low. I think right now it's estimated at 33%, but much higher if gastric cancer is caught earlier. So, I've always wondered, why aren't we doing more about stomach cancer? This is a really important and really deadly cancer. And I will say these are epidemiology curves of mortality from cancer over time. And you can see on the x-axis, it starts in 1930. And you can see that we've had some epidemics, such as lung cancer from smoking. We've seen rises in prostate cancer and colorectal. Stomach, in yellow, 100 years ago, was the #1 cancer, even here in the United States. And I have great-grandparents that died from stomach cancer. You might have too. But it's been on the decline for a long time. And I think that's why, in a lot of people's mind, it's not a cancer of concern. But we're all here because we know it is. And in fact, I would suggest that that line has flattened out and it's no longer declining. I won't get into this because I know we have some great experts talking about the stomach and the location of the stomach. My research focuses on non-cardia stomach cancer, which is the body, or the cardia is closer to the esophagus. And we think there are different etiologies of non-cardia and cardia gastric cancer. Symptoms for stomach cancer are not really specific. So here are a list of symptoms that may be related to your stomach cancer diagnosis. Things to think about. I think, again, Dr. Garman is actually going to talk more about this. A lot of the symptoms of gastric cancer can be the same as those caused by the bacteria Helicobacter pylori, which I will get into in a moment. We also have numerous inherited cancer syndromes, which will be discussed in more detail today. And we know that a family history of stomach cancer alone increases your risk. As I mentioned before, male gender is a risk factor. So for non-cardia, that body of the stomach, the risk factors we have established are smoking, a diet low in fruits and vegetables, a diet high in smoked foods, salted fish, meat, and pickled vegetables. But the #1 cause of non-cardia gastric cancer is the bacteria Helicobacter pylori. So we believe it causes about 90% of non-cardia cancers. This is really interesting because H. pylori can be detected and treated. We'll talk about that in a minute too. For cardia stomach cancer, there's a slightly different set of risk factors, but being overweight or obese is related to cardia stomach cancer. So Helicobacter pylori, if you're not familiar with this bacteria, is a really interesting age-old bacteria. So it's been found in mummies. We believe it emigrated out of Africa with us. It's evolved to live in the human stomach. So obviously it does some good things, but the problem is it also is a risk factor for stomach cancer. So currently it infects 50% of the world's population. In the US, we think about 30% of people have chronic H. pylori infection. I say the mode of transmission is uncertain. Well, we believe it's oral, fecal oral, vomitous oral, but humans are the only known reservoirs. There's lots of work into H. pylori in water sources as well. What is really exciting about Helicobacter pylori as a cancer-causing agent is that there is effective antibiotic therapy. And this is really exciting, right? There are so many cancers, we don't know the cause, we don't know how to deal with it. A lot of stomach cancers caused by H. pylori can be eradicated, the bacteria, and then the risk is significantly reduced for developing stomach cancer. The problem is we are developing increasing antibiotic resistance in the United States. So we have to be really careful, and again, Dr. Garman will talk more about this, about how we prescribe treatment for people with H. pylori. And a vaccine is still under development. It would be great if we had a vaccine. That hasn't happened yet. But back in 1994, it was declared a Class 1 human carcinogen by IARC, the International Agency for Research on Cancer. We know it increases your risk of gastric adenocarcinoma sixfold, also causes gastritis, peptic ulcer disease, and malt lymphoma. So when we think about infection-associated cancers, I think often we think about human papillomavirus, HPV, for which we have a vaccine, hepatitis B virus, which also have a vaccine, or hep C, which we treat. But if you actually look at all of the cancers in the world caused by infection, more cancers are caused by H. pylori than those other infections in which we have more systematic ways of testing and treating for. And again, as you guys know, it's one of the infections and honestly cancers that, especially here in the US, we know the least about. So it was actually back in 2005 that these friendly Australian physicians won the Nobel Prize for discovering H. pylori. And they won the Nobel Prize because no one actually thought bacteria could live in this highly acidic environment of the stomach. And the great story is Dr. Marshall, the younger one, without IRB permission, actually drank some H. pylori, developed severe gastritis. So it was an N of 1, no approval, but really was able to finally show what he had seen was that there was bacteria in the stomach. And so they won the Nobel Prize for the association of H. pylori with gastritis and peptic ulcer disease. It was later that we connected it as well to gastric cancer. So the natural history of H. pylori is really interesting because most people with chronic H. pylori have asymptomatic H. pylori and will never know they have the bacteria, will never have problems. It's that middle line, right? They go from acute gastritis to chronic to asymptomatic chronic gastritis. We think that's probably about 85% of people with chronic H. pylori. A smaller percentage go on to a duodenal ulcer, and an even smaller percentage with this low acid production on the bottom will go on to pangastritis, which could lead to either a gastric ulcer or on that pathway to gastric cancer through atrophic gastritis and gastric cancer. So again, it's trying to figure out who are the folks at highest risk. This is called the Correa cascade. Pelayo Correa, a physician from Colombia, discovered this, organized this cascade, and it's really helpful to understand the general progression of gastric adenocarcinoma, so that we have this nice time period, about 15 to 20 years from normal gastric mucosa to gastric cancer, where testing and treating your H. pylori can reduce your risk. And that's really exciting because that's a real interception point for folks on that pathway. So stomach cancer prevention, what can you do? You can get tested and treated for H. pylori. If you have symptoms, if you have a family history, you can talk to your physician about getting tested and treated. Again, Dr. Garman will talk more about this. There are non-invasive ways to be tested for H. pylori, including a breath test and a stool antigen test that test for a current infection. And of course, the gold standard could be an upper gastrointestinal endoscopy if your symptoms warrant that. This amazing thing about treating your H. pylori is that it's just 2 weeks of antibiotics. And I say just 2 weeks, I know 2 weeks of 2 antibiotics and a proton pump inhibitor can cause some gastric distress. It is not nothing that we ask you to take this medication, but it is very exciting that 2 weeks of antibiotics can eradicate a bacteria that can cause cancer. What's really important if you do have your H. pylori tested and treated is that you get retested 6 weeks later to make sure that you were eradicated. We know about 70% of people successfully eradicate their H. pylori. For those folks who didn't, we really need to retest and figure out the best salvage treatments. The current studies show that if you get tested and treated for your H. pylori, your risk of developing gastric cancer is cut in half. And that's a really exciting intervention. So then the big question is, who gets tested for H. pylori? And this is kind of controversial in the field. It's agreed upon by everyone that if you have a positive test of H. pylori, you should be treated. But the question is, who should be tested? And so it's established that people with active or past gastric or duodenal ulcers, people with uninvestigated dyspepsia or with malt lymphoma should be tested. But a Houston Consensus conference was conducted about 5 years ago, where they actually invited gastroenterologists, primary care physicians, a wide range of experts to talk about who else might be high risk and who else could we help prevent stomach cancer. And they came up with these 3 other groups: patients with a family history of gastric cancer, patients who are first-generation immigrants from high-prevalence areas, and patients of Latino and African-American racial or ethnic groups, because there is this large racial disparity, as Dr. Patino talked about. And again, it's not an insurance status yet. These aren't established, but this is where we're trying to move. Can we figure out really who's at high risk and how can we help you and intercept before you've already started on that cascade farther along towards gastric cancer? I would actually also suggest Asian American racial and ethnic groups should be in this grouping as well. So what else can you do besides getting your H. pylori intestine treated? Don't smoke. If you started smoking, think about quitting. Smoking irritates the lining of the stomach, and we think also can interact with H. pylori to increase your risk. Really, those salted red meats seem to be associated with an increased risk. So bacon, ham, and sausage, those delightful salted red meats, reduce your intake. You know, if you eat it often, can you go to once a week? And then finally, if you can increase your intake of fruit, we think these are all ways to help reduce your risk of stomach cancer. And finally, getting to and staying at a healthy weight. So I'm going to move it over to Dr. Garman. Dr. Garman is a gastroenterologist and a clinician scientist. She also co-leads the Cancer Risk Detection and Interception Program of the Duke Cancer Institute with me. Dr. Garman.
Good morning, everyone. Thank you so much for the invitation to join you this morning. It's really wonderful to see all your faces here in person, and welcome to everyone online as well. Thank you to the organizers, and special thanks to Mira, who is really a fabulous colleague in so many ways and has taught me so much about this area, and I'm really happy to be here with you this morning. So I am a gastroenterologist, and I think you'll see throughout my talk some of these threads of what we do in gastroenterology to partner with our patients for cancer detection and early interception and also prevention. I think that partnership is kind of one of the key messages here. And so, especially because many of you have such a deep understanding of stomach cancer already, I think emphasizing to everyone you know, right, that patients need to have the knowledge and the confidence to talk honestly with the healthcare team, and we as healthcare providers need to be very open recipients of all the knowledge that you bring, because you know yourself best as a patient and you know how to describe what's happening with you so we can work together to optimize your health. I think it's really important today to recognize the fact that there are some healthcare gaps right now, particularly related to screening, largely related to the COVID pandemic and how that has shifted health priorities and delayed things like screening, particularly endoscopies that people may need. We're definitely going to talk about H. pylori testing today, the kind of when, why, and how as one of the key pathways for many people to help prevent stomach cancer. So much changed in the pandemic, as we all know, but sometimes we know our patients found it was really difficult to get an appointment. I see patients in clinic who say, I've been waiting for this procedure for a couple years. It was hard to get in. Maybe I just had COVID. My procedure got canceled. Maybe the doctor had COVID and the procedure was canceled. Lots of reasons why there have been delays right now. And so I think it's a really important moment to make sure that we're getting back on track. There are data showing that cancer screening was delayed. So as a gastroenterologist, obviously I'm here to talk about stomach cancer, but colorectal cancer also really important. And we know that there have been delays in people scheduling colonoscopies, and the guidelines just changed. So colonoscopy is recommended for everyone at age 45, for some people much younger if you carry a genetic predisposition. So that's an important reminder too. And then I think one of the things that I've really noticed is chronic symptoms that might be smoldering have maybe seemed less important during the pandemic. So upset stomach type symptoms might be chalked up to stress, might be dismissed because other things seem more pressing if there were other emergencies or issues. And I think now is a time to really give those symptoms their moment to be fully explored if needed. So again, this cancer screening gap, I thought this was a really stark statistic on the website cancer.gov, right? 9.4 million screening tests that normally would have taken place in the US in 2020 didn't happen. And there's a lot of concern that this will lead to people presenting at a more advanced stage and more people dying from cancer. And that's true for stomach cancer as well, where upper endoscopies, particularly for people who know that there's a genetic predisposition, may have been delayed or deferred. And we want to make sure that everybody gets back on track. I often remind people in kind of community talks that there really is very little that will embarrass a gastroenterologist. We are probably some of the most desensitized people on the planet. I have 2 teenagers who benefit from this. They laugh that there's really nothing that will get a rise out of me. There's nothing that's too gross. So keep this in mind. It can feel super awkward when you're not used to talking about your GI function, to talk about bloating and burping and gas and all kinds of other symptoms that maybe it's a little early on a Saturday morning to talk about, but really nothing will faze us. And you do know your symptoms best as a patient and can help your doctor understand your experience. So I would say aim for clear, honest communication. It helps us. And sometimes we need reminders to listen to things that you know are off as a patient. So just a reminder to empower you all to do that. Sometimes it's helpful if you're someone who gets uncomfortable around doctors. I'm one of those, even though I am a doctor, I hate going to the doctor, right? So having a list of your questions and concerns so that you don't forget anything that's important to you can be helpful and can help you prioritize what's most important to talk about. Sometimes your doctor's priorities may not be the same as yours, and so getting on the same page is really important, right? So if I feel like, oh, it's really important we talked about colorectal cancer screening, it might be really important to you to talk about something else that's going on that you want to make sure gets attention. And so we have to find that middle ground and make sure all the needs are getting addressed. We're going to talk a little bit about red flags because I think it's good for people to have a sense of like what's going to trigger your doctor to say, oh, we need to make an action plan on that. So sometimes using those words, if you're really worried and these things are happening to you, can help make sure that your care is advanced. And then I think since I've met Mara and started doing this work, I find I ask my patients a lot more about upper GI tract symptoms, even if they're coming for a screening colonoscopy. Have you had GI upset? Have you had dyspepsia? Have you ever had an ulcer? To make sure that my patients are really getting complete care and H. pylori testing and referral for further testing, even an endoscopy if needed. Okay, so red flags, right? These are what we think of, what we're taught in medical school as symptoms that your doctor is going to take very seriously because we know that they could signal a really dangerous problem and they might trigger further evaluation like an endoscopy. So of course, bleeding is something we always want to know about. Vomiting blood, that dark sticky stool that we call melena, it's very characteristic but can be digested blood from the upper GI tract that's passing from below. Having blood that's red blood with a bowel movement are all things your doctor always wants to know about. Weight loss can, of course, it's non-specific, can be a sign that something is wrong. And so that is a red flag that often will also trigger an endoscopy. Diarrhea that's waking you up from sleep, is just really hard for your health because disruption to sleep is very difficult, but also could be a sign that something is off and needs attention. Difficulty swallowing, so in my lab we study stomach cancer, but also esophageal. Difficulty swallowing, pain with swallowing, or the sensation of something getting stuck is a red flag that we also want to know about. And then it's also important to talk about change in bowel habits because obviously something has changed and we want to know about that. Okay, so we're going to talk a little bit more about H. pylori now that we've gone through those red flags. So Mara told you already, the majority of stomach cancer is closely related to H. pylori infection. And in fact, H. pylori is now considered a class 1 carcinogen. And that's why we focus so much on testing and treating H. pylori. And it can be tenacious. It's a difficult bug to treat. The treatment can be challenging. And so that partnership between doctor and patient is extra important because I tell my patients treatment for H. pylori can sometimes feel like a full-time job. It's 2 weeks of medicines. They can have side effects. We really want to know if the side effects are so difficult to tolerate that you give up taking them because then we need to switch course and pick something else so that we can successfully treat that infection. We also want to know about things like previous antibiotic exposure that might inform antibiotic resistance. since we don't have a lot of data, especially here in North Carolina, about patterns of antibiotic resistance in H. pylori, we kind of base that on your previous antibiotics and want to know about that. So there are lots of symptoms that should prompt H. pylori testing, besides the red flag bleeding and weight loss that we already talked about. Aching, burning stomach pain, pain with an empty stomach pain that's disrupting sleep, nausea, loss of appetite, burping, bloating, indigestion. These are common symptoms. They can be somewhat vague, but if this is a persistent problem, we want to know about this. And one of the things that I have realized as a gastroenterologist is because we're so attuned to colon cancer and esophageal cancer, sometimes we don't always give these symptoms as much attention as they deserve. So if you're experiencing these things, it's really important to talk to your doctor and emphasize that it's a problem for you and maybe something that has changed. Other things that should prompt H. pylori testing, a diagnosis of iron deficiency anemia that's not otherwise explained should prompt testing for H. pylori because that is something closely associated with iron deficiency anemia. There's also this really interesting condition of low platelets called idiopathic thrombocytopenic purpura, or ITP. That actually should prompt H. pylori testing, which I think even a lot of physicians may not be aware of. We also, of course, want to test and treat H. pylori in the setting of active cancer, even early stomach cancer, and then malt lymphoma, which is directly caused by H. pylori and can be cured with antibiotic therapy for H. pylori. There are lots of different ways to test for H. pylori, as Mira mentioned. And again, this uninvestigated dyspepsia, these kind of vague abdominal complaints of upper belly pain and nausea or a feeling of kind of unease, should prompt testing. And that can be done with the stool antigen test, which has become much more popular during COVID when breath tests kind of fell out of favor. And it's just, you submit a stool sample to the lab, they run the antigen test. It looks for active infection, which is really helpful. The breath tests are also a great way to test for active infection. And then as a gastroenterologist, I think our standby is always, we'll just take a bunch of biopsies throughout the stomach and make sure that there's no H. pylori infection there. And all of those tests look for active ongoing infection. For any physicians who are listening, these are the different test characteristics, lots of good tests. I will note serology, which is an antibody to ever having been exposed, is not as sensitive or specific as some of the other tests, but breath tests, stool antigen, and biopsies are all great. It's really hard to culture H. pylori, so we don't rely just on a culture of H. pylori from the stomach. But when we find it, we know that the organism was there. So again, things to discuss with your doctor. Have you ever had stomach ulcers, even if a long time ago? Ever in your life should be a prompt for H. pylori testing. Some other considerations are if you're starting to take a low-dose aspirin long-term for cardiovascular disease, having H. pylori tested and then treated if you have it reduces risk of bleeding and is one of the indications. Similarly, starting a chronic nonsteroidal for arthritis like ibuprofen is another prompt for testing and treating for H. pylori. Family history is controversial, as Mira already alluded to. So in the US, our guidelines don't always recommend testing for H. pylori, even if a family member has had stomach cancer. But we think that this is starting to change, and I think that that's probably appropriate. So there's this new study in the New England Journal, the reference is on the next slide, where they performed a clinical trial in people with a first-degree family member with stomach cancer. They tested for H. pylori. Everyone with a positive test was randomized. So in the US, once H. pylori is diagnosed, we always treat it. In this clinical trial, they treated half the people, and what they found was that after treatment, people were much less likely to be diagnosed with stomach cancer compared to people in the placebo group. And again, people with a family history suggesting that testing and treating for H. pylori in this population was very helpful. Again, Mira already showed you the Houston Consensus Conference guidelines that, again, are pushing us more toward this consideration of family history as being a prompt. There are some other factors such as where you grew up, if you're an immigrant, and some of the higher risk populations in this country where gastric cancer tends to be higher than in other populations. And again, this area is going to continue to evolve. We're going to hear more today about some of the genetics of stomach cancer, and I know this is something many of you are very familiar with, but I do think it's really important for anyone with a family history of stomach cancer or other cancers in their family to talk to your doctor about this. We are starting to understand more beyond CDH1. There are other inherited conditions. Lynch syndrome is one, and I'll show you some of the others that are probably associated with stomach cancer. And while not all of them have that link to H. pylori, some of them probably do. And Lynch syndrome is one of these where there's a gray area. It's not clear how much benefit there is to testing and treating H. pylori in patients with Lynch syndrome reflexively, but this is an active area. And some of our guidelines are trying to say if you have Lynch syndrome, at least one H. pylori test is suggested. There are some really new papers that came out this year looking at DNA repair genes, BRCA2, PALB2, and ATM that may be associated with an increased risk of stomach cancer, both the diffuse and the intestinal type for some of these. And we really are starting to think more about H. pylori testing even in these populations, although our guidelines aren't there yet. So stay tuned as this continues to be an evolving area. Again, as Mira noted, any positive test for H. pylori needs to be followed with treatment and then eradication testing. There are several good options for antibiotic therapy. Talking to your doctor about antibiotic exposure is helpful. And that's all that I have. Thank you all so much. Are we taking questions, Ashley?
Any questions now? Right there. Okay, so that is the end of our first session on prevention. Does anybody have any questions for Dr. Garman or myself? Great. And I have a microphone. Hello? There. You should turn on. Yes, I think it's on. Okay, thank you. All right.
Hi, my question is, I'll just give you my example. I'm stage 4 stomach cancer, and this is my brother. And so I did not have H. pylori. Is it possible that at some point in my life I did have it and then it cleared? And then if that is possible, with somebody with a family history, would you recommend the testing maybe every 5 years? Can it come and go like HPV?
These are great questions. So thank you for sharing your story, and so glad that you could both be here today. So yeah, by the time stomach cancer is diagnosed in the general population, we only detect H. pylori about a third of the time. That doesn't mean that most of those other folks who tested negative never were exposed to H. pylori, right? The data tell us 89% of stomach cancers were associated with H. pylori at some point. We are starting to learn more about genetic risk and other things that maybe we don't fully understand in the environment that may be contributing to stomach cancer, particularly in younger people, and younger women is a really hot area here for thinking about what we don't know and trying to make progress. The guidelines are mixed in terms of family history and testing for H. pylori, but certainly from a preventive, personal kind of perspective, I would veer toward those Houston consensus guidelines to say, you know, it seems to make sense to test for H. pylori, and particularly if there are any kinds of symptoms of any GI upset at all, testing for H. pylori is not expensive and may have some benefit, particularly if it's eradicated, as those data from Korea are telling us. So the guidelines are a little bit vague, and I think this can be a very confusing area for patients because doctors may give you mixed messages, and there may be doctors that say, well, the American College of Gastroenterology does not suggest testing for H. pylori in family members, and I would say this is where you can kind of keep talking about, about your concerns and say, I understand that the guidelines are mixed at this point. In terms of reinfection, in children and in some populations where there's a lot of shared eating, H. pylori reinfection is a real concern. So there are lots of reasons why H. pylori can be persistent. The treatment can fail, and reinfection is a risk. There are no guidelines saying in healthy adults to test for H. pylori on a regular basis. Most of the guidelines say one-time testing and treating, particularly for most adults in the United States, where we don't do a lot of sharing of utensils and things like that. For children, young children, where there's just a lot more sharing of secretions, if children have persistent symptoms, reinfection is a real concern. Did I answer your questions okay? All right. Morning.
Trey Blazer, I'll be giving the surgery talk later. I guess my question would be, how good are we right now at following these guidelines? And, I'll just make the point that I had my primary care appointment yesterday. We talked about colonoscopies, we talked about PSA, and I didn't get one question about dyspepsia or anything like that. So what do we know right now about how good we are at doing this, and how do we get better?
It's a great question. So, we don't routinely ask about dyspepsia as part of routine care. And not only that, I think we are quick to dismiss dyspepsia when we hear about it from most patients. So this is where being persistent, if this is something you're concerned about, is really important. What we know in terms of how good we are about following these guidelines is we're terrible. So the guidelines right now tell us when we diagnose H. pylori, we should always treat it. We're okay at that as a medical profession. We could do better. We have data showing we could do better. But where we really fail are in 2017, our guidelines changed to say, not only should we always treat H. pylori when we find it, we should always order eradication testing, which means another test after treatment to make sure the treatment was successful. I had some residents who came to me and said, we want to do a project on H. pylori, and people with peptic ulcer disease who actually had like a bleeding ulcer that brought them to the hospital. 40% of those patients had eradication testing after their treatment for H. pylori, which is lousy, right? And in the VA, there's some data suggesting it's even worse than that. Nationwide, it's about 40%. So it's a really great question that Dr. Blazer asked, because if you have had H. pylori and you're treated for it, you need to make sure that your doctor orders another test to make sure that the H. pylori has gone away. And as doctors, we need to make sure that we're ordering this eradication test with a breath test or a stool antigen. If you need a repeat endoscopy to make sure an ulcer is healed, or for surveillance for gastric cancer screening, great, that's another opportunity. But this can be done easily with a stool antigen test these days. Great question. It's why we're all here, right, to raise awareness about some of these issues too.
Thank you, Dr. Garman. Stephanie Wheeler from UNC.
Hi.
Picking up on Dr. Blazer's comment, I wonder if you can talk about the opportunities for increasing public awareness. It seems like H. pylori is something that the general public just doesn't hear much about. And, if there was a way to, through smaller mass media campaigns to improve awareness, then the self-advocacy that you're talking about could actually increase. And the symptoms you describe are pretty nonspecific. So if people aren't getting the response from a primary care professional that would lead to the testing that you're describing, is that an opportunity to then self-advocate for a referral to gastroenterology, or what would be their next steps? But somehow educating the public.
Yeah, it's a great kind of public health question, right? And I think we need a multi-pronged approach, right? We need to have events where we're talking with people and we're out in the community and on Twitter and things that my teenagers are much better at than I am, right? About putting things on our websites and really being active. I know since Mira and I have been working together, we have had the opportunity to do more of that kind of thing, but also talking to colleagues, which I think is really important. So giving GI grand rounds and medicine grand rounds and making sure that doctors are informed, and also helping to enable our patients. And so both parts are really important, and I am open to ideas for how we can all partner together to do that better, because it is such an important point. I don't have all the answers for how to do that, but I definitely believe it's important. And I can tell you all a little anecdote. Mira hears these stories from me all the time, but I had a patient, I was doing a screening colonoscopy, and he was telling me about some just kind of a little bit of his family history. And he said, no family history of colon cancer. And I saw that he had something from many years ago that suggested he had maybe had an ulcer. And I asked him, he said, oh yeah, I was actually life flighted out of Vietnam a long time ago because I had an ulcer. And I said, did anyone ever test you for H. pylori? And he said, no, but I've been really worried because 2 of my uncles died of stomach cancer. But no doctor in the time from Vietnam until when he saw me had ever talked to him about this. And he had H. pylori, which we ordered with a stool test after his colonoscopy when he, when the prep was all done and he was eating again. But he came back, he got the test, he had H. pylori, we successfully treated him. And I think if we hadn't had that conversation, that never would have happened. And I don't know his genetics of why he had multiple family members with stomach cancer, but I worry about patients like that who, because either it's doctors or he just not feeling and able to have that conversation, that was like a near miss, right? And so we want to avoid those situations, yeah. So we should talk more. Thanks for the question. Anybody else?
Great. Any more questions?
Okay, thank you. Thanks.
Thank you so much, Dr. Garman. That story always gets me. So I'm so glad we have folks thinking about H. pylori, thinking about family history, talking to your patients. Okay, so we are on to having a break. Our break is scheduled until 9:45, so 15 to 20 minutes. If you want to go and get some drinks or food, go outside and get some fresh air. You have to go upstairs to go outside because I think these doors are locked. Is that correct still? Yes. And the restrooms are to the left and the elevators are to the left and the food is out there. So we'll see you in about 15 minutes. Thank you so much.
We are going to get started in just one more minute. So just to give folks a word of warning, if you're still out in the hall and you want to come back in, if you are one of our speakers for our session 2 panel, if you would please come have a seat and join us up front. We'll get started in just 1 minute. Thank you for being here. All right, so if you would like to come back in and have a seat, it gives me great pleasure to introduce to you our next speaker. Dr. Ian Grimm is Director of GI Procedures at UNC Hospital. He is a professor of medicine, and we are delighted to have you with us. And we'll start session 2 now.
Great, thank you for that kind introduction. I'd like to start with this slide because it's a really powerful illustration of how effective screening can be and early detection. So simply put, early detection saves lives. So in the red, you can see the long-term survival of gastric cancer in Korea and Japan. About 2/3 of patients will have a long-term survival as opposed to about a quarter in the US and Western Europe. And this almost perfectly correlates with the percentage of cancers that were found at an early or localized stage. So again, in East Asia, 2/3 of cancers are being detected at a very early and curable stage, whereas in the US and Western Europe, it's less than a quarter. So who are candidates for screening? In the US, we need to screen first-generation immigrants from Eastern Asia. They're the highest risk people. It's the highest risk country in the world, and even more so if they have a positive family history of gastric cancer. And then we're going to recommend screening for these precancerous conditions, which you've heard about already. There's a bunch of genetic syndromes listed there. Most patients with these are being screened periodically with upper endoscopy. And then you have the category of hereditary gastric cancer and individuals with pathogenic variants of CDH1 gene. So how do we screen? There's 3 methods: radiographic, endoscopic, and serologic. This is an upper GI X-ray, which have been used for decades as a means of screening in Korea and Japan. It's inexpensive, it's safe, it's widely available, but it's not very sensitive for detection of early gastric cancer. And it's largely been replaced by endoscopy. Endoscopy is, of course, more expensive, it's more invasive, but it's very sensitive for early cancer detection and detection of precancerous conditions. In East Asia, it's been associated with a 40% reduction in gastric cancer mortality. So this on the right is an illustration of what they do in Japan. They have a very rigid pattern of taking photographs in the stomach. You get 4 quadrants in one part of the stomach, then you go to another and you get these 4-quadrant photos. So you're supposed to get 22 photos to document all these areas, and that's often useful when the patient comes back in the future. You can compare changes over time. American endoscopists are nowhere near as compulsive or organized in their approach to this, and sadly have very little experience recognizing early gastric cancer because it's very uncommon in the West. The last method of screening is a serological one, which is not really of practical use in the US. So there are really 3 major classes of stomach cancer that are really quite distinctly different from one another. So you've heard mostly about the intestinal type on the left, which is what's associated with Helicobacter pylori. There's the diffuse type, which is associated with the CDH1 mutation and hereditary diffuse cancer, and it's really rare. It's only 1 to 3% of all stomach cancers. And on the right, we have the cardiac cancer, which is really more similar to esophageal cancer, and it's not really a topic of discussion much today. We're focused mainly on non-cardiac cancer, which is the two categories on the left. The really important takeaway from this slide is that in the intestinal type of cancer, there are very prolonged precancerous stages, and they are all visible endoscopically. So there's a very, very long period of multiple decades in which you can identify patients at risk and follow them and detect early cancer. That is not true of the diffuse type or undifferentiated cancer associated with CDH1 mutations. There is no visible precursor lesion. The cancer does not develop on the surface lining of the stomach where it's visible. It develops below the surface. So it's really not amenable to screening. Cardiac cancer, again, located in this area, not really the topic of today's discussion. It's more like esophageal cancer. So we're talking about non-cardiac cancer. You've seen the Korea cascade, and my emphasis here is that all of these precancerous stages here are visible endoscopically. And it's just a really wonderful opportunity to detect something way before high-grade dysplasia or early cancer develop. So when you go from chronic gastritis to atrophic gastritis, the risk of cancer is very low. When you reach intestinal metaplasia, you have about a 6-fold risk of developing cancer in the future. And then when you go to dysplasia, the hazard ratio goes up to 11. So this is atrophic gastritis. This part of the stomach here is very, very pale. There's no folds like you normally see in the stomach. The mucosa of the stomach is very, very thick and has these folds, whereas in atrophic gastritis it's gotten very thin. And you can see actually blood vessels right through. These little blood vessels show you how thin it is. So this pale demarcated area is atrophic gastritis, and it's not hard to diagnose endoscopically, and it is, again, the first stage in the Korea cascade. We have these protocols for doing biopsies throughout the stomach to determine how extensive the atrophic gastritis is. Next important stage is intestinal metaplasia. It's this whitish, frosty appearance, and it's not hard to recognize with some experience. This is a picture through the scope with a blue light filter that helps you recognize better what's going on here. And then up close with the blue light, you can see what's called a light blue crest. These blue lines are really diagnostic of intestinal metaplasia. And it's not uncommon in the US. 5 to 10% of the population has intestinal metaplasia. And it's a little uncertain how to manage that, perhaps. So intestinal metaplasia is the primary precursor to gastric cancer throughout the world, but the absolute risk is very, very low. So we're talking 2.5 cases for every 1,000 person years. Or if I follow, 1,000 patients for 10 years, I get maybe 25 cases at most, perhaps even less. We're supposed to do mapping biopsies of the stomach to see how extensive the intestinal metaplasia is, and then consider recommending endoscopic surveillance every 3 to 5 years when it's extensive, when there's a first-generation immigrant from a high-risk country and ethnic minorities, and anyone with a family history of gastric cancer. How do we diagnose gastric cancer? Well, endoscopically. Late, there's usually a mass, there's ulceration, there's bleeding. It's usually quite obvious. Early cancer, very, very subtle, very difficult to recognize sometimes. There might just be slight redness. There might be irregular microvascular or microsurface changes that aren't even apparent through a regular scope. You might need to use a magnification scope to even see these. And there's a demarcation line, which is something I'll show you here. So this is a late cancer. There's a big mass, there's a big ulcer, and it maybe even was bleeding, judging from the looks of it. This is late. We don't want to find this. But sadly, that's how most stomach cancer presents itself in the US. Whereas in Asia, this is what you'll get, a magnification image of a tiny, tiny little lesion. This little bit here is just a couple of millimeters and could easily be overlooked. Here you have a magnification scope which shows you these abnormal blood vessels. Those are tumor vessels. There's a demarcation line. That's early stomach cancer. It's highly curable. In Japan, they not only have magnification scopes, which again on the right is a magnified image, which is more than we can get in the US. We don't have this power of magnification on our scopes. We also don't use this blue dye spray, which you can see the blue dye helps accentuate the margin of this very, very subtle growth, which might have been almost invisible without the blue dye. These are examples of other early stomach cancers. And again, you can see the blue dye accentuates the surface pattern here and makes it a little more recognizable. So, you know, there's a slight redness here, very, very, very easily missed. Some of these things look like, you know, tiny little erosions in the stomach that are caused by aspirin and ibuprofen and things like this. Wouldn't always be recognized in Western context. Here's a very, very subtle, lumpy, bumpy thing in the stomach. Could easily be missed, but with the blue dye, now you can see the borders of it much better. A few more pictures. This is a cardiac cancer. This is the scope looking backwards at itself. And again, this is the differentiated type of cancer associated with Helicobacter. This is what's called undifferentiated cancer, not associated with Helicobacter. Typically presents as just a pale, almost white little patch, and the blue dye may help accentuate those as well. So many of you know about this condition of hereditary gastric cancer. It's also called diffuse cancer. And it's been said that the lifetime risk of cancer, if you have this pathogenic germline mutation, could be as high as 80%. We think now that that may be an overestimate. But the recommendation has been that if you're in one of these families and you have this gene, that you have your stomach removed in your 20s or your 30s to prevent cancer. These gene variants can be found also in patients with lobular breast cancer. And many times these patients face a dilemma whether or not to have stomach surgery. And so the advice is that you have an endoscopy and that we perform this Cambridge protocol to biopsy many, many areas in the stomach. And you're supposed to follow precisely this instruction here. You're supposed to spend 30 minutes examining the stomach, which probably most people don't do. You're supposed to do extensive washing. Ideally, you need to give a substance that will remove the mucus lining from the surface of the stomach. Again, we don't do that in the West. But we do take a whole bunch of biopsies, so 5 random biopsies from each of 6 areas, a total of 30 biopsies. And this sort of protocol would often be repeated on an annual basis for someone who is CDH1 carrier but has not decided yet to have stomach surgery. Well, here's my favorite slide here, perhaps. The surface area of the stomach is about that of a 12.5-inch pizza if you flattened out the stomach completely. The biopsies that we take are tiny. These forceps on the largest dimension are about 7 millimeters. Those little cups, they're about 3 millimeters wide. So when you take a biopsy in the stomach, it's maybe like sesame seed or something similar, maybe a little bigger. So the surface area of the stomach is 800 square centimeters. The biopsies are about 9 square millimeters. And by my math, you get 0.3% of the stomach is being sampled with these 30 biopsies. That's just some crude math on my part. There's some other numbers I'll show you here. This pathology study that looked at actual stomachs and did some calculations concluded that you would need 1,768 biopsies per patient to have a 90% detection rate of stomach cancer. Well, that ain't going to happen. So there's inability to sample extensive amounts of the stomach with biopsies. So in patients who have their stomach removed and they have this family history and they have this gene, you look at the stomach under the microscope after it comes out, 45 to 60% of the time you will find small cancers in there. So my concern about this whole Cambridge protocol business is false reassurance from negative endoscopic surveillance. I mean, I can tell you that I didn't find cancer, but I can't tell you that it's not there. This is what a signet ring cell cancer looks like. Again, it's this little pale business here. A lot of doctors don't even know how to recognize it. They've never seen a case in the West. It's lacking cohesion. These cancer cells are not sticking together and forming a tumor. They don't do that because they lack this protein made by the CDH1 gene that allows cells to stick together. So this often you will have just like single cells of this tumor rather than a big growth. And it infiltrates under the surface of the stomach, and it can spread long distances in the stomach before it's spread anywhere. But so early gastric cancer is defined as anything that's restricted to the surface layer, the mucosa, or the layer just beneath it, the submucosa. Early detection improves survival, and if found early, you have 90% 5-year survival for stomach cancer. And again, what we've heard several times already this morning, 70% long-term survival in East Asia due to screening versus 30% in low incidence countries. This is a recently published guideline on ESD, which is a treatment for early stomach cancer. And what it says is that if you have any signs of more advanced cancer, you need to go to surgery. But if it looks like possibly an early cancer, you should have ESD. Well, what's that? ESD is endoscopic submucosal dissection. Cancer is this orange thing. We mark the surface with these little dots around the circumference. We inject a blue dye underneath the tumor, and then we tunnel underneath it with this microsurgery technique. And the aim is to get this one piece here on block with negative margins. So the pathologist slices this up and looks at it under the microscope and says, you know, the edges are clear, the bottom is clear, looks like a cure. That's called the R0. So this is, again, this pale stuff here, very, very, very hard to recognize. Now you can see it better with the blue dye. Now you've put the marking dots around it. You've made an incision all the way around it. And then you start to tunnel underneath it. And this is a gradual process of tunneling and tunneling. You inevitably will hit these blood vessels here. You have to cauterize them or they will bleed during the procedure. And it's a slow, meticulous process by which you get out this beautiful piece here. You can see the marking dots around the edge, and this is the crater when it's done. That heals in pretty quickly on its own. But this is, a beautiful specimen for the pathologist to look at and tell us whether or not we cured it. This ESD procedure has been perfected in Japan and Korea and only recently come to the West. We participated in this study showing that American endoscopists can do a pretty good job of gastric ESD. So 347 patients had stomach ESD at 25 centers in the US. The en bloc and R0 resections were 92 and 82%, which is not bad, comparable to what you'd see with a Japanese expert. And recurrences of stomach cancer following a curative ESD were 0. So Western doctors can do this, but they don't get a lot of practice in the stomach. So I'm going to close with 4 takeaway thoughts for you. Early gastric cancer is highly treatable with endoscopic resection and surgery, but most gastric cancers in the US are detected late. Screening of high-risk individuals is recommended, but endoscopic recognition of early gastric cancer remains challenging. Thank you for your attention.
Thank you to Dr. Grimm. We're going to take questions after all of the speakers in this session have finished. So our next talk is on genetic considerations of stomach cancer, and Nicolette Sloat is one of our certified genetic counselors here at Duke, and we welcome you this morning. Thanks for giving the talk.
Thank you. Okay, can everyone hear me okay? Great. As you know, I am a genetic counselor here at Duke, so I'm going to talk a little bit about the basics of genetics of cancer and provide a little bit of information about how genetic testing and genetic counseling can potentially be helpful for an individual with personal or family history of gastric cancer. So with any patient that I see, I like to start by pointing out that most cancers are not genetic. We would estimate that about 5 to 10% are due to a hereditary predisposition, whereas the vast majority are what we call sporadic cancers, which are likely the result of a combination of many things: our environmental exposures, our lifestyle, our just random chance to develop these cancers. In the middle, you can see there's a third category, what we call familial cancers. And to illustrate that, I like to point out that, we share more than our genes with our family. We also share our environment and sometimes our habits. And so certainly there are likely cancers that have some contribution from both genetics and some of those other factors. Now, when I see a patient in clinical cancer genetics, there are certain characteristics that I am looking for that would tip me off that there could be a hereditary syndrome at play. Things like early onset, when we see cancers forming in younger individuals than we would expect. Rare cancers or unusual presentations. Multiple family members with either the same cancer or cancers that are associated with one another. And then more and more, we are getting information from the tumor itself that may tip us off that some genetic testing is needed to clarify whether there might be a hereditary cause for a cancer. So, why does this matter? What is the importance here for the patient? Of course, knowing your risk can help you take some proactive steps in some cases. That could look like changing the management of the cancer that you have, perhaps preventing a cancer in the first place, and of course, we'll talk a little bit more about preventative steps. We may be able to detect a cancer earlier than we might have if we didn't know that you were at a higher level of risk. And that can potentially improve outcomes, when we catch it at an earlier stage. Then finally, we can potentially alert our family members to their risk, allowing them to have some proactive options as well. So I'm going to provide a little basic genetic information. So first, each of the cells in our body contain a full copy of our DNA, or our genetic material. You can think of DNA like an instruction manual that tells our cells how to grow and develop properly. DNA is organized into segments called genes. You'll often hear, terms like DNA and genes, and that's just how they are related to one another. And finally, each gene has a unique job. We have over 20,000 genes, and they each play an important role. Some, in telling our eyes what color to be, others in contributing to how tall we get. But what I am working with regularly within clinical cancer genetics are genes that help to protect us against cancer. They play a really important role in regulating how our cells grow and develop to prevent them from turning into a tumor or a cancer. Both men and women have these protective genes, and we have 2 copies of each protective gene, one inherited from our mother and one inherited from our father. We hear the term genetic mutation, more and more these days. A mutation refers to a gene that is broken or is not functioning properly and cannot do its job. A mutation in a gene that should be protecting us against cancer can, impact the likelihood that we develop a cancer in our lifetime. In our clinic, we order hereditary genetic tests that will look for these mutations in genes that are important for protecting against cancer. And these genes would be present from birth or something that was inherited from a parent. Of course, I already alluded to testing of the tumor. There are genetic tests that are performed specifically on tumor tissue that are looking for mutations that arose during the development of cancer and are not passed on in the family. When someone is found to have one of these genetic mutations, we generally will now know that there is a 50% chance or a 1 in 2 chance that that person will pass that mutation down to the next generation each time they have a child. Mutations do not skip generations. If there is a mutation in a grandparent and a mutation in a grandchild, we know that the parent is the linker there and that they will also share that mutation. There are a number of genes associated with hereditary gastric cancer, and I've listed a number of them here just to illustrate that when we do genetic testing, we are casting a net to look at various different genes at the same time. There may also be other genes out there that are associated with hereditary gastric cancer that are not fully characterized today. We are learning so much every year that in 5 years this is going to look completely different in all likelihood. So now I just also want to illustrate that each of these genes has their own characteristic cancer risks and accompanying recommendations. The types of cancer associated with each gene vary, as well as the level of risk. Of course, many here are quite familiar with hereditary diffuse gastric cancer associated with the CDH1 gene, and I know that this has come up in other talks today as well. Of course, the stomach cancer risk is for this diffuse or signet ring type, and some estimates will suggest that risk to develop stomach cancer in these individuals is up to 80%. But as Dr. Grimm pointed out, there are some newer estimates suggesting that it may not be quite to that level of risk. There is also an increased risk for lobular breast cancer in patients with a CDH1 mutation. And that risk level is thought to be around 40 to 60% in the lifetime. Now, to provide some comparison, another hereditary syndrome that we do testing for is called juvenile polyposis syndrome, associated with the 2 genes listed on the screen here. Individuals who have this syndrome have a very different presentation. They will often develop polyps throughout the gastrointestinal system, and their level of risk for, say, a stomach cancer is perhaps not quite as high as someone with a CDH1 mutation, though certainly much higher than someone in the general population. Individuals with juvenile polyposis syndrome also have a higher risk for colon cancer, about a 50% lifetime risk. I also always like to point out that juvenile in this situation does not refer to childhood. It refers to the specific type of polyp. So this is not something that would necessarily be only present or detected in young children. So someone is found to have one of these genetic mutations after doing a genetic test. Now what do? We use that information to make recommendations for prevention, surveillance, and testing in family members. Of course, we know that the CDH1 mutations are, the recommendation there is to have a prophylactic gastrectomy, or if a cancer's already been found, a gastrectomy. In addition, women with a CDH1 mutation may consider having their breast tissue removed in a double mastectomy as a way to reduce the likelihood of developing a breast cancer over their lifetime. Early detection can, to use an example with the CDH1 mutations as well, women may opt not to have their breast tissue removed, and if not, we encourage them to do more frequent breast surveillance. For instance, having mammograms followed 6 months later by breast MRIs. That way they're being watched more closely. And we are, doing 2 different types of imaging to get a really good picture of the breast tissue over time. To use another example, for someone with juvenile polyposis syndrome, surveillance would look like having an upper endoscopy regularly, perhaps, every year or every few years. Then finally, we certainly encourage our patients to share this information with family. When someone is found to have one of these genetic mutations, we know that there's a 50% chance that their first-degree relatives share that mutation. That's their parents, their siblings, and their children. And of course, there is also risk for other more distant relatives to share this mutation as well. So I like to briefly review some common questions that I get as a genetic counselor. We are seeing direct-to-consumer testing more and more often. 23andMe is very popular. And people come in and say, I had testing through 23andMe and, everything health-related came back with a normal result. And I like to caution patients to not necessarily take that to mean that there is not any genetic predisposition to cancer or other hereditary syndromes. First, it's very likely that not all of the genes that we looked at on that previous screen are included on direct-to-consumer tests. In addition, these tests are typically not performing a full analysis of the gene that you would receive if you did genetic testing through a clinical laboratory. Often mutations are being missed or, aren't even being looked for in the first place. They also don't report what are called uncertain variants, or variants that are not fully understood at this time. And, I'm often getting updates about these types of variants for my patients and calling them down the road to, hopefully give them some reassuring information that the result is ultimately classified as negative or normal. But in those rarer cases that we find that something has been upgraded or truly is related to cancer risk, we can share that information because we know that variant is present. In addition, doing direct-to-consumer testing isn't necessarily going to have the same protections for your privacy that doing testing within a clinical or hospital system would have. And finally, there is benefit to having a healthcare provider interpret your results or help you to understand the clinical significance, not only of the result, but of that result in the context of your family and your family history. Next, a common concern is cost. That is obviously a big consideration, especially for someone who has had a cancer or is going through their treatment. Fortunately, insurance is often covering genetic testing when it's medically indicated or there is a strong personal or family history of these cancer types. In addition, the big commercial labs that are performing this test often will do benefits investigations prior to completing the testing to allow patients to have an estimate of their out-of-pocket. There are patient assistance programs available to ensure that those who are uninsured especially have access to this testing. And most labs offer this testing for a patient pay price of $250 if insurance does not cover testing for you. Next, insurance is always a big consideration as well. We are all protected against genetic discrimination by the Genetic Information Non-Discrimination Act. Specifically, this comes into play with our health insurance and our employment. Our health insurance cannot, bump up our premiums when there is a predisposition to cancer, or they can't drop us from coverage, things like that. There, however, are some limitations to protections by the Genetic Information Non-Discrimination Act. Those include companies of fewer than 15 employees, those who are active duty in the military, and certain types of plans are more autonomous, such as long-term disability, long-term care, and life insurance. Theoretically, a person who has a predisposition to cancer because of a genetic mutation could seek out life insurance, and they could be denied coverage on that basis. And so I often will encourage patients, especially individuals who are young, who are cancer-free, who are doing this testing because perhaps there's a strong family history. I encourage them to consider having a life insurance plan in place before having their test performed. Now, just a little plug for genetic counseling at the end here. Genetic counselors play a potentially important role in helping you to understand your risk for cancer. We regularly do assessments of cancer risk and assessments of how likely it is that you have a hereditary predisposition. We will recommend and order the appropriate genetic testing, taking into account your personal and family history. And we interpret and communicate those results to you. And we're also just a lifeline. If you have questions over time, or if new information comes out, we can help to, make sure that you're aware of changes in the care that you should be receiving. So our goal is to, bridge the gap between the science of genetics and what it means for your family and your individual case. And with that, I would just like to thank you for the opportunity to speak, and I'm happy to answer questions at the end.
Thank you very much, Nicolette. That was a really informative talk. We have one more talk in session 3, and then we'll have time for questions from this session. So I will introduce to you now Dr. Sean Wong, who is a medical oncologist at Duke, and he is going to speak on diagnosis and management of resectable disease. Thank you so much.
Thank you, Dr. Harmon. I'm kind of honored to be invited to be part of the fight for this challenging disease. I hope everybody enjoyed the symposium so far. I already learned a lot. So I'm a medical oncologist. I'm a gastrointestinal focused in medical oncology. So I treat GI cancer primarily in my practice. I practice in Cary as part of Duke Cancer Institute. I see basically stomach cancer on a daily basis, treat them. So I want to spend 15 minutes to share some of my as oncology, treating the patient, share some of my experience. I'll give you some updated treatment update and guideline, and I'll give you some historical background how we get here, so how much progress we have been made. So I'm going to focus on my talk today is going to be focused on a subset of cancer patient. I was asked to talk about resectable disease. So as you can see that resectable implying that some patient was diagnosed as amenable for surgical resection. So why is it important? So we know that we'll have 3 effective treatment for our cancer patient: surgical resection and radiation therapy and systemic therapy. Systemic therapy include, you've heard, chemotherapy, and also now expanded to target therapy and immunotherapy, which I will talk a little bit in my later slides. So historically, up to date, now, surgical resection is probably the only treatment we can deliver our patient a cure. So without surgical resection, the patient's cancer is considered non-curable. So that illustrates how serious this disease is. But you know that surgery is an aggressive treatment. Okay, so you have to put patient on general anesthesia most likely, and you have to remove part of the organs. You have to reconstruct their blood vessels. So also patient is subject to the infections or delayed wound healing. So not everybody is a surgical candidate. So who has resectable cancer is important to define. So clearly, if you have a poor functional status, I think Dr. Blazer will talk about it later in his talk. Functional is important. If you have liver failure, you have heart failure, you can't tolerate the surgery, you're not a candidate. But from the past decades of treating our patient, we collect the data and we come to the conclusion that even if someone with perfect functional status, no organ dysfunction, some of them are not going to benefit from surgery. Especially for those patients if the cancer has already progressed far beyond the surgical can resect. So if you only resect part of the disease, leave the other in there, so the residual disease will eventually develop metastatic disease, lead patient to die from the disease. So long-term outcome in those patients may not be altered. So if you offer them surgery, you subject them with unexpected complications. So it's very important to define those group of patients so that we offer them the best treatment. So in order to standardize the discussion in the cancer treating community, we developed this staging system for 3 purposes. One is we define who is resectable, who is not resectable in a more standard scale. We also use the staging system to give our patient some prognostic information so they know how far their disease is advanced. The third purpose is we use the standard system to compare clinical trial to clinical trial. We use the standard system to compare treatment effectiveness, so that we're comparing apple to apple. So it's a pretty complicated system, I have to say. I will discuss in the next couple of slides. Before that, quickly go back to the anatomy. So I'm not going to focus on this on the right side because we're already familiar with the structure of the stomach. I just want to point out that the structure on the left side is called gastroesophageal junction, and I think the other doctor already discussed this. I want to mention that because this cancer from this area, historically we were not very clear the behavior more like esophageal cancer or stomach cancer. So now we understand more likely the behavior is more likely esophageal cancer, and that they carry a poor prognosis compared to the cancer in the stomach body. But when we discuss the clinical trial later on, you will notice that some of the trial include this part into esophagus and some that lump them into the stomach. That will generate some discrepancy of the survival. So you can see that, we all talk about stomach cancer, but some of the median survival is pretty shorter than the other is because of population difference. I want to just be aware. This is a lymph node. I think Dr. Blazer will talk more on when he talks about the surgical resection. But I just want to put here that just to demonstrate that cancer metastasize progressing is a stepwise approach. They start to grow in the local organ, in this case is the stomach. And then they grow deeper and deeper, invade the stomach wall. Once they get deeper enough, the cancer cell will start to drop into the lymphatic circulation or blood circulation. They start to travel. They travel to, first stop is the surrounding lymph node that I put up here. We call it regional lymph node. So this is an important component from the staging system. It's a high value in the staging system to predict, like in the future, how patient will do. So pay attention. This is just regional lymph node. This is not distant lymph node, which I will show you later. The distinction is very important because if you have a distant lymph node, then the patient is categorized as metastatic disease. So this is a pretty complex table that we use in a daily practice this is a staging developed by American Joint Committee on Cancer. This is pretty much a worldwide used, adopted staging system. So you can see that there's 3 components we already talked about. T staging included in the local cancer, how deep the local cancer invade. The second component is the lymph node I just talked about. How many lymph nodes are there? Surrounding lymph node, not distant lymph node. M staging represents distant metastases, meaning that if you have a distant lymph node positive, or if you have distant organ positive, then that will go under this M staging. So with the 3 important factors, we come together with this table that it generates a 4 staging system, stage 1 to stage 4. So overall, if we come back to say who is resectable, who is not resectable, use this scale, we consider stage 1 to stage 3 disease are patients who will benefit from surgery. If you have any evidence showing there is a distant metastasis, stage 4 disease, the patient will not benefit from surgical resection, so we'll offer them other treatment. This right side of the table is from the Japanese group, but this illustrated on the left upper corner, this is the earliest stage, stage 1A. Very shallow invasion and there's no lymph node. But if you evolve into the right lower corner, you can see stage 3C is a very deep invasion locally and a multiple lymph node positive. Although this table still represents resectable disease. How do we use this complex system in our daily practice? This is an example that I just, one of my real patients I saw 6 weeks ago. Gentleman, 62-year-old, very healthy, functional and working. Developed a couple of months of stomach discomfort and early satiety or bloating. He was sent to our GI colleague, underwent EGD, endoscopy. Unfortunately, there is a stomach mass and biopsy confirmed there's a stomach cancer. So I saw the patient in my clinic about 6 weeks ago. So the way I apply the rule, we want to know the staging so that we'll determine what is the best treatment for him. So we applied the very sensitive scan called PET scan, I think you've heard of. This is scan, it will illuminate anywhere that in the body, if there's a cancer grow or actively growing tumor cells, or any cells replicating fast, it will illuminate it with a yellow color. You can see that on the left, there's a stomach wall here. There's clearly a yellow uptake indicating there's active growing. This is confirmed by biopsy. This is a active stomach cancer. But when we look at the surrounding area, we're looking at the lymph node and the liver on the left side. We didn't see anything. So we're thinking that the patient may have an early stage of disease. We're kind of happy, excited. But when you look up to the neck area, unfortunately, you see there is a dot clearly in the supraclavicular lymph node, indicated something is going on there. So this picture is a standing up picture. You see that the stomach is highlighted as dark, indicating this is a cancer, and then on the left supraclavicular area, you see that dot. This is a very red flag, a warning sign. So send the patient for a biopsy. Unfortunately, that dot is a metastatic cancer from the stomach. So this example, you look at this is a distant lymph node, is not the lymph node I was just talking about. So this patient, unfortunately, very healthy, functional, but has a stage 4 disease. With that, we won't be able to offer him a surgery. He won't benefit from that. So we'll have to offer him alternative therapy. So this illustrates the challenging that we're facing, that our cancer can escape very early, bypass some of the surrounding structure to degenerate a fatal metastatic disease. So now we understand the staging and we know who is resectable, who is not resectable. So how do patients do after surgery? Historically, it's always the question that we want to ask to see how effective surgery by itself is. And we can improve if there's a chance. So this is a survival curve that we use that every day in our practice or discussing with our colleagues. This is a chart that if someone is not familiar with this, is that on the horizontal line is represented the time we follow those patients after a procedure, usually up to 5 years. And on the vertical line, that it represents the percentage that patients still survive during the subsequent follow-up period. So this study is a community study, actually collected 10,000 patients diagnosed with stomach cancer from 1991 to 2000, underwent surgery, and they plot with this curve. So stratified by the staging that we just talked about. Stage 1A is the earliest, stage 4 is the latest. So if we look at this chart, it's a complicated chart, but let's focus on the stage 3C disease, this orange line. And we still consider stage 3C as resectable, but after surgery, how do they do? By the end of 5 years, here, look at here. Stage 3C, 5 years, only 9% of patients still survive. So 90% of patients died from this disease by the time of 5 years. Most likely died from the cancer. And the other factor we're always talking about is something called median survival. It's the one by the time 50% of patients died from the disease after procedure, how long it would take. So again, for this group of stage 3C, resectable, resected, only take 1 year for 50% of patients pass away. So this is a terrible survival curve. I think Dr. Eplin alluded 30% of general survival. But if you have an advanced stage, you probably have only 10% of chance survival at 5 years. So all effort have been made for the past decades or so to try to improve this curve, to lift this curve up so that we can offer our patient better outcome. So in addition to our scientists working in the labs to identify breakthrough treatment, and in the community, the clinical community, cancer community, trying to use combination therapy to see if by adding other available therapy together to improve the surgical outcome. I'm going to present a couple of landmark clinical trials that during the past 2-3 decades that it showed that combination therapy is effective and we improve patient outcome. This is the first study that conducted by the US group, published in 2001, New England Journal of Medicine. This is a US intergroup trial. So what they want to do at that time is, because the surgery by itself may not deliver the optimal outcome, so how about we combine some other treatment? So they randomized the patient into 2 groups. One is surgery alone, the other group is after surgery, the patient received chemotherapy and radiation. So when they compare to the surgery alone, you can see the survival curve. We already have some familiar with it. Surgery alone group is the bottom line, and a combination group is the top line. So clearly lift the survival curve up, indicating that patient live longer, and 5 years, more patient will survive. So the reported median survival, again, 50% of patients died, has improved from 27 to 36 months. And a 3-year survival improved from 41% to 50%. It's a good start. So it's proven that the concept or strategy in using combination is effective, although is not the perfect survival line yet. How about our European colleague? Our European colleague at the same time developed their own protocols. They only use chemotherapy and plus the surgery. So they gave the patient, they randomized the patient in the same fashion. One group only surgery. The other group gave them a sandwich type of chemotherapy. They gave part of chemotherapy before surgery, and then send them to surgery. And then after surgery, they gave them more chemotherapy. So again, this is the survival curve that they were able to successfully lift up again, and indicating that combination chemotherapy and surgery without radiation will be able to provide better outcome to our patient. Still pretty bad curve, but there's some improvement. So the median survival improved from 20 months to 27 months, and 5 years survival from 23% to 36%. Our European colleague take one step further. They published this study in 2019 in Lancet. So they modified their chemotherapy regimen by switching one drug. When they compare this new trial called FLOT trial, when they compare to the MAGIC trial I just presented, the new combination actually further worked better. So you can see this survival curve, again, has been lifted up from the blue curve with the MAGIC trial that we just used, and it lifted up the red curve that is the FLOT trial. It was just, the difference is just a different chemotherapy component. So the median survival has been further improved from 35 months to 50 months, and the 3-year survival they reported from 48% to 57%. Again, one step ahead. So this is the defining trial that defined current treatment for anybody with resectable stomach cancer. We offer them the FLOT regimen, and then give surgery and offer the HAF treatment, as long as the patient is in good health to receive that. So what are we doing now? So by now, I think everybody in the audience probably already heard the revolutionized immunotherapy. It's a breakthrough therapy available for us about maybe 5 to 10 years. This is a very different therapy. They activate a patient's own immune system and then let them to find the cancer and start to fight with the cancer, kill the cancer. They had the immunotherapy achieved huge success initially in melanoma. I think our President Jimmy Carter received that treatment. As far as I know, he's still alive in age 97. And the other cancer type, including lung cancer, also achieved huge success with this. And then certainly gastrointestinal community also wonder if this will work in the GI cancer. So I think in the resectable disease group, the first reported success is last year in New England Journal of Medicine. So this is a group actually treated for esophageal cancer and GE junction cancer that I mentioned in my anatomy slides. This enrolled those population, but by adding immunotherapy to the standard of care, you can see that the survival curve lift up further. It's quite significant improvement. The median survival was 11 months before, without immunotherapy, now improved double to 22.4 months. So quite exciting a setting that we know that in the concept, the immunotherapy is working on the GI cancers. So how about the stomach cancer? There's still ongoing research that actively recruiting patients. There's 2 phase 3 trials recruiting patients for stomach and GE junction cancer. And I think they will release the data maybe in a year or 2 years. We're eagerly waiting for them to release. Hopefully we will see the same magnitude of improvement for the esophageal cancer. Future direction, I think in my personal opinion, that at the parallel we develop the immunotherapy, the cancer treatment enter an era called personalized medicine and a precision medicine, largely thanks for the gene sequencing technology. So this is a paper published 2014 in Nature. By applying the gene sequencing technology for cancer patients, the cancer look-alike cancer now are divided into 4 subgroups based on the distinct gene mutation pattern. So I think we already know this diffuse type is featured as CDH1 mutation, characteristic. Okay, so the other type, the intestinal type, features the TP53 mutation or RAS mutation. So all these 4 groups features individual mutation patterns. What we're doing right now is trying to develop what we call a target therapy, hopefully to target individual genes so that they reduce the growth signal, and then the cancer cell will start to slow down and they will die. So this strategy has already been applied for lung cancer fairly successfully. For the stomach cancer, we're a little bit slow, but we're getting there. So this is a pie chart I borrowed from Dr. Weinberg from UCLA, just to illustrate that this pie chart is whole stomach cancer. And you can see that There's different gene mutation, 5% of FGFR, 5% on MET, and we're developing individual target to those mutations. Hopefully that someday we'll effectively develop the target therapy. We'll come back to apply those target therapy in combination of our we already have to further improve the patient outcome. So hopefully someday we'll deliver a survival curve is a perfect flat line indicating nobody will die from the disease. So I'm so excited to be here and to be joining the fight for stomach cancer. And my father died from stomach cancer when I was in college. That's why I'm here. So I'm hoping that someday we can present a better outcome to share with you. I thank you for your attention.
Thank you so much, Dr. Wang. Thank you to all of our speakers on session 2. I realize we've gone a little bit into our break time. If you need to get something to drink or a snack or get up and move around, that is fine. I think we will try to take a few questions. So the floor is open if anyone has questions for any of our 3 speakers from session 2. If you can wait just a sec, we'll give you a mic so everyone who's tuning in from home can also hear you.
Thank you. Hi, my name is Kylan Riley Knapp. I'm on the board of No Stomach for Cancer, and I'm CDH1 positive and have had a total gastrectomy. And I'm curious to know what theories you have, if any, about what triggers the growth of the signet cells. Why do they go from stage 1A and stagnant to later stages?
So any of our panelists want to take a question on the biology of CDH1 stomach cancer? I've got a mic here if any of you. Anyone want to chime in?
Well, my understanding of CDH1 is the gene as encoded a protein called E-cadherin. E-cadherin is a marker on the surface that basically link 2 cells together. If you have a deficiency of that, the cells are loose. They are not attached to each other very tightly. So that also the surface antigen of the E-cadherin will activate the growth signal. So that's what the mechanism from the diffuse type of genes. That's also applied for the breast cancer as well. If you have deficiency of that, that's basically is just the cell are not functioning well. So they are highly, other mutations lead to the cancer. So the CDH gene, if you have deficiency, the cancer travel easily because they are not attaching to each other. The cells are not attaching each other as a normal way. That's my understanding.
I can just build upon that and say it's a great question, and I think one that many of us wish we had better answers to right now. I think one of the things that we know is there's a lot that we still don't know, and particularly in those early stages and how you go from an inherited mutation or an exposure to get to cancer. It's complex, and there's just a lot of difference in the pathways that people take. And so I think it's an area that many of us are trying to learn more about, but we don't have perfect answers to that question yet, but it's what inspires a lot of us to do the work that we do. So we'll keep trying to understand it better. Anybody else want to expand on that? And then I think there was a question in the middle. Dr. Grimm, were you going to say something?
This gentleman had a question.
Yeah.
Hi there, thank you. My son and I lost our matriarch, it's probably the best word, back in February, and I'm still really processing what that whole journey was. And it's just for my own reasons. Can stress cause cancer in this way? She had a very stressful job, and I've always wondered about that. And I haven't heard anything from the medical community about that, and especially today. So I'd love for you to debunk that, and if that's the case. And the second is, my wife was also, we found out she had retroperitoneal fibrosis during the surgery while she was on the table, and the complications with that. I'm wondering if that's common, and the thinking at the local hospital where they're 2 independently problematic issues, but the swelling of the stomach with retroperitoneal fibrosis and what all that is just led to a very speedy ending.
Of course. Thank you for the question. I'm going to let the panelists take a minute. Let me know if any of you want to respond to that question. I just will say a huge thank you to all of the family members, caregivers, and patients who are here and sharing their stories. I know it's really personal for all of you, and it's really impactful for all of us to hear what you have been through. So we're glad you're here. I think there were a couple questions in there. One was about experience of stress and cancer, which I can tell you Dr. Epline and I are both looking at as part of the stomach cancer study that Dr. Paterno mentioned. So we can maybe talk more about that. You're right, it didn't feature in the slides because there hasn't been a lot definitive in the literature, but it's a great question and something that we're actively looking into. We have a survey that tries to get at experience of life stress to try to answer some of those questions. If any of the panelists want to jump in, that is fine. There's another very personal question in there about retroperitoneal fibrosis and surgical complications that may have contributed to outcomes. I know Dr. Blazer is sitting behind you and is going to talk to us later about surgery. This is something that's a little beyond my own personal expertise. I don't know if anyone on the panel wants to comment on that. It sounds like Dr. Blazer is going to jump in here, which thank you.
I can just briefly say that generally that disease condition is considered to be sort of a separate issue from gastric cancer. I'm not aware of any links between the two conditions. Retroperitoneal fibrosis is a very tricky, complicated disease. It's probably outside the scope of this symposium today, but we think about it obstructing the urinary system, and it's a disease of the retroperitoneum, which the stomach does not sit in that part of the body. So could it complicate the conduct of the operation? Absolutely, and I could certainly talk about that with you offline, but I think in general we don't think about those two conditions together, except for obviously in this particular case may have been.
Yeah, thank you to Dr. Blazer for the answer. And again, I think this is very personal for many of you here, and we all appreciate that. And your stories and experiences are important, and we learn a lot from all of you. Any other questions? Yeah. Oh, sure. Here you go.
Well, this is the million-dollar genetics question. So there's like thousands of CDH1 mutations, right? Do you get these in your report, and can you, grade different mutations in terms of their risk?
To some degree, we do full sequencing and deletion duplication analysis of these genes, so we are getting a very comprehensive look at them, and there are some genotype phenotype what's the word I'm looking for? Associations. So sometimes we can provide a little bit more information about how a particular mutation has presented in a group of people, but I would say that's not always the case that we can provide that detail.
It's not helpful for people who are considering a gastrectomy to say you were in a lower risk or higher risk based on your genotype?
I think that may become a way that we can have that conversation more individually. I know, so many studies are happening now in populations that were not initially, recruited because of a gastric cancer risk, but maybe are recruited from a breast cancer point of view. So, I think maybe we're heading that way.
So interesting debate on the stage about the evolving genetics of CDH1 mutations and different mutations, the role they play in the manifestations of disease, what we do about it, which is, I think, an evolving space. There is one more question I saw. Yeah, go ahead.
Hey, good morning. My name's Sue Catherine from Greensboro, North Carolina. My late husband was fortunate enough to be a patient here at Duke and also at MD Anderson in Texas. I just have two quick questions. And one of them was, do you all think that there will be an upper endoscope that'll ever be part of regular medical screening, just like a regular colonoscopy is? That's one question. And then my second one was, we're hearing a lot, especially being from North Carolina, a lot about the Camp Lejeune toxic water situations. My husband was a U.S. Marine, and he was stationed at Camp Lejeune during those years in question. I just wanted to find out from y'all, because I'm like this gentleman here, we're in just disbelief when you're diagnosed, and you always want to find out how or why did it happen to that loved one. So I'm just wondering if you all happen to have any studies that are showing evidence of all of that with Camp Lejeune and the toxic water situation.
Great. Thank you for your questions. So 2 questions. I'm going to let Dr. Grimm answer the first one, which is about the role of screening with upper endoscopy and how we're headed in terms of that question. And then we'll circle back to your second question.
Yeah, I haven't heard of any calls for routine upper endoscopy to screen for stomach cancer in the U.S. because it's so rare. So the idea, like in my talk, is to try to identify high-risk populations. Your question could also be targeted at esophageal cancer, and people are more interested in non-endoscopic ways of screening the esophagus. So you could, for instance, swallow a little sponge on a string and pull that string out and look at the sponge for tumor cells. So non-invasive screening, I think, has got a lot more interest than doing upper endoscopy on everyone. It's not so invasive to do. As if you're having a colonoscopy, you can do an upper endoscopy in 5 minutes, but it's not recommended on a population basis.
Great. Thank you for that answer, Dr. Grimm. So if any of the panelists want to tackle the question about Camp Lejeune, raise your hand. Otherwise, I can talk a little bit. And for folks who have traveled from outside North Carolina to be here today, North Carolina is a state where there's been increasing attention to environmental exposures, and particularly water-based exposures, and the association that that may have with a number of cancers. And this is something that I think is finally getting more attention. I can tell you that in the program that Mira Epline and I lead here in cancer risk detection and interception, we have on our steering committee an environmental scientist who is actually giving a talk this week on PFAS and drinking water contamination and association with cancer and other health conditions as well. So we're really encouraged that there are some folks here who are very interested in learning more about that and trying to get at the why. If anyone else on the panel or in the room wants to weigh in on that, it's an important question, and we totally recognize that need to try to understand what happened to your family member. So we recognize that. Thank you to all of our speakers for a really interesting session 2. Thank you to all of you for your questions. We will go to a break and then resume with session 3. Thank you all.
Since we're running a little behind, if you guys don't mind making it a short break and coming back in about 5 minutes, thank you so much. just saying, like, you know, the really simple introduction.
I know these guys, and that's all I can probably thank you.
How many people online?
I know at least 33 people registered. It's open and it's not bi-directional, it's unidirectional. Apparently that's what Booth does their live streams, but it will be then saved.
Okay.
They can ask us questions.
Oh, okay. Okay. Sounds good.
Yes, this is called Sword Energy. Yes, and I think I left it up here.
Oh, that's perfect, okay.
And then I can use that.
Okay. Do you want me to just say we're gonna get started? Okay, you do that.
Okay, we are going to start with the next session, if people would like to take their seats. We let it run a little bit late just because there's so much good information. You guys had great questions. We really appreciate that. And I promise we will get done by noon for lunch, so we won't delay eating. Okay, thank you very much.
Hello, everybody. My name is Hope Uronis. I am a GI medical oncologist here at Duke, like Dr. Wong. So I'll be moderating this session. I have two of my esteemed colleagues, Dr. Trey Blazer, who's one of our surgical oncologists, and then Dr. Brian Cito, who's one of our radiation oncologists. And we're going to go through radiation treatment, surgical treatment, and then my talk will be on clinical trials, and then I'm also going to talk about treatment of metastatic disease. So I'm sort of combining those two. All right, Dr. Cito.
Right. Thank you, Dr. Uronis, and thank you everybody for attending today. This is not a really easy talk to give because the role of radiation is somewhat ill-defined. And for those of you who don't know what radiation therapy is or don't have any experience with it, it's the way I describe it to patients is it's really nothing more than an X-ray type treatment, except the X-rays that we use to treat cancer, which are pretty good at killing cancer, also have potential side effects that go along with it. So they're much more powerful than, say, a chest X-ray or a CAT scan. But first, as an introduction, you probably have already seen slides similar to this today. This slide is a few years old, but gastric cancer worldwide is a major public health problem. And when you look at the incidence of gastric cancer, it's really much more predominant in Asia, some parts of the Middle East, as well as parts of South America. So in the United States, we're relatively spared, all things considered, when you look at the rest of the world. And similarly, mortality rates that go along with gastric cancer are also quite high in these regions as well. When you look back in the United States, if you go back a century, it wasn't always that way. In fact, around the 1930s, gastric cancer used to be one of, if not the top killers in the United States, although the incidence has steadily declined since that time. However, worldwide today, it's still the #2 killer, at least as a few years ago, it was the #2 killer. And environmental factors likely play at least some, if not a strong role in the development of this malignancy. I don't want to go over this too much because you probably have already heard some of this today, but there are certain risk factors for gastric cancer. You've heard about H. pylori already. Smoking's never a good thing in any type of cancer. There are probably dietary factors as well. Even a history of childhood radiation probably predisposes you to developing gastric cancer, as does a family history. In the U.S., at least as of several years ago, there's roughly 23,000 cases a year. This pales in comparison to other malignancies we see, such as lung cancer, breast cancer, prostate cancer, but still not a trivial number of cancers. As I've indicated already, we're seeing less in the way of true gastric cancers compared to what we used to see. And also what we're seeing less of is we're seeing really less in the way of more distal gastric cancers. So we've seen a decline of those, and we're actually seeing much more in the way of proximal gastric cancers, more near where the esophagus and the stomach come together. As I indicated before, worldwide, there's probably at least 1 million cases of gastric cancer every year. Most people are going to die of that disease. It's so predominant in Asia that they do have screening programs, unlike the United States, and they simply put, they catch disease at earlier stages, and therefore they have better outcomes in this cancer compared to the United States, where most of the patients we're going to see present with more advanced malignancies. Lymph nodes or lymphatics are everywhere in the body. If you've ever had swollen glands in your neck when you're sick, those are lymph nodes. They're literally all over the body, and including around the stomach. Gastric cancer likes to go to lymph nodes. In fact, when you look at some trials that have been run, in the United States, most patients with gastric cancer are going to have lymph node involvement. There are varying degrees of removal of these lymph nodes surgically, which Dr. Blazer will probably touch upon briefly, and I'll talk a little bit more about. And the spread of gastric cancer outside the stomach is somewhat predictable, but not entirely predictable. So there are many avenues that gastric cancer has to spread outside the stomach. As you also heard from Dr. Wong's talk, that surgery alone is probably not enough in most gastric cancer cases. We need additional treatments to help reduce the likelihood of recurrence in these patients. And this is an interesting paper that in my field is kind of a classic paper that now goes back 40 years. And actually the patients who were treated on this study were actually treated well beyond 40 years ago. It's from actually a surgeon at the University of Minnesota who took gastric cancer patients and realized that even though he was operating on them, most of them were recurring, and so he wanted to try to figure out how these patients were recurring, what was going on. And so he would take their tumor out initially, and then between 6 and 12 months, he would go back and he would take another look surgically to see where these recurrences were. And what he found was several interesting things. Number one, about 80% of patients recurred. It's not because it was bad surgery, it's just because you can't see all the disease when you're doing the surgery. And what the investigators on his team discovered was that roughly half or maybe even more developed local recurrence or local regional recurrence. And that means they grew back right where the tumor was or in the soft tissues or the lymph nodes that were adjacent to the tumor or near the backbone. And they actually came up with these diagrams, and all these little dots you see here in this paper showed that regional or local regional recurrence around the stomach was very common in these patients. So that actually gave rise to the thought, well, could we give radiation therapy to that area and potentially eradicate any microscopic disease that's causing these recurrences? Another thought process around this was, well, can we just do a better job of removing the lymph nodes? And this is a complicated diagram, but basically what it shows is the primary lymph nodes, which are right around the stomach itself, are in green here. And then there's the next level, or I guess highway that the tumor likes to go to, or what we call the D2 nodes, or I'm sorry, the red are the D1, or the ones right around the stomach, and the D2 are the green, which is the next highway or so that so to speak, that the lymph nodes tend to travel to. And so these are the lymph nodes that are standardly removed now in gastric cancer surgery to try to prevent this from happening. However, even with this more, I don't want to say radical, but more extensive lymph node removal, what you can see at the bottom left here is that local recurrences still occur with surgery. And in fact, when you look at this large experience out of Europe with good quality surgery, what you can see is, what I call LRF, or local regional failure in the bottom, is still happening even with more extensive surgery in about half of patients. So it's still a major problem to overcome. So when you look at this, what you can see is that local recurrences are common in gastric cancer. Extended surgery probably helps some, but is not a panacea for this. Relapse in these areas is common, and removal of all disease surgically can be very difficult. And in fact, when you look at experiences from this country, including for excellent cancer institutions like Memorial Sloan Kettering, what you can see is that when they have recurrences, about half or so are happening local regionally. So these principles gave rise to the strategies of what can we do to prevent this from happening? How do we prevent these recurrences? And there's a lot of different ways you can think about this. The first is you can do surgery and then give some kind of therapy afterwards. We call that adjuvant, and that can be chemotherapy or radiation therapy, potentially immunotherapy at some point as well. You can give treatments before an operation, and there are potential advantages to doing these, giving treatments before an operation, which I'll go into momentarily. And these can be chemotherapy or chemoradiation. So as Dr. Wong pointed out earlier, one of the first trials, really large trials looking at this, was a so-called intergroup trial, which is now largely, I don't want to say it's a historical trial because it still applies today, but a fairly large trial in the United States, which they took over 500 patients with stomach cancer, and they removed them, and then they randomized those patients to either just watch them and see what happens, or to deliver adjuvant or postoperative radiation with chemotherapy. We often combine chemotherapy and radiation at the same time. As I tell my patients, not because I love chemotherapy, but simply put, it makes the radiation work better than it does by itself. So that was the randomization, so half and half. I'll spare you that. And as this curve you already saw, what you can see is that the patients, even though it might not seem like a big number to everybody in this audience, this was actually a big number in the world of oncology. It improved the 5-year survival by almost 10%, which is really big. And so that really established the adjuvant or postoperative chemoradiation as a standard, if not the standard of care for most resected gastric cancers at that time. In Asia, one of the criticisms, not only in Asia but in this country, was, well, the surgeons in the United States didn't do as good a job. They didn't do a more extensive lymph node dissection, and that probably just, the radiation is just making up for that. And so in Asia, they also had an interest in looking at the role of adjuvant radiation therapy as well as chemotherapy. And so these investigators in Korea took nearly 500 patients with a good lymph node dissection, surgical removal of the lymph nodes and the tumor, and randomized them to either chemotherapy alone or chemotherapy plus chemoradiation. And not to bore you with these curves again, what you can see is there did seem to be what we call a disease-free survival benefit, essentially meaning you're less likely to have recurrence of disease if you had node-positive gastric cancer and received the adjuvant chemoradiation along with the chemotherapy. However, this included all patients, including node-positive and node-negative patients. And so they ran another trial called the ARTIST-2, looking to see, well, is radiation really benefiting these node-positive patients, or is it really all in the chemotherapy after an operation? So in this trial, they took 900 patients and randomized them to 1 chemotherapy drug, 2 chemotherapy drugs, or 2 chemotherapy drugs plus chemoradiation following removal of the tumor. And what they found is clearly the addition of both chemotherapy drugs was better than one in terms of improving outcomes. However, the radiation, unlike the first trial from the United States that I showed you, did not appear to benefit these patients. So it really started tempering the enthusiasm for giving radiation after an operation. Similarly, in the Netherlands, they ran another trial called the CRITICS trial, somewhat similar to the trial I just told you about, except that instead of giving everything after an operation, they actually gave preoperative chemotherapy, which you'll have already heard and know now that is probably the preference in stomach cancer patients. But then patients would undergo removal, and then they were randomized to further chemotherapy alone or postoperative radiation therapy with chemotherapy. Criticisms of this trial are that only 75% of the radiation patients even started treatment after an operation, and even fewer completed it, which shows you that it's hard to give treatment after an operation due to a variety of reasons. And what they found, however, is that there is no obvious benefit of radiation therapy in these patients. So again, unlike what was initially reported in this intergroup trial I started off with, these trials did not support the role of radiation therapy. So that brings us up, it brings us into a more modern era where we really are more focused on preoperative therapy in these patients. And the rationale behind preoperative therapy is multifold, including that it increases the likelihood of tumor resection, meaning removal of the tumor completely. And you certainly, in most cases or many cases, you get shrinkage of the tumor. It allows you to eradicate microscopic disease, which we know is a source of recurrence in these patients. You can tell what the tumor intact, if it's sensitive to the effects of these additional treatments or not. It minimizes delays. Dr. Uronis can start chemotherapy very quickly in these patients. And again, postoperative treatment is often hard to give. Patients have complications. They don't bounce back as quickly. They can have wound healing complications. They can get infections, things like this. So it may be a preferred way to give these additional or adjuvant or neoadjuvant treatments in these patients. Can you give radiation and chemotherapy before an operation? You can. This is a small trial that shows that that showed that it was very feasible. And in fact, when they removed the tumors, about 1 in 4 had no evidence of cancer, suggesting that it is an active regimen. So that's, again, low-level data suggesting that. There's another trial from China looking at pre-op radiation. It's an older trial now in which they gave radiation therapy alone compared to surgery, and what they found was that the radiation therapy patients, again, live longer than those patients who did not receive radiation therapy. However, things were kind of upended from a radiation, not really upended, but from a radiation standpoint with the publication of this trial, which you heard earlier, this so-called FLOT regimen, which arguably now is the standard of care for gastric cancer patients. In this trial, they took patients who had gastric or gastroesophageal junction cancers and randomized and received this so-called FLOT chemotherapy regimen before and after surgery, as well as this older, more historical ECF regimen. And what they found was that, again, the winner in this trial was this red curve, the FLOT curve, which again gave us numbers, survival numbers that were much better than we've seen historically. And so as of now, as Dr. Wong pointed out, and as Dr. Uronis may allude to, this is the standard of care in most stomach cancer patients. So the question is, well, what's the role of radiation therapy now? Well, there might not be any. That's certainly possible. However, when you look at national guidelines, and a lot of us look at these so-called NCCN guidelines, which is made up of gastric cancer experts from multiple fields, and what you can see here when you follow this flow diagram is that patients who have even moderately invasive gastric cancer, the general recommendation in these patients is to give perioperative chemotherapy. So category 1 means there's really good data supporting it, and really the panel members all agree this is probably the preferred way. But even on this, which I looked at this month, they still have preoperative chemoradiation as a possible option, although 2B means there's some data supporting it, there's some disagreement about whether it's appropriate in these patients, but most of the panel thinks that it is. In patients who have more advanced gastric cancer, meaning they're medically fit, but Dr. Blazer has concerns about removal of the entirety of the tumor, you can see chemoradiation certainly is an option in these patients to downstage or to shrink the tumor. When you look at patients who, for whatever reason, go straight to an operation instead of preoperative chemotherapy, chemoradiation is still in the mix if they have any semblance of invasion or lymph node involvement. And that's primarily, again, based on the intergroup trial that I presented to you. And if there's some question when we call R1 or R2 resection, meaning there's concerns about having residual disease left behind, certainly chemoradiation is indicated in those patients as well. And similarly, even in patients who have undergone preoperative chemotherapy, who undergo resection, if there's concerns about residual disease, we often will recommend adjuvant or postoperative radiation therapy as well, which fortunately we don't see that many patients like that, but we still certainly do see some. Future of radiation therapy, there's a couple of ongoing trials which will either support or kill the role of radiation therapy in this disease. The first is another Dutch trial that's ongoing looking at preoperative therapy, which again is probably preferred, preoperative chemotherapy, preoperative chemotherapy plus chemoradiation, or pre-op chemoradiation alone. Another trial, which is now complete, which hopefully we'll have the results of in the next 1 to 2 years, is so-called Top Gear trial out of Australia. And this trial also looking at perioperative or before and after surgery chemotherapy versus perioperative chemotherapy plus the addition of preoperative chemoradiation therapy. So, conclusions. Stomach cancer worldwide is a major problem from a morbidity and mortality standpoint. Fortunately, in the United States, the incidence is declining over time, especially for more distal or lower stomach cancers. Outcomes are clearly improving. Lymph node and soft tissue spread in the area of the tumor is very common, and despite more extensive surgeries, local recurrence can be a problem. Radiation improves local failure rates. Question of long-term survival, still a little bit ill-defined. There are advantages to preoperative therapy, and the role of preoperative radiation therapy is potentially promising and should be clarified by upcoming trial outcomes. Thank you.
Morning, everybody. Thanks again for the opportunity to present. I always learn quite a bit myself at these sorts of conferences and symposia. I had never heard of the sponge on a string that Dr. Grimm mentioned, and it actually reminds me of a very important medical history story in the United States, the story of William Beaumont and Alexis St. Martin. That has nothing to do with what I'm going to talk about today, but you should Google it. It's very interesting, and I was reminded of that story. How do I advance? Just click. Okay. So my job today is to tell you just a little bit about surgery. I think what is very clear for the majority of patients with gastric cancer is that surgery alone is not sufficient. In fact, my last slide is exactly that. And so I hope if there's any theme today, I think that's absolutely the case. I'm not going to focus on that because we're getting several talks in that region. So I am going to focus on the role of surgery and kind of all things anatomic, because surgeons love anatomy. It's also nice to see that we all steal from the same websites, because I've seen these pictures before today. So hopefully we're not violating anything. But just as a reminder, the stomach sits kind of in this part of your body, in the upper abdomen. And it sort of anatomically, we refer to various parts of the stomach as the cardia, the fundus, the body, the antrum, and the pylori. So you may have heard your surgeon talk about that, and it actually is really important, and especially to surgeons in one part because it very much determines the type of operation that we may be talking to you about. It may have a significant impact on your long-term function and quality of life, and so it's really important. The other thing that's been alluded to today is some of the things around not just the anatomy of the stomach itself, but the blood supply. If any of you were previous medical students, I promise you will get asked about the blood supply to the stomach, because we talk about 5 different blood vessels that supply the stomach, and it's a great question to ask them as they're shaking in the operating room. But it also speaks to how robust the stomach can be. We can do lots of stuff to the stomach and it will do okay, because it doesn't tend to get ischemic, and so it actually plays into a lot of the ways that we manage various different conditions of the stomach. We've also talked about the lymph nodes, several of the speakers already today, and the lymph nodes are really important when we're thinking about how to treat stomach cancer, and so it actually is a really big component of getting the right kind of surgery and being treated by a surgeon that kind of has some knowledge of that. The other is the nerves that feed the stomach and kind of propel stuff through. That actually is a very big historical importance prior to the evolution of a lot of the drugs that we use to treat ulcer conditions and things like that, because you would have these operations where we would manage the nerves in various ways. And so there's a lot of historical importance to this stuff. So what does the stomach actually do? Some of you, even in this audience, have told us that you don't have a stomach. And so how in the world are our patients surviving without a stomach, or only having part of their stomach? I mean, it's a major abdominal organ, right? So what does the stomach do? Well, I think this is a surgical textbook, which is what I tend to go to for lots of kind of broad overviews. And you can see here that the stomach really prepares ingested food for digestion and absorption. I think one of the critical words in this quote I stole is prepare. It doesn't mean that you can't live without it, but it does have a function in kind of getting things ready. It has a role of storage, and it does have some role in digestion. And in fact, there's a bunch of different kinds of cells in the stomach. I hope you can read it a little bit, and some of those cells are located in various parts of your stomach. So if you have part of your stomach taken, you may have some impact in some of these hormones and substances that are secreted by the stomach. So it's actually pretty remarkable that we can take all or part of your stomach and you can kind of get along okay. And so there are a lot smarter people than me that could tell you more about this, but I do think it's important to understand all these various functions of the stomach. One of the things, again, that I alluded to is digestion. You cannot watch a football game without getting an advertisement about various pharmacologic interventions. All of us have probably at one time or another taken something like a proton pump inhibitor or an H2 blocker, which completely revolutionized the way that we manage diseases of the stomach. And so this is really, it's a big deal. It's a big deal in pharmacy, and it's a big deal in terms of how we manage patients on a day-to-day basis. You can also see all kinds of like miracle drugs that are going to come by. There was a few years there where we talked a lot about ghrelin, which is this substance called the hunger hormone, and nobody was going to ever be obese again, because if we just found a way to target ghrelin, then we would eradicate that problem. It's obviously not quite that simple, but there's also, your stomach has a role. Somebody spoke earlier this morning about anemia, but you can, if you take the whole stomach, as many of you know, you do have to get injections for B12 and things like that because of one of those functions of your stomach. So your stomach is important, but as I said, it can tolerate a lot. We actually operate on the stomach quite a bit, okay? And so bariatric surgery is probably at the top of the charts in terms of these days what we operate on the stomach before. And I think it's important to put it in context, because what we're talking about today is not all that common compared to a lot of these other operations. Bariatric surgery, you hear about sleeves and Roux-en-Y gastric bypasses and all those kind of things. Those are performed, this may even be a little bit outdated, but performed at least 252,000 operations a year. That's a ton of operations that patients undergo for anti-obesity surgery. We talk a lot about anti-reflux surgery. Again, that it was hard to find numbers. I searched, and the best I found was about 20 to 30,000 operations per year. Again, that's actually more common than stomach cancer operations. Ulcer surgery, which is a hugely important historically to general surgeons, because it used to be one of the most common reasons we would operate in the middle of the night, because somebody would perforate an ulcer, or they'd have a bleeding ulcer or something like that. And again, the evolution of H2 blockers and PPIs and things like that really rendered us pretty ignorant about how to manage it. Now, most of my residents will never operate on a patient for a problematic ulcer. So those drugs really revolutionize what we see as general surgeons. And again, you can see some of the crazy stuff that we can do to the stomach. You see on the far left here with bariatric surgery, we're putting bands on people. We are rerouting your plumbing. We're taking parts of your stomach, doing sleeves and all that kind of stuff. Anti-reflux surgery, we actually mobilize part of the stomach and wrap it around your esophagus. And then classically, a lot of different kinds of ulcer operations that we would do. So a lot of the principles that underpin what we do for gastric cancer surgery really come from lessons that we've learned from ulcer surgery and other kinds of operations. So again, all of these operations actually still happen more, even anti-ulcer surgery probably happens more frequently now in this day and age than stomach cancer surgery. So as folks have alluded to before, somewhere between 25 and 27,000 cases in the United States per year. But as if we've also talked about quite a bit, is that we detect in the United States a lot of folks late, and they're not even candidates for surgery. So if you're trying to estimate the number of operations that we do per year for resectable stomach cancer, it's probably somewhere on the order of less than half of this number that you see here, if you're kind of doing a back of the table calculation. You've also seen various pictures like this today. It seems I stole a unique one, but this is really important for surgeons, okay? And so when we talk about the stomach, I think Dr. Grimm put one of those up too, but it's important when we talk, when we have somebody that's diagnosed with stomach cancer, I really want to know exactly where that cancer is, okay? And we talk a lot, and you'll hear potentially your surgeon talk about the Siewert classification. And why is that important? Well, actually super important, because we basically, anything that's in that GE junction, we've called it before, like in the cardia region, it's actually even a little bit more than just the cardia, but any kind of cancers that are between sort of a centimeter above that transition between your esophagus and your stomach, or 2 centimeters distal, are actually treated with a very different operation, and it's called an esophagectomy, and some of you may have had that operation, but that is a very different operation than the various gastric cancer kind of operations I'm going to talk about today. So when we talk about kind of the classic gastric cancer that gets some sort of gastrectomy, we're really talking about cancers that arise 2 centimeters beyond that junction between your stomach and esophagus. And everything proximal to that really goes into that esophagectomy. And you can see from a lot of the trials that have been talked about, there's a lot of overlap. Dr. Zita was talking about some of these trials in addition to Dr. Wong, and you'll get that overlap. And in fact, when we have things in that region, we still sometimes deploy radiation still pretty frequently in that region, whereas more distal gastric cancers, radiation is at least currently has gone down in frequency in terms of our recommendations. So that location is critically important when we're thinking about it. Dr. Grimm talked a little bit about how we work folks up. Again, for me, an endoscopy is obviously critical because we get the diagnosis. We know they actually have a stomach cancer, but we also have other kinds of diagnostic tools like endoscopic ultrasound, which is also can be really important, kind of understanding where exactly this tumor arose from. And again, it really matters because you want to get the right surgery, right? If you're right at that borderline, then you really may benefit more from an esophagectomy than a gastrectomy. And I've seen a number of people who have sort of been localized not in the best way, and then they get their whole stomach gets taken out and they have a positive margin proximally because really what they probably should have had is an esophagectomy. So really important. It's also really important why we need to think about other treatments before surgery like chemotherapy and radiation, because you may also reduce the risk of having a positive margin. So in the most basic way, as a surgeon, when I'm thinking about the surgery that's going to be appropriate for a patient, these are the things that I think about: the margin, the lymph nodes, and then a lot of you will ask me, and appropriately so, what the role of minimally invasive approaches are. You hear about robot technique, you hear about laparoscopic technique. I'll make a little comment about that, but let's talk about those three things in terms of the surgery that you're going to get. So there's really only three operations in my mind for gastric cancer, and it is a distal, what we call a distal gastrectomy, a subtotal gastrectomy, and a total gastrectomy. And the way that we make the decision about those three very basic operations are, where is that tumor? And as I said before, it's really important. So I am utterly reliant on the endoscopist. And I ask them to tell me exactly where that tumor is. The medical oncologist and I will talk about it. I'll talk about it with Dr. Zito because, again, it can really dramatically affect the recommendations that we make. So your endoscopist is super important in terms of thinking, because you want to give the patient the best chance of a margin negative resection, all right? And so what is that margin supposed to be? Okay, there's a bunch of words here. It's hard to see, I know. But Dr. Zito alluded to the NCCN guidelines that we follow. Those are really universal, or not universal, nationally accepted kind of standard of care guidelines that oncology folks follow. Europe has its own set of guidelines that are called the ESMO guidelines. I think the national meeting or international meeting was just recently. But if you look at those guidelines, the NCCN used to say you need somewhere between a 4 and 6 centimeter margin. They actually don't even say that anymore. I just looked this week, which is kind of interesting to me. ESMO still talks about getting a margin of at least 3 centimeters on an intestinal type tumor and at least a 5 centimeter proximal margin on a diffuse type tumor. And we've had, you've heard talks already today about the differences in those kinds of malignancies. And so when I think about the operation that somebody needs, I'm thinking about, can I get an appropriate margin on this patient and still spare some of the stomach? Well, you might say, why not just take out the whole stomach? That's the easiest way to get a negative margin. Well, for many of you in this audience, I suspect you would have a better answer than I. That's a big deal when your whole stomach is taken out. So, but I'll describe just in very basic ways what we're talking about when we talk about those three operations. So a distal gastrectomy, which is kind of illustrated here, is in every operation that we do for gastric cancer, we're basically stapling or cutting across the duodenum. The duodenum's the first part of the small intestine. Your stomach empties into your duodenum. So all three of these operations, that's where your distal margin is. I get asked a lot, why not, if I have a proximal tumor, why not just cut out the proximal half of my stomach and leave the distal half and just pull that up to the esophagus and hook that up? It seems like it makes sense. I would love to have some of my stomach left over, and if you can get a negative margin, I mean, why not do it that way? Well, it's actually been done. I've done it, and it works kind of terrible. And the reason is that your stomach just does not like to get cut like that, and your stomach will not empty well. And so people can be really miserable. The one time I've done it in my career, I actually had to dilate what's called your pylorus multiple times and really try to just break it apart so that the patient would empty. And so it turns out that it's really not a great functional operation. And so that's why, for the most part, everybody gets transected right in that first part of their intestine. And then it just becomes a matter of how proximal we're going to go, thinking about that margin. So the distal gastrectomy is the most tolerated operation. I tell patients, or the most well-tolerated operation. I tell patients this really is not a huge deal in terms of quality of life. You will, in general, get back most people to eating kind of the way you used to eat. There can be issues, but generally your quality of life is pretty good. Subtotal gastrectomy is really a glorified distal gastrectomy, but you're going up and taking much more of the stomach, and you may only have just a small pouch of the stomach. For those of you who know people, or you yourself have had like what we call a Roux-en-Y gastric bypass, it actually is kind of a glorified subtotal gastrectomy. You leave, the principles of that surgery is that you leave a really tiny pouch of stomach, and you basically reduce the capacity of when that food goes into the stomach. That pouch is really small. Well, that's basically what a subtotal. Now, there are other things that go into a gastric bypass that cause malabsorption and other, which is we're not going to talk about, but the idea of just reducing the capacity of that stomach, that's kind of what you're dealing with when you get a subtotal gastrectomy. And that's kind of illustrated here. And then we basically have to reconnect your plumbing, as you can see here, with basically bringing up part of your small intestine, hooking it to that small gastric pouch. Now, you might say that looks pretty gnarly, but actually your quality of life can also still be pretty good even with a subtotal gastrectomy. You know, people, it can be remarkable. In fact, you can see it in folks that have bariatric surgery or obesity surgery. Even with a small gastric pouch, you'll see their weight loss plateau in general, and people can actually regain the weight even with a small gastric pouch. So you can actually kind of maintain your weight, maintain your nutrition in general when you have a subtotal gastrectomy. But the big one, which many of you, as I said, know better than I, is a total gastrectomy. So if you can't get that proximal margin and you have to take that whole stomach, then this is what you get. You get a total gastrectomy where we remove the entire stomach, and you can see that we hook up that small intestine to the esophagus. And that really does have a real impact. And also for some of the folks in this audience who have said that they were CDH1 carriers, that this is the prophylactic operation that we're talking about. So in terms of the stomach itself, this is the operation that group of patients also gets, although there are differences in terms of what we do with lymph nodes, and treatment before and after can vary quite a bit. But in terms of the actual anatomic operation, this is what CDH1 patients get. And this is a big deal operation. And I'll talk a little bit more about that at the end. The other thing I mentioned other than margin is getting those lymph nodes. So again, Dr. Zito and Wong kind of alluded to this, that there are lymph nodes that are kind of around the stomach itself. You can be the world's worst surgeon and you'll still get some of those lymph nodes. You just can't avoid getting them. But there are guidelines that really that tell us that you need to do more than just taking the lymph nodes around the stomach. Well, why is that? A lot of people think there's some magic in your surgery that if you get 15 lymph nodes or do a D2 dissection, which Dr. Zito alluded to, that somehow you're magically going to make that patient do better surgically. I have a lot of trouble with that. I think it's really just better understanding. When you get a better lymph node harvest, it's better understanding what your stage is and kind of what the best treatments for you are. But there certainly is, I mean, you could speak for hours on the surgical debates about the appropriate lymph node dissection, but the bottom line is that what the guidelines tell us is that we really try to get, in the United States, we try to get 15 lymph nodes. And what that usually means that we need to do more than just take the lymph nodes that are kind of right around that stomach, is that we want to take them, as you see in the bottom picture here, you want to take the lymph nodes that are associated with some of those other regions. Near the pancreas, as you can see here around the splenic artery, this is called the celiac axis that comes off the aorta here, if you can look at my marker. And then it gives off some branches like the splenic artery and the hepatic artery, and you basically try to strip a bunch of those lymph nodes off of there. And again, people will tell you that somehow surgeons are magically curing patients by taking those lymph nodes. I have a lot of trouble with that. I think what we're doing is we're better understanding what that disease is doing so that we can better think about what your best treatment is. Again, that is an area of always hot debate in the surgical literature. But again, just to remind you, in sort of our United States guidelines, the NCCN guidelines, the goal is really to get 15 lymph nodes, and the most reliable way to do that is try to get lymph nodes above and beyond the ones that surround that stomach. A quick comment, again, because I think the future of gastric cancer has very little to do with surgery. It has much more to do with what Dr. Uronis is going to talk to you all about. But you'll see a lot of stuff about minimally invasive versus open approaches. I will tell you what is by far the most important thing is that you go to a surgeon that does this operation with enough frequency and in the context of having people that know the best way to treat. So, me talking to Dr. Uronis, me talking to Dr. Zito about where does surgery fit in other sorts of therapies, that's way more important than whether somebody deployed a fancy robot for your surgery, okay? And in fact, this trial that was published in the Premier Oncology Journal kind of gets at that. It's another Dutch trial. We talk a lot about the Dutch when we talk about gastric cancer in Western populations. But they conducted what I consider probably the most important trial around this. And what they did is they basically just randomized people to get an old-fashioned open operation where you kind of get an up and down scar on your belly versus getting a bunch of little port sites and stuff like that. And essentially all the endpoints were identical. I don't think there's anything wrong by any means. I operate and do minimally invasive surgeries myself, but if somebody tries to tell you you're getting a better cancer operation because they're rolling out the robot, that's false, okay? And so what you want is an operation done by an experienced cancer surgeon that is done in the context of a place that knows how to manage that disease, and nothing else matters in my opinion. And this trial, I think, sort of underlines that point. We've talked about staging. Again, appropriate surgery means that we're getting the best staging information. We're getting enough lymph nodes that we can figure out whether you have lymph node positive disease or negative, or your lymph node negative. It's important for prognosis. It's important for treatment decision making. We've kind of gone over some of these survival rates, so I won't go over that again. I did want to make just sort of one comment. We've talked again about some of the CDH1 carriers. I think there is, for those that don't know, there is a nice review of sort of consensus guidelines for this disease that was published in Lancet Oncology in 2020. And so I would encourage you all to look at that. And then finally, what's life like without all or part of your stomach? Can I eat? There's a whole laundry list of post-gastrectomy syndromes, and what I would tell patients and tell you is that you may get, we usually say about a quarter of patients may get some form of a post-gastrectomy syndrome, but long-term, in the absence of getting your whole stomach taken out, most patients do pretty well. There's lots of things that you'll read about: dumping syndrome, early and late, iron deficiencies, electrolyte deficiencies. You'll read about afferent, efferent limb syndromes, alkaline reflux gastritis. There's a whole laundry list of things that can be an issue, and so every patient that has a gastrectomy, I do plug them in. I know a nutritionist is speaking later today. They're really important, okay? They're super important for total gastrectomy patients. They're really important even for patients who have partial gastrectomies, because educating patients about what some of these syndromes are, encouraging them that most of this will pass, but there are some dietary modifications that you can make are critically important and can really be can really have a huge impact on your quality of life. So I was glad to see the nutrition person was speaking today. Again, in that same guideline document that I alluded to, there's also a nice list of a lot of the sort of quality of life issues that patients with total gastrectomies face. And then finally, is surgery enough? No. Okay. And so I think if there's anything else, when we're talking about established gastric cancer, even though your surgeon may have a lot of swagger and walk into that room and act like that they can fix you, it ain't enough, okay? And so all of the most important advances for patients with real gastric cancer is going to really be around getting the best decision-making in terms of systemic therapies, radiation therapy. It's important to have a good quality surgery. It's important that you have a surgeon that has an appropriate level of complications. But these surgeries can be difficult to manage and negotiate, and I'm not trying to diminish that whatsoever. And that's why I think a lot of what you're going to hear later today is really important, because a lot of what these patients and nutritionists are going to talk about is life after a gastrectomy. So thanks.
Okay, I know I'm standing between you and lunch. So as Dr. Cito and Dr. Blazer said, this is very much a team sport. So we talk about patients. We don't make decisions in a vacuum, so we all work together. So I think one of the things I was going to talk about is clinical trials, and then as I was reviewing things, I realized we didn't have anything about therapy for metastatic or stage 4 disease, so I was going to sort of kind of combine those two in a bit of a whirlwind. So those are just my disclosures. So I'm going to go over clinical trial basics, options for therapy, just sort of briefly touching. I know Dr. Wong talked about some of these, but sort of how we use the different ones. Trials for locally advanced disease, which Dr. Wong basically covered, so I'll sort of go quickly over that. Treatment of metastatic disease, and then trials for stage 4 disease. So the basics of clinical trials, and this is what I tell my patients, is there's 3 phases. Phase 1, 2, and 3. And that's something to think about if you or a family member or someone you know is thinking about a clinical trial. Phase 1 is the very, very sort of basic. It's typically the first step in testing a new drug. And the drug companies, when they do these trials, are interested in the safety and the side effects and the best dose. So we all want it to work. They also want it to work for different reasons, maybe. But they're trying to figure out, how do I give the drug? How does it affect patients? How do I dose it? And then sometimes it tests the best way to combine different treatments. So phase 1 trials definitely have a role, but if you are a newly diagnosed patient, you wouldn't really want to do, or I wouldn't encourage someone to do a phase 1 trial, because it's very early and we really are just not testing sort of how well something works. Phase 2 is the next step up from that, and that basically helps us understand how safe a treatment is, how well it works, and typically in a specific type of cancer. So many phase 2 trials are done at single institutions or groups of institutions, and they say, we want to look at this drug or combination in stomach cancer and make sure that it works well enough for us to try to advance it to the next phase, which is phase 3. So phase 3 is a lot of the big things we hear about in the news is basically we're taking a new treatment that we've developed and pitting it head to head against the old standard. Or we're taking the old standard and adding something to it to see, does this new combination work better than the old standard? And these are most often randomized, and Dr. Wong and Dr. Cito talked a little bit. So basically, if you're in a phase 3 trial, you kind of agree to say, okay, I'm either going to get the standard or I'm going to get the new treatment. And a lot of patients are skeptical about doing randomized trials because they want to get the new treatment. The problem is the only real way to know is to compare a group who got the standard treatment and the new treatment. Otherwise, we'll never really know if one is better than the other. So that's kind of the general framework. Each of these has a place in treatment. Typically, phase 3s are more done in newly diagnosed patients. Phase 2s are sometimes newly diagnosed if we're in the small setting. And then phase 1 is typically in patients who've already had a lot of treatment and don't have many other treatment options, although that does vary a little bit. So in terms of, the three things we use, and this is what I talk to my patients about, we have chemotherapy, we have targeted therapies, and then we have immunotherapies. So chemotherapy is basically, it's basically poison. There isn't really any other nice way to say it. So it basically kills the cell, stops the growth of the cancer cells, and then the side effects come because we've also affected normal cells. There's sort of a whole laundry list of different chemotherapies we can use, and it depends on sort of what we're trying to do, how well a patient's doing, and what cancer you have, because there's some drugs that I would use in gastric cancer that we wouldn't use in a breast cancer or other things. everybody's mostly familiar with chemo side effects. So bone marrow problems in terms of low white blood cells, red blood cells, platelets. Neuropathy is a common thing we see in our patients because many of our drugs will cause damage to the nerves, and so people will have numbness, tingling, sometimes pain. So that's something we have to pay attention to. And then issues with the GI tract, so nausea, vomiting, diarrhea, which is often a problem if you already have a problem with your GI tract. Targeted therapies are sort of where targeted therapies and immunotherapies is sort of where the field is going. I think a lot of the things we're trying to do in clinical trials is see how these add and then maybe try to get rid of the nasty chemos that we use. So targeted therapies are more selective than chemo. You can use them alone or in combination, and they work in different ways. So in general, they will block a particular pathway. So for example, HER2 is something we talk about in gastric cancer, and that is a marker on a cell, and it's called what we call a cancer driver. So the HER2 basically gets the signals and tells the cells to grow and divide. If you block HER2, that will stop that drive for the cancer. And so there's a couple other ones. HER2 is the big one. Claudin 18.2, that's another one. FGFR2. So this is, again, getting back to what Dr. Wong was talking about in terms of personalized medicine. When we do these genomic panels, this is what we're looking for. We're looking for what we call actionable mutations, and these are the ones where we can just target. And so, and the interesting thing is many of these targets, not all of them, are cancer agnostic. So in HER2, you hear about it in breast cancer, you hear about it in gastric cancer, and now we're starting to talk about it in colon cancer. So that's the other interesting thing about these. So the two we talk about mostly in gastric cancer is HER2. So you might have heard about a drug called Herceptin or trastuzumab, and about 20% of gastric cancers will overexpress HER2. The other one we talk about is ramucirumab or Cyramza, which is a VEGF target. So basically, VEGF is a pathway that helps stabilize blood vessels. So the idea is if you block VEGF, the blood vessels that lead the tumor and give it the blood that brings the nutrients will be leaky, and you don't get as much blood or nutrients. There's many other things that are in development, but these are the ones that are approved for gastric cancer. Side effects depend on the target. Trastuzumab, thankfully, doesn't have many side effects, so cardiac dysfunction is something we have to watch. You have to get an echocardiogram and just follow that. And Cyramza has more side effects because if you think about affecting blood vessels, you could cause hypertension, protein in the urine because you affect blood vessels in the kidneys, wound healing problems. So whenever I describe this drug, it sounds really awful and terrible. But most people don't get those things. So immunotherapy is the big thing that everybody's excited. Everybody is excited about. So this is trying to harness the immune system. So the drugs you hear about may be Keytruda or Opdivo, which basically allow the immune system to remain revved up. So the general immune system has a baseline. It gets revved up when you get an infection, and then there are these checkpoints that tell it to turn back off. So those two drugs block a couple of those checkpoints so that the immune system just stays a little more active and can try to find a cancer, which it can't normally see because cancers look a lot like self. The other things are vaccines, which are not really something we use in gastric cancer, and then cell-based therapies. And there's a new thing that I'll mention at the end in terms of the trials, which is one of these cell-based therapies. So Keytruda and Opdivo I mentioned. The two general scenarios where we use these are in patients who have a microsatellite high tumor. So when we meet patients with stage 4 gastric cancer, we check their HER2 status because we want to see if we can use trastuzumab. We check their microsatellite status, which I'm not going to go into because I don't do a very good job of explaining it generally. But if you have an MSI high tumor, then you can go straight to one of these immunotherapy drugs because it will work really well. Or we do PDL testing, which is sort of all the other patients, and we look to see, that helps us know how likely your tumor is to respond to immune therapy. Immunotherapy side effects are completely different than chemotherapy side effects. So if you think about your immune system's revved up and is trying to attack the cancer, it can also attack your own body. So the most common things we see are thyroid problems, rash, and diarrhea, which is due to inflammation of the colon. We can usually manage those pretty well, but you can have, one of my colleagues, John Strickler, says you can have itis of anything. So pneumonitis, inflammation of the lung, inflammation of the adrenal glands, the heart, the liver, the kidneys, anything. And the way we treat these is we basically give steroids to shut down the immune system. Sometimes we're successful, sometimes we're not. So luckily, less than 10% of patients will have severe side effects, but sometimes they can be really difficult to manage. Okay, so that's sort of the general overview. In terms of trials for locally advanced disease, so Dr. Wong kind of touched on these. So what we know is, as Dr. Glazer said, surgery alone is not enough. We got to do something else. Radiation, we're still thinking about, we haven't given up on, but because we know that the immunotherapy drugs have really revolutionized the way we treat stage 4 patients, we've said, okay, let's move them up. And the way I think this is going is we're going to add them. If it works really well, we're going to start peeling off chemos, because anybody in this room who's had chemotherapy knows, or has a loved one that's had chemo, is it's pretty awful. So this is the Matterhorn study, which is looking at gastric or GE junction. So FLOT, which you heard about from Dr. Wong. So they're doing either FLOT, surgery FLOT, or FLOT plus durvalumab, surgery and durvalumab, and then they're doing maintenance durvalumab. So the other question, which has come up in the Checkmate 577 study that Dr. Wong talked about, is, okay, we do this perioperative strategy, but if we do maintenance immunotherapy for longer, is that helpful? So this trial is currently enrolling. I think it's got another year to enroll, but we're all pretty excited about this one. And then the other one, which I didn't include, is similar design, which Dr. Wong also talked about, is basically the same trial, but just with a different immunotherapy drug, and that's Keynote 585. Then this slide, I apologize, this is not resected. So this is, Dr. Zito talked about this. This is the Top Cure study. So basically saying you get diagnosed, so you're not resected yet, but you get diagnosed, you get chemo, or you get chemo plus some chemoradiation, then surgery, and then more chemo. So this trial is enrolling. They were able to get patients through, toxicity was acceptable, and so as Dr. Zito said, it's finished enrolling, and hopefully we will get some results about this. So in terms of totally switching gears, treatment of metastatic disease. So metastatic disease is basically disease that can't be cured surgically because the cancer has spread to multiple different places. And so the big thing when treating these patients is balancing keeping the patient feeling well while keeping the cancer under control, which generally we can do well with and sometimes we don't do well with. So it's very much a partnership between the patient and the team and the family to kind of balance goals and sort of how we want things to go. So we talk about lines of therapy, and this kind of ties into the clinical trial discussion as well. So the first line of treatment is the very first type of treatment you get. The second line is the second type, and the third line is the third type, and so on. This is important in the setting of clinical trials because when clinical trials are designed, they are designed for a certain population of patients. So in an undiagnosed patient, a newly diagnosed patient, we would say we're looking for a first-line trial. If you have already started, if you're newly diagnosed and you've already started chemotherapy, then you're automatically not eligible for a first-line trial because then you've already had treatment. So what I try to tell my patients is, before you start a treatment, that's when you want to look for clinical trials. Then if you're on a treatment and it's working, even if the clinical trial comes up and it sounds really exciting, if your treatment's working, we would never stop it because even if the trial sounds really exciting, we don't know if it would work for you. So then if your treatment then stops working, that's when you should pause again and say, okay, if I'm really interested in trials, how can I find one? And so that's, if you're looking at trials, that's kind of, in addition to the phase 1, 2, 3, kind of think about first line, second line, third line. The other thing to know is that some trials have a limit on the number of types of therapy you can have. So sometimes they'll say, well, you can have two prior types of chemo, but not anymore. That's not usually a big deal, but that's just another thing to think about. So just in general, I'm not going to show any Kaplan-Meier curves or anything. In general, the typical first-line treatment, if you have a gastric cancer that's spread, would be chemotherapy. And the typical backbone in this country is either FOLFOX or XELOX. And then we do this molecular testing, which I talked about. So microsatellite status, HER2 status, and CPS. And then we pick a regimen. The other thing is we will often at this stage do what's called next-gen sequencing, where we will try to, there's different vendors, there's Foundation Medicine, Tempus, Caris, and that's where we look for those targets. So we send off a tumor tissue if we have it, And the way I describe it is like a fishing expedition. I don't know what I'm going to catch, but if I catch something, I might be really excited about it. In general, I would say 95% of the time we find things that are academically interesting, but not particularly clinically relevant to treating. And I've also heard it described as looking for a needle in a haystack when you don't know what the needle looks like. It's worth doing, though, because if you're in that 5% where we find an actionable or targetable mutation, that's like hitting the jackpot. So in general for these things, microsatellite high patients would get immunotherapy. If you're HER2 amplified, which again is about 20% of gastric cancers, then you would do chemo plus trastuzumab, which targets that HER2, plus immunotherapy. So the drug pembrolizumab has been shown to have, so you'd get that 4-drug combination, which can have really kind of amazing results. And then what happens is you get 4 drugs, and we try to do all 4 drugs for 4 to 6 months, and then we cut back to less agents so that you'll have a better quality of life. And then the CPS score, so if you are not microsatellite high, you're not HER2 amplified, we do this combined positive score to look at sort of your likelihood of responding to immunotherapy. If that score is 5 or greater, then we would add immune therapy, either pembrolizumab or nivolumab. So really the current standard is chemo plus some kind of targeted agent or some kind of immunotherapy. So you do that as long as it's working. So then the next line would be second line. So if and when that first type of treatment stops working, then you go to the next type, and it depends on whether you're HER2 amplified or not. So I just put these for completeness. I'm not going to go through all of them. And then again, this is where you'd pause and say, is there a clinical trial? So in terms of trials, so what we're trying to do is see chemo backbone and what can we add to it. So this particular trial uses this target Claudin 18.2. So anybody who is going into this, they would get tested for Claudin 18.2. They have to have that, but they have to be HER2 negative. And then they get randomized to the regular standard chemo versus this drug that blocks the Claudin 18.2. So this is a very specific trial. It would probably take a little bit of time to accrue just because there aren't that many patients that have that specific target. This is another one which has gastroesophageal cancer, so esophagus, gastric, and GE junction. So it's looking at, again, the standard backbone plus pembrolizumab, so that checkpoint inhibitor, plus lenvatinib, which is a targeted drug, kind of similar-ish to Cyramza. So basically saying, okay, if we do immunotherapy plus a targeted drug plus the chemo, is that helpful? And then, as I mentioned, we try to do all the drugs up front, and then we sort of cut back to either maintenance chemo or some kind of consolidation. So this one's actually getting rid of all the chemo once you get a little further along. This is another study. So there's a theme here, obviously, chemo plus whatever else we can add. So this is one we actually have open at Duke. So this has the chemo plus tislelizumab, which is another checkpoint inhibitor. And then this drug, DKN-01, targets something on the cells, and it's a pathway that seems to be interactive with the PD-L1 pathway. And so if we block both of those, is that helpful? And then in second line, again, sort of on the theme of targeting things, so this is in HER2 amplified patients, so they get the standard second line Taxol Cyramza plus trastuzumab, which targets HER2, and a drug called tucatinib that also targets HER2. So this one is also enrolling, and we have this one here at Duke. So then beyond second line, there's some other different things sort of looking at CAR T cells, which you may have heard about in the context of leukemia and things like that. This is a first-line trial that I found, which is enrolling. And then, so the way CAR T cells work, just in general, is you remove blood to get the T cells. They manufacture these T cells in the lab, so they make them do something, and then they put them back, and the idea is that they're then primed to treat the cancer. So it's, again, using your immune system, but in a little bit different way than giving you a drug that allows your immune system to be revved up. And we actually have a trial here, which is using, which is in the second line, which is using these types of agents. So this, in terms of the clinical trials, that sort of scratches the surface. So any of you who tried to look, I think one of the things we don't do a very good job of is lots of times people will say to me, what are other people doing? And I know some of the people because I have a lot of context, but I don't know what everybody's doing. And so it is a little bit hard and challenging to kind of find a trial. So in summary, we have a lot of options to choose from, side effects based on what you get. I think we're starting to bring immunotherapy and these targeted agents. I can tell you, I've been doing this 15 years. In the last 5 years, the amount of knowledge about gastric cancer has like skyrocketed. It's really kind of crazy. It used to be just chemo, 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 and now I think we're getting a lot more sophisticated. And then that's it. So we're like, well, we're over. But if anybody has questions, we can maybe take a few questions.
I was going to say that lunch is ready. And I also was going to ask, we're going to fit in one extra talk from a survivor story, patient story that I think we'd love to have. So if you guys don't mind, we can take a question now. If anyone has one, you can grab your lunch and then bring it back and just eat here. And then we can keep going. We have a lot of great speakers coming too. Do we have any questions right now? Yeah.
Hi, my name's Suzanne. I'm stage 4, and my PDL score is a 10. And I have had great treatment response to Opdivo, Folfox, and now 5-FU. So unfortunately, at the beginning, it wasn't really, it doesn't seem, even Hopkins didn't suggest MSI testing. And now I've tried to have that MSI testing and it's failed because I have great treatment response. How often would you, how likely is it that I could possibly be MSI high and also with a PDL of 10? And then if and when my chemotherapy became too toxic, would you consider, but my cancer was not progressing, this is what I hope for, would you consider someone in my situation just remaining on the Opdivo instead of switching to second line?
Yeah, so that's a good question. So it's probably less than 5% that you would be microsatellite. We don't see microsatellite high very much. So while I do think it should be tested, and we test those 3 things in everybody, and actually we've asked for what we call reflex testing, which means any new gastric cancer, we want it immediately. So for any new colon cancer, immediately gets it. And now with the data we have, everybody should get it. So, but I think it's unlikely. The other question is an interesting one. So to be honest, we don't really know. So we only just started using the chemo immunotherapy combinations in sort of spring of 2021. So I can tell you what I do. And actually, I was just at an education session the last 2 days about gastric cancer. And this is kind of what the other experts there said, is I typically continue everything for the first 4 to 6 months and then drop it. And then I go to 5-FU plus the Opdivo. And then what I've done is just continued the 5-FU plus the Opdivo and to the 2 years, although I don't have anybody quite at 2 years yet, but that was my thought. But I would say is if you have toxicity or other things and your disease is completely stable, then you could definitely drop the 5-FU. One of my other colleagues, John Strickler, he basically says if patients have a good response, he'll do the chemo and then he'll just go straight to the Opdivo. And he and I have had debates about why I do what I do, and the problem, we just don't really know. We don't have so I think it has to be an individualized discussion with what your disease is doing, how you're feeling, so some of my patients are like, don't you stop anything. If it's working, I don't want to change a thing. Whereas there's other patients who are like, well, if I don't have to have the chemo, I don't really want that part. So that's a long way to say we really don't know because it's so new, we just don't have good guidelines or sort of thoughts on what to do.
How much would the PDL-1 score 5 or higher play into that?
Yeah, I don't think it does, to be honest. CPS is not the best marker because I've had patients if CPS is 60 and we're like super excited and then they didn't have a good response. So I personally, it wouldn't affect any of that decision.
Hi, my name is Amy, and I have the CDH1 gene, and I live in Massachusetts. So as a potential patient for a total gastrectomy, I've heard from a couple people that it's important to get a really good surgeon, so maybe Dr. Glazer, this is more for you, but what should I be asking of a potential surgeon?
So when we're talking about established gastric cancer, I think, as I mentioned, it's really important that you know your case is talked about in tumor boards, and it sometimes, to me, it's just as important the timing of surgery as any technique. In your particular case, when you're just talking about, in all likelihood, a total gastrectomy, I think the things that we say, it's you can ask the surgeon about their volume. You can any surgeon that treats gastric cancer is going to be obviously have done a fair amount of total gastrectomies. And so I think it's fair to ask. I get asked it all the time, and there are surgeries I do not that often, and I tell the patient that, but most of the ones I don't do that often, a lot of people don't do that often. And as we mentioned even before, you know, gastric cancer is not that common, so finding high volume centers can be hard. We have another surgeon in the room, Dr. Myers here, and I would let him answer the question too. But I think if you live in Massachusetts, you know, going to a sort of tertiary academic medical center is what I would recommend, because that's probably the easiest place to find surgeons to do appropriate volume. But again, the operation itself, in some ways, is more straightforward. And I'm not discounting what you may be looking at all, but some of the things that we think about with cancer operations, with local invasion, getting a more extensive lymph node dissection and things like that, really what your critical issue is going to be just getting a good operation on that stomach. I'll let Dr. Myers.
Want to comment?
This is Dr. Myers from UNC, who's speaking later, but who also does a lot of these surgeries. So I absolutely would get his input too.
Thanks, Dr. Blazer. So, I look forward to talking with the group, and my apology for a late arrival. I don't have much to add to what Dr. Blazer said. I think in our area here, we have a little bit of an embarrassment of riches with two centers that do a lot of treatment for gastroesophageal cancer not far apart. The only thing I would add to that is that the decision-making around timing of surgery and, you know, the lifetime risk of surgery in those with CDH1 mutation, that's the expertise. And so the programmatic side of that, I think, makes a difference. And again, similar comment, you know, there are, we both groups work with GI docs and genetic teams who have specific interests in inherited gastric cancers, inherited GI tract cancers, and we work as a team to try and think about all of those things together.
And as was said this morning, that's a little bit of a moving target, right? We've talked about that this morning, so that's a great point that he makes in terms of that issue.
So everything is in the PowerPoint presentation, except for this speaker. And did you see who? Yes, I did. Okay. So you hit Alt, and then you hit Tab, and it's not cool. You can tab it. So hers is there. It's a PDF. So when we go to it, I think we just make it full screen. We have to figure that out. How to make this PDF full screen. Show all. Well, do we know? Is it that?
We can just, if we just like
Yes.
move that.
Oh, that seems okay. Okay. Alt Tab, and we'll go back to yes.
Okay, and then to switch with each one, or the rest of them? Just
Yes,
on
they
this one
built
slideshow?
exactly. And Suzanne doesn't have slides, so we have a slide that has her name.
Okay.
And then she's just going to talk.
Perfect. Okay. All right, we are ready to restart. I know folks are still grabbing lunch. Feel free to continue eating during this next session. If my other speakers could join us on stage, well, maybe you're still eating. I guess it's okay if you just come up when it's your time to speak. Okay, let's do it that way. So before we get started, if you are here because you are a CDH1 carrier or a gastric cancer patient or a loved one, could you just raise your hand in the room? Wonderful. Thank you. Thank you for being here. I know it's a Saturday and you could be doing many other things, and we all just want to acknowledge the time that you've taken out of your weekend to be here with us today. The spouses, the children, the friends, the caregivers, all of you are really important to the work that we're doing. We've heard a lot so far this morning about the status of the science and the important clinical developments in stomach cancer, but as a scientist myself, I would argue that the most important session of the day might be this one, because we're going to be hearing about the experiences of patients, of caregivers, of a nurse who's treating these patients, about the perspectives of living with stomach cancer and living with the CDH1 mutation. Understanding your perspective is absolutely critical to helping us deliver the highest quality care that we can and making sure that it's timely, that it's equitable, and that it's more patient-centered. With that, I should have introduced myself. I'm Stephanie Wheeler. I'm the Director of Community Outreach and Engagement at UNC Lineberger, just down the road, and we are delighted to be here co-hosting this with No Stomach for Cancer and with Duke University today. And our first speaker is Stacy Martin. She is a CDH1 carrier, and she's the creator of Seahorse Snacks, of which there are some samples right outside. I highly suggest that you try them out. They're delicious.
Hello, everybody. I'm really excited to be here. Thank you all for putting this event together. The last time I went to one of these, I had a stomach, so this is a whole new thing for me. And I went as a patient. So this is just sort of my experience and my journey with CDH1. And so here we go. So also, I would like to preface this with this is probably the most non-technical presentation that you'll hear today. And there's probably not continuing ed credits associated with this, but this is the human part behind all of the things that we've heard about so far today. So how this started, in the fall of 2017, my mom was diagnosed with stage 4 uterine cancer. And so she was being treated at the Mayo Clinic. And I went out on FMLA, and I was her caregiver. So I lived in Atlanta at the time. She lives in Wisconsin. So going back to Wisconsin in the winter is not really like what anybody does, but you got to do what you got to do. So she had a hysterectomy. She was going through her chemo. They did genetic panel testing to try and explain why she had the cancer that she did. And it turns out it was completely unrelated to her uterine cancer, but now she has this CDH1 mutation. And I remember being in the room with her, and they're explaining all this, and they're talking about what it is, and I was just like, wow, that's a lot. That's a lot. But it was her a lot. It wasn't my a lot yet. So after she got done with her chemo, I went back to my life. I turned 40, celebrated my birthday. I moved from Atlanta to Chattanooga. I bought a house. That's the picture of my mom that next summer. So her hair's growing back. She's doing pretty well. In the meantime, I was working with my sister, who happens to be my financial advisor, so I was getting life insurance. And so for a year, I knew that there was the potential that myself, my brother, and my sister could have this genetic mutation. So I had a very busy life. I was a top performer at work. I traveled all the time. So if I was home long enough to buy groceries, like, it was a big deal. So I decided to finally bite the bullet and called the genetic counselor at Mayo. She sent me a kit. I went to the local hospital, drew blood, sent it off, and didn't think anything else of it. And then February 6th, 2019, I was working in my home office. It was a really busy day. The cleaning lady was at my house that day. I had customer meetings that afternoon. I got a little notification on my phone that I had some test results, so I went on my patient portal, and I open it up, and it says, "You are CDH1 positive," and it had the little variant, and I was like, I don't know what this means. Like, what? And it's just like this whole tidal wave that washes over you. I'm sitting at home by myself, and I get these huge results. And I called my sister immediately, because she usually handled all the medical stuff for my mom. So I called her, and I was like, this is what just happened. So she tried to call the doctor, and she wasn't in that day. And I just remember, like, bawling and thinking I was going to die immediately, because I didn't really know what it meant. So I had meetings. I had to get on with my life. Like, there was no time for any of this. But because I sort of heard some of the things with my mom, I knew that this was a big deal. So I was flying to Chicago, and I think sometimes when people are threatened with their mortality, they think of things like, oh, I'm going to go skydiving, or I'm going to do all these things. My thing, I'm a foodie. And so the first thing I did was decide I was going to make a food bucket list. And so I was on my way to Chicago, and then I was also going to be in New York that week. So this is the beginning of my food bucket list journey. So I landed at O'Hare, and I texted my dad, and I said, you want to meet me for lunch? So we started at Portillo's, and I started with an Italian beef and a chocolate cake. And that's actually when I told my dad what was going on too. And his first question to me was like, is this for real? Did you do this on the internet? Or is this, like, for real? And that was the beginning of a lot of the reactions of people who don't know about this, or don't really understand how they react, because this is a big deal. It's like, we didn't just get a paper cut. This is life-altering news. And because it's so new and people don't know a lot about it, and there's not a lot to do about it, but we're working on that, that was one of the parts of my journey, was when I shared my status with people, people say really dumb things to you when they don't know what to say. But it's nice to be on the other side of that. Anyways, back to my food bucket list. So we hit Portillo's for lunch. I went to Gibson's for dinner. I had tapas at Cafe Barbarilla. I had lobster rolls for breakfast at the Plaza when I got to New York. I went to lunch at Peter Luger's. So I was taking this very seriously. I don't really know what's going on yet, but my stomach is going to put in some work before it gets evicted. That's basically how this is going to go. So I was able to get my appointments at the Mayo Clinic because that's where my mom was going through. Like, when I moved to Chattanooga, I still didn't even have a local doctor at the time. So I didn't have anybody locally to reach out to, because I didn't even have a PCP. So I was very thankful that I had a great place to start at the Mayo Clinic. But it was also really scary. So when I called, and they're like, okay, we're going to do these things. We're going to do an EGD. We're going to get a mammogram. We're going to get an MRI. I was like, well, how long am I going to be there? They're like, I don't know, just book a hotel for 2 weeks. Like, I'm just going to be at the hospital doing tests for 2 weeks. What am I going to do about my job? And I can't tell anybody about this because I don't really know what it is. So got to the Mayo Clinic. All the tests, everything was good, so there was no, like, immediate risk for anything. I met with the surgeon, and he was very cocky. He was like, yes, I do these. I do a couple of these every month. he was confident, and he also did it laparoscopically, which appealed to me. So I met with the genetic counselor, and when I was there, because we had the history with my mom, obviously I was a little, it's interesting because now I know about all the genetic maps with the circles and the triangles and all the little notes and stuff. So we continued to map my family history. So an interesting thing is that my mom's a triplet. And so my mom has this, but my mom's two sisters that she was in utero with, they're identical, and she was an oddball. So she was the bonus egg. But they're negative. And then my mom's sister has had lobular breast cancer, but she hasn't been tested. So we just assume that she does have this. But as far as we know, in my family right now, it's just my mom and myself that have this. And my brother and sister tested negative. So when I was meeting with the genetic counselors at the Mayo Clinic, they gave me a flyer for a study at the NIH. And I'm in research mode. I met with the dietitians at I requested to meet with the dietitians at the Mayo Clinic because they don't usually get involved at that point in time. But one of my closest friends is an oncology dietitian in Atlanta, and she helped me navigate some stuff with my mom. So I already had an idea of the value of the relationship and how important that was to pre-surgery and healing. So they have a lot of resources, but they weren't necessarily all connected. So I went back home, went on with my life, still doing a lot of research. I think there's a lot of soul searching that you go through when you first hear about this, because it's such a big life-altering thing. Like questioning, what can I do? What are my other options? So I tried to exhaust all of my research. I looked into CRISPR technology to getting my genes edited. That's not legal here in the US, but also it's not very reliable as an adult because you have a lot of cells. And so if they miss one, you just paid a lot of money for nothing. I went to a Reiki healer to see if I could get my energy balanced so we could get rid of this. And then I called the NIH. They called me back right away. We had some really good conversations with the intake nurse. I was scheduled for an appointment in May, so I could go meet the team. One of the really appealing things about the program at the NIH is that they have a full team that works with Dr. Davis. So there's a pharmacist on his team. There's a PA. There's the dietitian, Rachel. She's infamous. And so it really is a completely holistic approach to all of your needs. And that was very appealing to me. So when I first met with Dr. Davis, he's like a really calm guy. He's like pretty cool and laid back. And he's like, yeah, we're just going to do this. I do it open. That was not really appealing to me, but he explained the reasons why he does that. And so he's just really laid back. And I was like, I need you to be cocky. I need you, if there was ever a time where you like, tell me you can do this, I need you to do that. He's like, that's not me, but I'll take care of you. And I believed him. So that led me in my journey to the last time I did this. This is the stomach cancer symposium that they had in Chicago in June of 2019. That's me in the middle with the white pants and the blue shirt on. And this, I call this lovingly as the Seahorse Convention, because that is the first time I met a lot of people who have been on the other side of this and are living their lives and thriving. And I heard, there's John too in that picture. I don't know if you guys, right there. Anyways, so that was the first time I met people that have survived this and that were really thriving. And they kept saying, you're going to be fine. You're going to have a great life. And I had an amazing life. And I didn't know if these people knew how amazing my life was. So I didn't really feel like they could tell me that I was going to be okay. But at that point in time, I decided that I was going to do this. So after I left there, I called the NIH and booked my surgery for September 12th, 2019. So at that point, I felt like I had solved the medical problem, and I knew that I was in the best hands possible and that I would receive the best care. So then I started focusing on what I needed to do for myself to ensure everything I could do to get the best possible outcome. All of our journeys are different, all of our inputs are different, and that causes different outputs. So I was still very serious about my food bucket list. So I continued eating like it was my job. And I started working out at Orange Theory 3 days a week, so I could be really, my heart could be strong and I could be physically strong so that it would help me in recovery. I got a therapist because I wanted her to know the crazy that I was before my surgery, so she knew where the baseline was. I also started listening to, there's an app or a program called Health Journeys, and it's guided visualizations and affirmations that I would listen to before bed. And it was like, after surgery, I'm not gonna bleed. After surgery, I'm gonna get up strong. And there's been a lot of research done with these things that actually do ensure positive outcomes post-surgery. So literally I was looking for anything that I could do to help myself to ensure the best possible outcomes that I had. So that takes us to September 11th, 2019. So I go to the NIH, I check in, I ask Dr. Davis, what time do I have to be back? He's like, just come back before midnight. My surgery's 5 a.m. the next day. So I said, well, do I have to stop eating? He's like, just be back by midnight. I said, do I have to be sober? Just be back by midnight. So this is a picture of my last supper, and I was very, very lucky to get a reservation at this restaurant in Capitol Hill. It's called Rose's Luxury. It's a Michelin star restaurant. I've been wanting to eat there for years, and that morning we were able to get a reservation for 4 people. So that's me, my mom, my cousin, and my sister, and we went for the Last Supper. So we sit down, and they're like, oh, what are you guys celebrating? And I had my IV still in my arm, like wrapped up. And I was like, well, this is my Last Supper. They're like, tell me more about that. I said, well, tomorrow I'm having my stomach removed. So when we made our reservations, it was for a 9-course tasting menu. And so when the waiter heard my story, he was just like really touched. And he's like, okay, first round of drinks on me. What do you guys want? So we started that way. And apparently he made his way back to the kitchen and told the chefs there. And they literally brought out everything that they had. So my 9-course meal turned into a 13-course meal. And literally, this is pictures of every course. This is what I ate in 3 hours. So then I go to surgery. And that's what I ate for the whole next week. So I made it through surgery successfully. They have protocols and programs, so you don't eat anything for the first couple days. Then you start with the clear liquids. And I remember when it was time to eat, I didn't know what was going to happen when I put the food in my mouth. Like, I know my esophagus is attached to my small intestine. I've seen the pictures. We can do this. But, like, I don't actually know what happens when it goes. So the dietary people brought on a whole tray and the whole plate of eggs. It was like the biggest plate of scrambled eggs I'd ever seen. And I was like, oh my God, do they know I can't? And I was like, I don't know how to do this. So I made them bring me medicine cups so I knew, like, portions, because they told us we could only eat 2 ounces at a time every 2 hours. And after my whole pilgrimage of evicting my stomach and my food bucket list, like, clearly portion size was not a thing for me. So this was quite the transition. So I had my total gastrectomy at the NIH in September of 2019. Went back home 10 days after surgery. Because I'm single, I live by myself. Having my mom and my sister there the whole time. My mom lives in Wisconsin, my sister lives in North Dakota. I had to come up with a care plan for myself. So I made a calendar. It was called Stacy's Babysitting Calendar, and I sent it out to all my friends and said, pick a week, because you're coming to take care of me. So I'm very, very privileged and grateful to have the people in my life that I do. And for 16 weeks, a different person came every week and took care of me. It was a great experience for me. So before that, I had a really high-performing job. I had a really high stress, very super active. And I left to go to the hospital on Monday, and I worked until Friday at 5 p.m. before I stopped working. So to go from running 100 miles an hour to do nothing, it was a very tough transition. So I would get home, I would eat, set my timer, go fall asleep on the couch. My timer would go off. I'd wake up, have to go eat again. And I'm thinking, like, how am I ever going to get back to my life? But we figured out a way. So being a foodie, I had a ton of recipes. Rachel, the dietitian, gives you a phase 1 diet, a phase 2 diet, but it's just like a bunch of ingredients. So you can eat these things, you can eat these things. And I was like, how can I put these all together into a thing so that I actually want to eat? So I made a ton of casseroles. Apparently I was well prepared for this for my whole life because it was hard, but I've been very successful. So I went on adventures with my friends and family every week. We'd go to a park, we'd go hiking, go to Costco. That was a big trip. So I was stretching my boundaries. And I gave myself goals, trips to look forward to so I could get back to my life. So my sister was turning 40. I took her to New York. One of her favorite chefs was there, and we got a reservation at Blue Hill at Stone Barn. Dan Barber's a chef there, and he had an 18-course tasting menu. And also, it was raw vegetables. And at 3 months out, you're not really supposed to move on to that yet. But here I am at this very fancy restaurant paying hundreds of dollars for my dinner, so I'm not going to not eat the vegetables. So I made it through 15 out of the 18 courses, which was crazy 3 months after surgery. And I ran around New York for the whole weekend, like successfully. So that was one of my little ticks in the box to recovery. Then I was in DC for my 3-month checkup. The next big sort of milestone was eating steak. So I went to Vegas for New Year's, and of course we're just gonna have a steak dinner while we're here. And I ordered the steak, and it came. I was like, okay. I mean, we have to chew our food really well. So normally I'd say about 20 to 30 chews is like a normal bite. I stopped counting at 80. And I was like, I'm never going to eat steak again because I don't have time for this. Like, I just cannot sit here and chew steak for 4 hours. So, whatever, lessons. And it's the little things that you don't even think of. So, we survived. I went back to work in January. Then COVID hit. So, it was really interesting because I was kind of good at staying home and being by myself, and then the whole world gets shut down. So, it gave me a little bit more padding for my recovery because nobody knew what was going on. So I had my gastrectomy in September of 2019. In September of 2020, I was addressing the breast cancer part of it. So I had a breast lift. And in November of 2020, I had a double mastectomy. And then I went back to the NIH for my 1-year checkup. And there's a market near where my cousin lives. And this lady was selling nuts. And I was like, okay, I can buy nuts. I can eat nuts. They're cool. You can throw them in your purse. You don't need a cooler. I can eat them on the go. And I bought these nuts, and I ate a pound of nuts in 3 days. And for somebody without a stomach, that is a lot of nuts. Eating every 2 hours, I get really bored eating the same things over and over again. So, like, my pantry is full of a lot of things, but they're only like half eaten. But I thought nuts were a good idea. So an idea was born. And I said, well, why can't I do this? So when I got home, I ordered a bunch of spices and I ordered some nuts. And that is the first batch of nuts that I ever made. And they were burnt and I threw them away. It was horrible. So this did not start out as a good thing. But eventually we got there. And so I started a company. It's called Seahorse Snacks. I make healthy and delicious roasted nuts with unique and unusual flavors. This is sort of the silver lining for me that's coming out of this story. And it's my way of sharing my love of food and my story with the world. I currently have 2 flavors. The first one is savory. It's called Chili Turmerific. It comes on almonds, cashews, and pistachios. And then my second flavor is a sweet one. It's called Maple Chai-tastic, and it comes on pecans. And it's a better for you version of a candied pecan because, as you all, well, a lot of you know, we have to be very careful with sugar. So I make snacks for me and people like me, but you don't have to be a seahorse to love them. So I started selling at markets last March in Chattanooga. And then in October, I moved into a commercial kitchen and I became certified as a food manufacturer by the state of Tennessee, the Department of Agriculture. Selling at markets. I'm in 4 stores now in Chattanooga. I'm in 1 in Florida. This year in November, I will be celebrating Stomach Cancer Awareness Month by doing a pop-up at a Sam's Club in Phoenix for 2 weeks. So you'll be able to buy my products there, which is also the largest order I've had to date. But basically, this has not been an easy journey, and there's a lot of ups and downs. July 12th was 1 year that I finally made it surgery-free. I had 4 surgeries in less than 2 years. I'm healthy, I'm thriving. There's no surgeries on the horizon, and now I get to sort of just live my life and see what I can do with this. So, thank you for listening. Also, snacks in the back. I also have a website, so if you want to order, seahorse-snacks.com. I ship to all 50 states. Thank you.
What a wonderful and inspiring story. Thank you so much, Stacy. I'm delighted to introduce our next speaker, who is a nurse at the UNC Cancer Hospital. This is Trudy Tatton-Howard, and when I wrote to Dr. Myers to say, we need a fabulous nurse who treats stomach cancer patients, without hesitation, he's like, you got to get Trudy up there. So thank you, Trudy, for being here today. You just push the button.
Oh, great. Thank you so much. Wow, what a story. That's kind of a hard story to follow. This might be a little bit not as exciting. Anyway, so my name is Trudy Tatton-Howard, and I'm a nurse navigator. And as you can tell by the lighter shade of blue that I wear, I work at UNC in the cancer hospital. And my particular setting is in the GI surgical oncology outpatient clinic. We call it SurgOnc. I'm what's called a nurse navigator, and some people are really not familiar with that role. It's found a lot in the oncology setting. But basically what I am is I'm an advocate, helping patients and families from the first visit through treatment, surgery, and beyond. And today I've been asked to share my particular perspective taking care of patients who have been diagnosed with stomach cancer. And on a personal note, my mother was diagnosed 30 years ago with esophageal cancer. And as a result, she had her esophagus removed and part of her stomach. So I have a little bit of a personal experience being a caregiver, family member to somebody who's gone through a very similar surgery. So I thought I'd kind of take you through what our patients should expect when they come and see us. As I said, I work in the cancer hospital at UNC in the outpatient realm, and our patients usually come to see us for an initial consultation. And so they arrive in clinic and they're checked in by our clinic nurses, and they begin the process of answering a lot of questions, getting their height and weight taken, giving their history, their medications. We want to know all about you, and we want you to spill the beans. And I also, at this point, want to encourage people to have a PCP. Because when you have such a big diagnosis like this, you really need a primary care physician. God forbid, along the way, you get COVID, or you have an infection, or you have heart problems and things like that. You really should have a primary care physician who's kind of in your back pocket. It's very helpful. So during your visit, during our patient's visit, we kind of we're gathering information to put the pieces of the puzzle together. I encourage people when they come to see us that they ask a lot of questions about how the pieces of their puzzle kind of fit together to kind of form a picture. We can explain what the scans mean, what the biopsies mean, what the labs mean. I encourage you to write your questions down because I think sometimes when we're in a different environment, we kind of forget some of the things that we need to talk about, things that are really important. And if you can jot down the answers too, like as we're all talking, that really, really helps. the other wonderful thing in surgical oncology is we have a lot of resources. We have social workers, we have financial counselors, we have people to help you quit smoking, and we have other resources like accommodation. At UNC, we have a SECU house, which is very helpful if you live I think 40 or 50 miles away. You're eligible to be put up for you and your family to be put up in this really fantastic environment. It's run by volunteers, and we use it often for our patients. There's also a website called MedStay that you can look up when you're getting treatment to help look at places to stay that offer a discount when you're receiving treatment. We have a comprehensive cancer support program. We have gas cards for patients. We even have a lawyer that helps with living wills and notarizing things. So we have a lot in our toolbox to help people. We also have the ability to support you emotionally. I think a lot of people think that they shouldn't be as worried about their emotional situation and their anxiety, but that is so very important. And nobody should ever feel ashamed about feeling kind of lost emotionally and depressed and anxious. And patients really need to feel very comfortable by sharing their fears with us. Now, sometimes when patients come to see us, they're kind of hoping to leave that day with a plan, to have all the answers to their questions, and unfortunately, it kind of doesn't work out that way. But never mind, don't worry, we'll get there. Sometimes you need some more scans to make sure the cancer hasn't spread. Sometimes the quality of the scans aren't the best, or we just need some more information. Maybe we need like a biopsy, another one. And sometimes for people are a little bit disappointed that it's all not going to be solved in one visit, but we will get there. The other thing that we often do is make referrals. Some of our patients need physical therapy because they've had a lot of weight loss and weakness. As I mentioned before about maybe to see psychology or maybe, those sorts of things. And we're here to help you with those sorts of things that you need to kind of like give you some additional support and care. So what's the plan, Stan? So when you meet with us, we will talk to you all about what we see. I work with Dr. Myers, and he is very good about explaining all the pieces of data that we have and what his thoughts about what the best plan of action would be. I know that the earlier speakers today have talked a lot about chemotherapy, and most of our patients get chemotherapy. And so when you're going to be having chemo, we're going to talk to you about having a port placed. You're going to have a referral to a medical oncologist, and you're going to have, a schedule of when you're getting your chemo, and it's all kind of going to be mapped out. The other thing is when you meet your medical oncologist, they're going to talk to you about side effects. And what's wonderful about medical oncology is they're very good at educating you and prescribing medications in the event that you do have side effects. A lot of our patients have nausea. We have medications for that. A lot of our patients have diarrhea. And the medical oncology folks are fantastic at kind of like anticipating that should you need those types of medications. The other thing that we talked about earlier was radiation. And a lot of people don't realize this, but radiation is kind of very short appointments, but every day, Monday through Friday. So a lot of our patients get treated locally. And so that kind of gives you an idea about kind of what to expect when you're initially diagnosed, and kind of like when you come to us to, get our thoughts and our plan. That's kind of what our plan kind of starts to look like. Now, after your patients have finished their treatment, we have to get you back. And we usually do it's kind of in a timely manner, and that's where kind of I come in. I'm like all about logistics, all about people getting their, sorry, I tend to move around a lot. So we get our patients back after they finish their treatment within a certain time period, and we get scans. And the reason why we rescan is we are really hoping that the cancer has stopped growing. has not spread, and maybe even gotten a little smaller. So Dr. Myers, who I work with, sits down with our patients and talks about what he sees on the scans and talks about what kind of surgery he's going to do. So that would be your pre-op visit. So you sign your consent, and you often get labs done, and you get some instructions that you're supposed to follow before your for your surgery, and what to expect. During this time, I encourage people to take a copy of their consent. Sometimes things happen very quickly, and it's good to kind of refer to, like, what exactly did I sign up for? Another thing that is important to think about is your support system. Oftentimes, we're going to have a caregiver taking care of our patients, so we ask that if you're eligible for FMLA, that you give us that paperwork and your caregiver as well. I know a lot of people who work full-time, they are eligible for short-term disability as well. So, you know, we talk with patients and let them know that we're here to sign paperwork to help support them with their job, short-term disability, and also their caregivers' possibility to have FMLA as well. Okay. So, during your pre-op appointment, we'll also talk to you about the plan for the hospital stay. What should I expect when I get admitted to the hospital, and how many visitors can I have? That's always a big question. So at this point at UNC, you're allowed 2 visitors. So I know that we talked about this part about, can I live without my stomach? I think that we've answered that question. And I know we've had lots of stories about that. I know that there's going to be a dietitian speaking after me, so I'm kind of going to just like lightly brush over this. But yes, you can live without a stomach, but it takes time. It takes time for your body to adjust. Usually what happens is people are kind of used to having, 3 meals a day, or maybe even skipping a meal. But people who have had this type of surgery, they need to eat very, very frequently. Sometimes you don't feel hungry, and sometimes you just feel so weak that you don't have an appetite. So the diet after a gastrectomy is, it's trial and error many times. But the good news is that we have dietitians, and we have lots of support. I'm sure the dietitian is going to be talking about dumping syndrome, which happens a lot when people have had this type of surgery. We also, after your surgery, we're going to be interested in your height, your weight, and concerned about weight loss, and hoping to keep your weight stable. So I'm just going to talk about the big day. So as our previous speaker talked about her day for her surgery, you're going to have your pre-op instructions. Usually we ask people to do a clear liquid diet. I like yours better. Yes, so clear liquid or full liquid diet the day before surgery. And of course, now in the land of COVID, our patients have to have a COVID test. I had asked Dr. Myers about the plan, how many days that you're supposed to stay in the hospital. So he says that generally his partial gastrectomies stay in the hospital for 5 days, and then total is 7 to 8. So, many people haven't been admitted to the hospital before, so it's kind of like a different world. I mean, it's difficult to have a major operation. So once patients get to the floor, they'll be taken care of by the nurses who are, our frontline people. Lots of vital signs, lots of questions about pain. The nurses will be checking the surgical site, making sure you're deep breathing, coughing, looking at how much you're eating, how much you're putting out. We get very interested in the return of bowel sounds. Some of our patients get an NG tube. And so an NG tube is a tube that is put down your throat into your stomach, and it drains some gastric juices. Usually that's not in place for very long, and it's removed. It's just to help minimize the people vomiting. and having lots of nausea. And while you're in the hospital, dietitians will be visiting you, advancing your diet, so from the sips to clear liquids to the full liquids. And also, most of our patients, actually all of our patients, get physical and occupational therapy. So for the moment our patients are admitted to the hospital, we're working towards helping them get home, get their strength up, start bringing their diet back to normal. It won't be totally back to normal, but just doing all the things we can do in order to support them to be able to let them go home. Okay, so when you're getting ready to go home, sometimes it can kind of feel like a little bit of an overwhelming thing. Our patients get discharge instructions and a post-op appointment, which is very, very important. And I think one of the most important things too is when our patients get discharged is they need to know like what they should be thinking about when they need to call, when they need to reach out to the providers, things that they need to feel concerned about. One of those is fever, of course. We worry about people having infections or pneumonia. Also, shortness of breath, we definitely want to know about that, chest pain. Worsening pain, redness around your incision, and problems with your feeding tube. Now, the total gastrectomies usually get discharged with a feeding tube, and I don't think we've talked a lot about the feeding tubes yet, but usually what happens is a feeding tube is placed with a total gastrectomy, and it goes in your jejunum. I always have a problem with that word, but there's a tube placed, and 2 feedings are used in order to supplement your nutrition until you're ready to kind of eat normally. And so our patients go home with the equipment and the supplies, and oftentimes home health, and there's a lot of teaching that is involved and a lot of support that is needed, but we do our very, very best to kind of teach people the best we possibly can, and also give them numbers to call should they run into trouble. At your post-op visit, we're always interested in your weight, of course, any symptoms, and the final pathology is discussed. And then going forward, patients might need more chemotherapy or immunotherapy, and we see our patients regularly at specific intervals, and more if people are not having sufficient weight gain, or their weight isn't stabilized, or they're having issues with dehydration, or problems with weakness and just really not returning to normal. It's concerning things like that. Okay. So I talked about knowing when to call. So things that are commonly that patients are concerned and call our triage line, or send me a MyChart message, are about wound healing. And I think people are often concerned about their incision. We want to know, and sometimes you can take a picture and actually send it by MyChart, and to see kind of what it looks like, if there's any drainage, if there's any redness, or it feels hot to touch and super more tender than it has been. We want to know about weight loss. We want to know if you're really struggling to eat, and we want to know if you're feeling dehydrated, if you're not able to drink as much as you probably should be. Many times we ask our patients, what you color your urine is. If it's super dark, we're concerned about you getting dehydrated. And sometimes we have our patients come in and get infusions in our infusion center to get some fluids and things like that, to kind of perk people up a little bit and get people feeling a little bit better. Oftentimes our patients have problems with diarrhea, so especially with the tube feeding, it can be hard to tolerate, so we have medications for that. People want to know when they can have their feeding tube removed, so we usually think about that when the weight is stabilized, and then hopefully that you're gaining some weight. Physical activity and driving, people want to get back behind the wheel, and usually we do that. We say you can't be on narcotics, can't drive under the influence. Usually, Dr. Myers tells people that they can start driving again if they just feel comfortable that they can, check their blind spot and kind of move around in the car. So it's probably going to take a little while before you can start driving again. And of course, we want to know about depression. It's nothing to be ashamed of, and it really needs to be addressed because it really makes a lot of difference to our patients. We have, as I talked about, we have counselors, and we have the ability to refer to get some medications to help with mood. And fatigue and lack of physical activity, we'll often order physical therapy. Sometimes they can come to your house, and sometimes that you do it in an outpatient situation. So I hope that that gives you some idea of what to expect. I know it's like a ton, but I just want to emphasize the fact is that your team is willing and able to support you in any way we can in all aspects of your life, and we encourage people to communicate with us and to let us know what's going on. Sometimes what works for some people doesn't work for other people, so we're very good about getting together and just brainstorming and thinking about how we can help this person feel better, how we can get them to kind of feel like they're back in the swing of things. And that's what I really love about where I work. I learn something new every day, and it genuinely is a privilege to be in the role that I'm in. And I really am thankful that you invited me today to talk to you all. And I think this has been a really special day, and I really am so proud to be a part of it. I just wanted, on a lovely note, this is my mother, and she actually went on to have breast cancer as well. And she's still going strong. She turned 82 this year, so she's doing fantastic. So here are some of the resources I used in order to provide you with some of the information. And again, I really thank you for your time. Okay.
Thank you so much, Trudy. I think it's clear why nurses are referred to as angels on earth. We have 2 more speakers in this session, and I realize we're a little tight on time, so we're going to ask you all to try to keep it to your 10 to 15 minutes. And unfortunately, that'll take us a little bit into the break, but I hope folks can just head outside if you need something. I'm pleased to introduce next Suzanne Ottinger, who is a stage 4 cancer survivor, to share with us. Suzanne.
Hello, my name's Suzanne. Thank you so much for having me here. I've really already learned a lot, and I'm always grateful to learn as much as I can about this. So briefly, we have a lot of family history. My mother had adenocarcinoma of the appendix, so like the tip of her colon, and she passed at 33. Then my father had, right after she had passed away, and he had 3 young children, he was diagnosed with CLL, which is a type of lymphoma. It never actually made him sick, and my dad remarried my second mother, and they never told us. Then later in life, my father did end up with stage 3 melanoma. And again, at that point, there was only interferon, which really didn't help that much, but he never got sick from that until 9 years later. He ended up with brain tumors. So, and even the brain tumors did not test positive for melanoma. So coming from my mother and my father, there's 3, possibly 4 types of cancer. And then I won't go into the aunts and uncles, but there's a strong family history. So I'd always been very aware and careful and getting my screening. I did regular colonoscopies even starting in my 30s. So my stomach cancer symptoms started probably around 2019. I can see in my portal that I went to the doctor. I had a lot of stomach pain when I would eat, especially certain foods, probably dairy a little bit more so, coffee, and occasional vomiting. And the vomiting was more if I ate quickly something more of a doughy texture, like a bagel or chicken, something like that. It really was more the texture than the type of the food. So that was 2019. And then, of course, we had COVID, and I always had reasons, stomach things you can say there's a lot of different reasons for stomach problems. And my doctor at the time hadn't been too concerned. So COVID ends, I'm back to work, and at this point, I'm throwing up pretty much every day. Again, it was with a thicker textured type of food. I was having a lot of stomach pains. After I ate, I would have to lay down. I would do like a meditation. I would be really shaky after I would eat. I had a lot of diarrhea. And then I also had a lot of pain through my side. I couldn't lift my arm up. I would have to, if I was in the car driving, I'd have to take this hand, put it on the steering wheel, and drive. So there was no reason to think this was connected to this. So then I went back to the doctor. They did some blood work. Everything looked fine except for my alkaline phosphatase was in the 500 range. But all my other liver enzymes were good, so they said you should see an endocrinologist, and also it's time for your colonoscopy. So go to that, get that set up. So I did, and they said, you know what, let's go ahead and do an endoscopy since you're having these stomach problems. And they got me in pretty quickly. I was lucky. And my mother went with me, and Dr. Yeatman came in after the surgery, and he said, you have a stomach tumor. And I said, what? I have a what? And we weren't able to do much of your colonoscopy. And I had had many colonoscopies because your colon is tortuous. So my stomach had distended and was pushing out all around my intestines. So they couldn't really do the colonoscopy, and the endoscopy, they found the tumor and, the gastritis and the friable mucosa. So there was a lot going on. So I right away got into the oncologist. My doctor, a scanner, the man who was saving my life, and they ordered scans. And actually, I got the scan done even before I had an appointment with him, but the scans were being done even before I had my appointment. And my scan showed that my stomach was distended into the other organs, and the lymph nodes were, filled with cancer. And I have metastatic stage 4. It's in my, this is my sternum, my scapula, all through my spine, my hips, and then they say my ribs are kind of like salt and pepper. All the cancer is, all throughout. So I also had genetic testing done through this, and I don't have the CDH1, but I have 2 types of variants of unknown significance. But one is appendix cancer, and the other is stomach cancer. So, there's got to be some connection. I gave my blood to one of the clinical trials for genetics, and then heaven forbid something were to ever happen to me, and they do find, they will always be testing my blood, and they will tell my daughter if there's anything else. So hopefully, there'll be more information, and we will have, better outcomes for the rest of my family, although I'm doing fine. So I had my scans, and my doctor, a scanner, we went to see the oncologist. I was with my boyfriend and my mom. And at this point, I still really didn't get it. And I said, okay, well, I know I've read I have to have my stomach removed, and, what's the plan? And he said, no, we do not remove some cancer. It's everywhere. It's already spread. We don't remove some cancer. And I said, well, how long am I going to live? 5 years or 5 months? And he said, I don't know. And I think that was the low. I was very upset. We stayed for a couple more minutes, and I said, I got to go. And we left. And then, we already had the plan, though. We had the plan, and my doctor, we had the biopsies also at that point, and my biopsy showed PDL1 score of 10, I did not know what that meant. It was not HER2, and the MSI testing was not done. That was a year ago. It wasn't really as much of a thing. I mean, things change so fast. Now all I hear about is MSI. Back a year ago even, it wasn't really talked about that much. Hopkins didn't even mention it. So I started right away on FOLFOX, Opdivo, and then also Xgeva, which is a monoclonal antibody for my bones. So I was getting those 3 treatments. I also right away started with the acupuncture every week, sometimes twice a week. I see 2 acupuncturists, massage. I did all of the integrative therapies as well. So I started on the FOLFOX. It was tough. The first couple rounds really weren't horrible, but it wasn't great either. And actually, I went into this with somewhat low white blood cell count. So my white blood cell count, after just 1 round of chemo, I couldn't do it. So they had to stop my chemo. And then I was really upset because I thought, well, I am strong, I am healthy, I'm young. I'm just going to be able to tolerate more treatment than anyone else. I'll get the most treatment. No, and I couldn't get chemo very often at all. Even with the Granix and then with the Neulasta, I still am getting chemo, but I never get what I'm supposed to get in the chemo. Luckily, I haven't had any side effects from the Opdivo, and I get it every 4 weeks with my Xgeva, and I've been getting it for a year. So my boyfriend and I went to Hopkins. We saw Dr. Duncan, who is the surgeon there, and he said, I can't remove your stomach because it's pushing out too far into your other organs, and no, we will not remove your stomach because it has spread. And I said, well, okay, but things are advancing so quickly. In 3 or 4 years, there's going to be something else and something else and something else. And he said, no, 2 years. You might live 2 years. You are not living 3 years. And I said to him, well, I don't believe you. And it'll take me a long time to convince myself that you're wrong. Just please, please, please remember me. And when you hear of something that might help me, please reach back out to me. And he said, okay. I mean, he spent a long time with us. He really did. But it was tough. I mean, my boyfriend and I left. We couldn't find our way out of the building for about a half an hour. It was just crazy. And then I spoke to NIH. We're in Frederick, Maryland. So I've got Hopkins and I've got NIH kind of right there. I can drive to either one very easily. And I talked to Dr. Davis, and he said no surgery. So now I'm kind of like, all right, I finally believe that no surgery. I've heard it from enough people. So, but he referred me to, I think Ann Goodwin. So Hopkins has my information, NIH has my information. Anybody that will take my information has it. If I get one lymph node that is showing cancer spread, then I will, I kind of skipped a part. I cannot get into a clinical trial because my disease is not considered measurable. In the stomach wall, it's very hard to measure, and in the bones, it's very hard to measure. So no one will take me for surgery, and no one will take me for a clinical trial at this point. But we watch it very carefully, and if it even just goes to a lymph node, then that's a possibility. So December was my one and only hospital visit. At that point I was getting the FOLFOX, and I started to get big, huge sores all over my body, and I started to get fevers, and I just get fevers with chemo and sores and things like that. My doctor was on vacation, so another doctor said, you're neutropenic and you have a fever, you need to go to the hospital. So we went to the hospital. My boyfriend stayed with me. It was still a tough time for COVID. So he just stayed there with me, and I had my first scans. And it showed ascites, which I hadn't had before, and the bone metastasis looked less, and my cancer is also diffuse type. The bones looked less diffused and more discrete, they said, which is like more, less kind of filtery and more like this. And it said progression of disease. So that was April. My doctor, when I said, you know, what is happening here? He said, no, that's not right. You know, the ascites can be from the tumors actually kind of dying off. You can have that, and then more scarring in your bones is actually better. And at this point, my alkaline phosphatase was starting to go down, and that was a good sign. And I was also able to eat. I felt a lot better at this point by the time December came around, except for from the chemo. I could eat things that I hadn't been able to eat in years. I could drink coffee without pain. And also my hunger signals were back. Prior to all of my chemo, I really just ate out of habit because it was lunchtime, or if my blood sugar would start to drop. I never really had a sense of hunger. So I would say that's another symptom kind of for people to be aware of. If you don't have a sense of hunger, maybe there's something wrong with your stomach. So then they said, no more Folfox for you. We're gonna put you on capecitabine. Capecitabine was not a good situation for me. I'm an esthetician. I do facials for a living, and I like to exercise. I don't like to sit for long periods of time. So we did 2 rounds of capecitabine. Also, my white blood cell count went even lower. My red blood cell count started to drop, and my kidneys were a little bit not quite as great. So I said, please. So we went back on the 5FU. So I'm currently doing my Opdivo, my Xgeva. I get the 5FU pump every 3 to 4 weeks. It should be every 2 weeks, but that's really what my white blood cells can handle. And then I get it with the Neulasta. So that would be really kind of what's going on with my doctor. He's fabulous. He's saving my life. He has a lot of respect in the community. He's a great doctor. I'm very, very grateful that he got me on everything that I should be on from day one, just day one. And then I go to Hopkins just for that second set of eyes so that I know, okay, we're all still on the same page. Is there anything new? Is there anything, what else is out there? And then on my own, I do take Chinese herbs. I see the acupuncturist and I take the Chinese herbs. I think it helps. I think it helps me recover. And she never says, take these instead of. She always says, these are going to make you stronger so that you can handle chemo. And I think it helps. Also, I have no neuropathy, none whatsoever. I had 8 rounds of Folfox. I think most people do. And I attribute that to the acupuncture. And I know with my next choice of chemo, I get the better chemo if I don't have neuropathy. So I think that it matters, taking care of yourself so that you're strong enough and you don't have the side effects. It helps you later on down the line. I exercise a lot. My boyfriend and I, as soon as I start to feel better, we start back with the hiking. I do about 4 yoga classes a week. I do my meditation apps. I think that helps a lot. Recently, I did this Signatera where they test the biopsy and compare it to my blood. I want the MSI right now. MSI is a thing that you hear about a lot, so of course I want it, but it failed. I think probably the tumor tissue was a little bit too old, so we tried Guardant, and the Guardant test came back that they can't find any cancer in my blood. So that's the good news. Bad news is we don't have that information that we wanted about the MSI. And, I'll just share kind of like, you always have to have something in your head, like your mantra. And for me, it's what comes out of my doctor's mouths. And, what was being said to me a year ago was really hard to hear. And, it's not that hard to hear anymore. My doctor, Dr. Skander, anytime, I come with a stack this thick, what about this, what about this, what about this? And he said, he'll never say, you're cured, or things are gonna last this long. But he did say, hopefully it doesn't come to that, hopefully you're good and we can continue on for a while. And then Dr. Beber at Hopkins, I said, to her the last time I spoke to her, I said, where do you see me a year from now? And she said, it's very unpredictable, but you're doing much better than almost anyone with stage 4 gastric cancer, and I wouldn't be surprised to see you in the same state of health a year ago. And so I tell myself that over and over and over again. So that's it. That's my story.
Thank you so much, Suzanne. What a remarkable story. We are so lucky to hear from you all. And I love that you coordinated your outfits, by the way. Really well done. So you match, you still match. We're so excited that we were able to have Miss Anissa Bass join us as our fourth speaker today. So come on up.
All right. Good afternoon, everyone. Thank you for having me. My name is Anissa Bass, and is it this button right here to move it? Yes, you should be. Okay. So my name is Anissa Bass, and as of May 2nd, I became a caregiver to my wonderful husband of 18 years, Anthony Bass. We have 3 children present. He has a son, so 4 children. And my husband was working. He had a physical in December 2021. The physical was fine. There was no indicators at all. February, we celebrated his 48th birthday. I took him to Steak 48, got him the big cowboy steak, and he couldn't eat it. And so I was noticing just little things like that. He wasn't home a lot, so I wasn't able to really watch him and monitor his, everyday habits because he worked out of state. He worked in Memphis. He was a paving foreman for RC Construction. And he had a group of guys out there, and they were out there doing airports out in Memphis and South Haven, Mississippi. So he was out working, and I was home. And I'm a nurse. I've been a nurse for 26 years. I'm also a veteran, U.S. Army, and a mother and a wife. Me and my husband, we got married twice. We married each other, divorced, and then got remarried and bought a home and moved to Charlotte. And we had so many plans to do things so different this time around. So I got thrown into COVID. I survived it. And that was great for me. I was able to meet some wonderful people. I was able to advocate for patients. I was able to stand there and do what I do, which is nursing. But with this situation with my husband, this 26-year career as a nurse really prepared me for this caregiver journey. I took it very personally that I couldn't save my husband. I thought that I could. When we found out, our oldest daughter was graduating with her master's degree from Salem University, so we were in the hospital when we got the results, and she was graduating. Let me go to the next slide. Okay. All right, so I'll just read this real quick. Okay, so on August 10th, we lost an incredible man named Anthony Bass to a long battle with stage 4 stomach cancer. Anthony endured over 30 blood transfusions, 10 rounds of radiation, 2 rounds of Fofox chemo, and an attempt at a total gastrectomy, which was aborted because of metastasis to the peritoneum. He was a loving husband, devoted father, and a mentor to those he worked with. Anthony fought hard and remained optimistic throughout his entire diagnosis. His bravery, courage, and resilience inspires his family to keep going and tell his story to everyone who will hear it. So the risk factors, I started looking, we didn't have a chance to really get in front of this thing. So my daughter, she's wonderful, y'all. We would write everything down. We had notebooks. So every time the doctors, nurses came in, we're from Charlotte, North Carolina. So we were at Levine Cancer Institute. We had the best oncology team. We had the best surgical oncologist. He was very cocky. I knew he was going to be able to get this stomach out. I knew he was going to be able to do what we needed him to do. But anyway, let me tell you. So the risk factors for my husband was he was African-American male, and statistically, African-American men die from stomach cancer more than any other ethnic group in America. He had cancer on both sides of his family. His grandmother, his grandfather, his aunt, and his mother all had cancer, which increased the chances of it showing up in him. his blood type, which I didn't know until all this happened. He was anemic, and he was also A positive blood, which is the rarest and thickest blood. It thickens very easily. And he also had H. pylori. He had it twice. Early signs was that Anthony was experiencing uncomfortable sensations in his stomach. He began to complain about feeling like just having dark stools. He also had some swelling that I noticed that I would see. We had a primary care physician. We went to the doctor. Nothing was indicated. They didn't find anything. We kept going back. He went back at least 4 times to the doctor before May. He was told twice that he had stomach ulcers. Until May, he received an endoscopy, and that revealed the stomach cancer. He was given 6 months to live at that point. So I went into overdrive because I didn't believe that. I just wasn't believing it. You know, cancer wasn't my scope of practice. You know, I've dealt with hospice, veterans, cardiac step-down patients, wound care, all type of things. But cancer was just not one of those things that was really prevalent in my family. But it was in his family. The treatment plan for Anthony was he had to get a Pleurex catheter because he had pleural effusion on his right side, on his right lung. He had an IVC filter placed. That's a filter that they place into your groin, I believe, and it travels with a really thin catheter. It travels up to your IVC, which is your inferior vena cava, and it stops any blood clots that are coming upwards to, help you not die. He also had blood clots in his lungs and his legs, and he was wearing these little massage devices on his legs to keep his legs, the circulation going. He had 10 rounds of radiation and 2 rounds of Folfox chemotherapy. First round, he did great. His urine cleared up. His hemoglobin, hematocrit came up from 5 up to 12. It was perfect. I just knew we were coming through that tunnel. I saw the light, at the end of that tunnel. Anthony began to lose his sense of taste around July, my daughter's birthday. And because of the size of his tumor in his stomach, and because also it was bleeding. Okay, he had I guess all cancers do bleed somewhere, somehow, but his was just an angry mass of his cells, and it was just bleeding, and it wouldn't stop. They had to go in twice and do a hemostat, where they spray it and keep it from bleeding so they could figure out what they were going to do. He would eat small bites and feel as though he ate a full meal. I'm going to go back real quick. When they did the surgery, they went in, and they were going to remove the stomach, and they said they saw spots. They saw some spots, and they just sewed him back up and brought him in the room and said, well, we've aborted the surgery. We can't do it. And that was the most heartbreaking thing for my husband to wake up and realize that he still had this stomach. So as a nurse, and a caregiver, I didn't know what to do. I didn't know what to tell him. And I started panicking, okay, because it's real when it's, when it's in your family, when it's in your face, and you can really see it and feel it and taste it, and you can't run away from it. You go home and it's there. So I started to panic, and my husband said, I really need you to be strong for me and not cry and not panic and just, be strong, because I may not make it out of this, and I need your voice. I need you to talk, and I need you to find out why and how I got here. When he ate too much, Anthony would vomit dark blood or anything that he had to eat or drink that day. He had a lot of vomiting of blood. That was just awful to see. He also had severe weight loss, which is called cachexia. It's cachexia. He stopped eating. He had some scar tissue that started forming in his stomach after the chemotherapy, the radiation. And that scar tissue, they thought they were going to have to do a surgery because they thought he had a block. But then they decided, he was okay. The block cleared itself. And we took him home, and, we thought we were okay. But when he started losing the weight and vomiting at a fast, very, very accelerated pace, I knew that we were headed for hospice at that point. So what I want to tell you all is to read everything you can read. Stay updated about everything concerning the form of cancer that your loved one has. Look everything up, YouTube, research studies, foundations, groups. We weren't eligible for any of the, trial therapies. I contacted, MD Anderson. I contacted Johns Hopkins. They did reach out and they did say that they would take my husband, but the doctor had already put hospice in his chart. And so once hospice comes in, they see that as being terminal. And so advocate every day for your loved one. Make sure you get copies of your records before they get too far gone, because they freeze those records, they delete them. You can't get them anymore, and you have to go through a medical release to get them. Speak up for your loved one, because they may be in a situation where they cannot. The reality is you are fighting on their behalf for their life, and that has to be done every day. I know those nurses at Novant and Atrium and Baptist Memorial. I know they know my name. I know they know my face, because I stayed with my husband. I didn't leave his side, not one time. I didn't leave. I couldn't leave him. And my daughter was there. Our other two daughters, they were there, and we did this together as a family. This just didn't happen just to my husband. It happened to all of us. And so, now we're here to tell his story, and we're also hoping that we can get, some recommendations for guidelines on, how you get a mammogram and you get you get all these tests done to make sure you don't have certain diseases. We need to also get that on board somewhere for stomach cancer. It needs to be, if it's not the endoscopy, it needs a little thing that you stick down your throat. I don't know, but it needs to be something in place for so many people that are being affected with this, because I've met so many people on the internet that are fighting this right now, just right now, Take detailed notes. You will meet so many people during the duration of your loved one's journey with cancer. Take notes on every conversation you have, because more than likely you will have to reference back to that. Stay organized. Make sure that all your notes from the visits and conversations with your care team and any appointments are organized, dated, and in an area where you can easily access it. They love that, because, you're paying attention, and, they don't have to, guess at things. They can really, give you the good answers. Thank you all. We love and miss Anthony every day. We will continue to share his story every day in hopes to spread awareness and honor his life. Thank you.
Thank you, Ms. Bass. I know it was incredibly hard to share your story. We really appreciate that. And to you and your family, I'm so sorry for your loss. Thank you to your daughter as well for fixing the slides. I couldn't see that they weren't all shown on the screen, so we appreciate that. Do we have time for one or two questions, Mira? Maybe? Okay, I know we're over time. Does anyone have a pressing question that they want to ask to this wonderful panel? Everyone's stunned into silence. What a powerful, powerful panel. Let's all thank them again.
Thank you all. Thank you, Stephanie, for moderating that panel. Okay, so I think we're going to skip our break and push through so we can try to finish kind of on time. If you guys don't mind, again, when you need to get up, please get up. Please get food or drink or go to the bathroom, come back. That is all fine. If we could move to session 5, Living with Stomach Cancer. Kermit and Lily and Dr. Myers, if you'd like to come up to the stage. Kermit, I see you talking. Okay, let me just get you back to the right. And yes, and I was just, yeah, you have it there too. I was just going to just do the really, just exactly what's written there, nothing else, and it should just be one at a time. Okay.
Hello, everyone. My name is Lily McWilliams, and I will be moderating this session on living with stomach cancer. Our first speaker is going to be Kermit Farmer. who is a stomach cancer advocate, caregiver, and founder of CarePaths, and he will be speaking on patient and caregiver perspectives.
I want to get a hug from you. Yeah, at the end of all, no, not right now, not right now. Hang on. Here's the funny thing. I'm just an emotional guy. I laugh a lot, I cry a lot, and both is okay. On the way here, we're from Auburn, Alabama, my son and I, and he's like, hey, Dad, you're going to cry when you get up there? And I'm like, well, I don't know. But it doesn't, it doesn't bother me if we do. If we don't have passion for what we do, if we, you only hurt as much as you love, right? And when you love, it's the best thing ever to have that. So, let me talk about how do you go forward?
You can just hit that.
Hit the 6.
Nope. There you go. Over here, I think we have to just click that. Yeah.
Hey, there we go. This is a vacation with my wife and some really good friends. Right before we got diagnosed with stomach cancer. My wife is right here, and Linda Farmer, and we had everything that a family would want and care for, and we were so blessed. 19 years of marriage, and all things were great, all things were wonderful, and then you get this traumatic news, and then everything changes in a moment's notice, and then you start working through that, right? We've all been through that by the very nature of who we are in this room, or doctors or nurses in the room. This is what we deal with. Clearly, I don't know how to work technology. If I hit the 6?
No, just hit that.
Oh, hit that one. Hey, here we go. So, this is back when I had a little bit of hair. We went to Maui as a celebration after marriage, and my wife looks like a dainty little flower, and I'll be quick to say she's not. She's quite the badass in every sense of the word badass. And I got asked if I could say that, and it's like, you're a caregiver. Yes, you can say whatever you want. So I said, okay, that's what I'm going to say. She, like many people who love their spouse, is the most amazing person that you've ever met and you want to spend the rest of your life with. And you have this picture of holding hands when you're 90 years old, going to the grocery store, doing whatever you do. And sometimes that's an option, and sometimes it's not. So in our case, we went through, damn, I didn't think it was going to be this hard. This is my son, who's a little bit different now. In the back of the room, he's 15 years old. We were going through adoption, and this is the first night that we had a chance to spend with him. This is my wife sitting with him in the airport in Seoul, Korea. And it's just been a beautiful ride, and have so many great memories of this time. The different events that we were able to participate in and be a part of and participate in, just so many beautiful memories. Did a really big thing for her 50th birthday. This was a year and a half ago now, where it was during COVID, and you can't really get together for a big birthday party. So we did a full parade of like a COVID parade. So we had the police cars escort out first in front of us where we were sitting, and then we had truly a drum band, and then all the cars came by, and the fire truck ended the whole thing. And it was just to celebrate her, and just how an amazing person she is and what she had done in the community. Avid runner, so just over 23 marathons or half marathons, fit as a fiddle. And I was, the husband that was at the end of the finish line each time with a beer and say, "Good job, honey," because she was able to do all things, and I was just in awe that she was able to do. Here she is with the medical team. you see the nurses around her, and I'm standing behind my wife here, and this is her practice. My wife's an oncologist. And when you have adversity, right? When you have everything, when sorry, buddy. When you as a team of oncology people in her practice, she was the first oncologist of the hospital. And when I say the first one, like the downstairs of the hospital, they cleared out human resources in order for her to have a 2-patient room, and there wasn't even a hallway. So it was less than 800 square feet, the oncology center. That's about the size of a kitchen. And from that, she was able to recruit some top-notch doctors because of her love and her compassion for her patients. And it turned into a 93,000 square foot facility. That's what it is today, which they opened, and she was a part of that for a few years, and just absolutely amazing. So with all the king's horses and all the king's men, we're going to figure this thing out, right? There's just nothing that we're not going to be able to do, but she had some stomach problems, and find out, it took an oncologist 3.5 months to diagnose the cancer and of herself. And then we're looking for the best people that she's recommended surgery to, and found that person at UAB, again from Auburn, Alabama. And so we had chemotherapy first, and then we had surgery planned for chemotherapy after. The chemotherapy after was just a little bit tough for us. So our stomach cancer journey started on May 2nd, and we had 11 hospital admissions within 10 months. Due to all the complications associated with not only the disease, but all the complications associated to the disease. And, you know, that was just a slog. Just like you, just never left my wife's side. We, with all the admissions, we stayed in the hospital and we did what we did, and that was a part of that. So here she is getting ready for battle. She's getting ready for her first chemotherapy. Again, tough as nails, and we should go up to the Spencer Cancer Center, and in part named after my son. This is us in the facility that she had a chance to participate and be a part of. And we would, you know, we're going through the process and doing everything that we can, and just with her being the badass that she is, you know, all the medical records with all, you know, every time we're in the hospital, we're checking blood work. She knows the results because she gets out of the bed and she's making decisions prior to anybody else coming in to the building, right? Because she's on the cancer floor, which is where she practices. Now she's a patient. And this is a video, and I'll show you this video, and then I'll talk on the other side of it. If it's going to play. Volume. This is us leaving the hospital after the 9th admission, and I really thought we had gotten ahead of it at this point. My wife's kidneys had failed, had to get dialysis. She's like, I'm not doing dialysis. So she was calling it. And I was like, a kidney is not going to take us out. We have accomplished too much to get this far for a kidney to take us out. Talked her into a dialysis. She thought she was going to be on it for life. She wasn't. We were there for about 20 days or so. And I really thought we could get over the hump at this time. And the nurse and I said, this is what we're going to do if we get out of here this way. So celebrating as much as we can, because we know we have the experiences. I think everybody, well, the caregivers know what this table looks like at the house. My wife was on TPN for most of the time. which is she couldn't eat regular food. She had to eat food in a bag. And the weight of all of that, and you guys, I think, know. So as much as we try to have fun with it, we had our bad hair day wigs or hats that we wore. I wore her wig more than she wore her wig, and trying to keep spirits up and what all that is. But at the end, it was just too much. So she wanted hospice, and it was 18 days at home, and that's what she had decided on. So one of the things that we did, it was like right afterwards, there were things that just caused me a lot of pain that I would see. And then what I did was turn around and I said, well, during the funeral, I'm going to give these items out that caused me a lot of emotional pain, like the blanket that she had for the last month when she was bedridden, for instance. I gave to one of the nurses who was just amazing. Her first stethoscope that she ever had went to the first oncologist that joined her practice, for instance. So we handed that out at the funeral, and I got a lot of comfort because there's certain things you don't want to look at, but it's going to bring joy to somebody else, so that's what we did. And then here's my son and I at the funeral. Sorry, Duke fans, my wife went to North Carolina. It's no accident that we were called to be here. I really think it's quite a spiritual thing. We had asked everybody, this is in Alabama now, we had asked everybody in the community that's coming to the service to wear UNC blue. Her love for the school, her love for not only the basketball, but the academics where she went was just second to none. Our playroom, for instance, is a recreation of the Dean Dome all the way in Alabama. And it's just been a beautiful thing that we've been part of. From the stage here, I talked about that we need to improve patient education, and not in a way where we make a little tweak, but we make a quantum leap in how we communicate and disseminate information to caregivers and to patients. And I didn't know what that looked like when I stood on stage, but I said, my wife was one hell of a communicator. On average, she spent over 28 minutes per patient in rural Alabama. And if you know anything about rural medicine, the population is so high and there's so few doctors, and you have to make sacrifices. And my wife's sacrifice was setting her alarm at 3:45 in the morning in order for her to get to work, for her to do what she needed to do. Sometimes she got home at 7 o'clock at night, sometimes she didn't. So the best way I can carry her legacy and her prowess for education is to do something in the space of education. And I forgot about that one. We all breathe differently, right? I forgot to mention earlier, like there's a shirt that my wife was wearing, which was, it's backwards up here, but it talks about you can do this. All the nurses made shirts for everybody and for my wife. So it said, you can do this. So there was like this big movement kind of thing. And 2 days after, I was telling myself, Kermit, you can do this. And I put on the shirt. And then I was talking to a friend on the phone, and then somebody knocked at the door, and I was like, her name's Nancy. It's like, Nancy, I got to go. I'm wearing women's clothing right now. I think we have to find the ways of coping that's consistent with who we are. And anyways, this is what I did. My observations over the 10 months is that doctors are overwhelmed with everything but time with their patient. They want to do so much, and especially they want to spend more time with their patients. And you get asked that question of X, and you know the answer to that is a 20-minute answer. It could be a 90-minute answer, depending on what it is. And you don't feel that this is my weight as a husband of 19 years as an oncologist. You don't feel like you've done a good enough job with your patients to provide the answers that you need in the time that you have available. And then patients and caregivers crave more time from their doctors. We know that. We want to know what the doctors have for us. And we hang on to the very things that our doctors tell us. And so what are we going to do, right? And the way that we do it now is auditory, that you go to the doctors, you write down your notes beforehand, you get all this information, and the whole thing is just really overwhelming. And it hasn't changed since the birth of medicine. We've had so much innovation in healthcare over the last 50 years, but how it's disseminated and communicated to caregivers and patients hasn't changed since the birth of medicine. There's more than just auditory mechanisms. We have too many tools at our disposal today for us to have the conversations that we're having, which is audio. And I have a background in work for a NASA affiliate, managed that organization for some time, got hired by NASA to do some things. And I have a background in logistics and in processes. And the things that need to happen, I would argue it's not that hard. It looks very different because it's a quantum leap in education. If our nurse navigator is still here, I don't see her. I'm going to kind of walk you through it a little bit. It's kind of two-part, and I'm almost finished, I promise. But I founded a company called CarePass, and today is the actual, as I stand here right now, it's the formal launch of that thing. I needed to put a date on the calendar, and to be in North Carolina, to honor my wife, I couldn't think of a better place. So we have a company, I can now say, called CarePass. And what we've done is built a web portal for a medical team to upload any combination of videos, audio files, Zoom links, and documents and polls or questionnaires that you can put in any order of your choosing. So you give a link to your patients and they can go through all of that information. And there's quantifiable information of what the patient has gone through and what they haven't. So the individual has it, and so does the doctor team. So you know what has been accomplished, and if you know where they are in their journey, you know where to help them. And you can extend the patient time with the doctor by providing all of this information, and it's making the doctors feel a whole lot better about it. So this is an example of a mammogram path that is, this is a view from a computer screen, but the patient can see what they've done and what they haven't done, for instance. And we have local doctors using the product now. We've been doing a lot of testing until we launched today, and looking for partners outside of that as we speak. The benefits of it is it's maximizing the physician's time, and by doing that, if the doctors can save time, it's going to provide value to doctors by the very way that it's wired. And it's simplifying the patient's journey because they're given step-by-step instructions on here's what the discharge of the hospital now looks like, or here's the medicine that you have going. And when you have empirical evidence of relationships built and lives touched by the very way that we're wired, because you have the knowledge with a timestamp of when they've been engaged. There's a lot of information where you can do three-dimensional GIFs, which is just 7 pictures here that are spliced together, where you can have conversations in a video that you can't have. That's just a whole lot harder if it's audio. And so you can have really deep conversations, or you can have some conversations of how do I take the cancer that I have and share that with my 5-year-old and my 7-year-old. And Barbara, in the back of the room, this is a picture of her actually and her kids. She was encouraged to take watercolors and to have the kids decorate her head, so they weren't afraid of it. They had ownership of it. And there's not a great way to scale or to have a lot of best practices all in the same place at the same time. So in this case, a medical team can create a path for here's what the patients need to know if you have a toddler or young kids. If as a teenager at home, I wanted something that I could give to my son, or we could walk through together that they help aid his understanding and what all that is. So what we're finding is there's an uptake in medical compliance, and this is my favorite of all that I wasn't expecting, because when you create a path with a video, you can watch that pill go down the throat, and people are actually saying, hey, I know why I need to take my blood pressure medicine. And because of that, they're actually following through with being compliant, and that leads to fewer phone calls. That leads to fewer readmissions when you know what's going on and you're actually doing the things that you need to do at home. And all of this should lead to increased satisfaction, and that's what we're all doing. Why I think doctors are going to be a part and want to be a part of this is because this is the very thing the doctor signed up for. It's the Hippocratic Oath. And they got to have their own knowledge, skills, and performance. And then they're going to make the patients their very primary concern. And in rural America, that is a really tough deal right now. And if we can give them a tool that helps them fulfill that second tenet of the Hippocratic Oath, I think we have something pretty cool. So that's all I have. And I would love nothing more than for Duke and UNC to be a part of this journey. And if there's anybody within the universities that want to talk, one large organization or a few are going to have to go first. They're going to have to pioneer it, and there's going to be pain points with that. But what we're doing now in patient education can be improved. Thank you.
Thank you for that. Okay. Shifting gears here, my name is Lily McWilliams. I'm a registered dietitian. I got the opportunity to work with some of our Duke colleagues here in the Cancer Institute outpatient for a few years, and I'm now in PA school here at Duke. So it's good to see you all again. So we're going to talk about nutrition after gastrectomy, and although this topic could be a whole symposium in itself, we're going to try to condense it into this 15-minute conversation focusing on these main points. So the overarching theme of nutrition after gastrectomy, the whole goal basically is to prevent malnutrition. So malnutrition has a very broad definition, but what we're going to focus on in this context is undernutrition that leads to a change in body composition or diminished function. And 65 to 85% of patients with gastric cancer are diagnosed with malnutrition, so it's very, very prevalent. And it's important because it leads to higher rates of morbidity, mortality, longer hospital stays and surgical recovery times, poor treatment tolerance, and decreased quality of life. On average, about 15 to 20% of patients lose about 15 to 20%, so about a fifth of their body weight after a total gastrectomy, and over 80% of that weight loss is just within the first 3 months, so it's very, very rapid. This is a snapshot of what we use to diagnose malnutrition. And there's different contexts that we diagnose malnutrition in. So I included the criteria for the diagnosis in the context of chronic illness, such as cancer, as well as the context of acute illness, such as surgery. And these are based on multiple indicators, including percentage of energy intake, percentage of weight loss over certain periods of time. We also use nutrition-focused physical exams to assess degree of subcutaneous fat and muscle mass loss, and sometimes we factor in fluid accumulation as well as loss of grip strength. So based on those criteria, we have recommendations on how we are going to intervene based on the degree of malnutrition or energy intake. So after surgery, if you're able to meet over 75% of your estimated calorie requirements, all that's recommended is a meeting with your dietitian to figure out ways to better optimize that and manage side effects. If you're meeting 50 to 75% of your needs, we recommend additional oral supplements. So those are nutrition drinks between meals, such as Boost or Ensure or other common ones that we see. If you're unable to meet 50% of your needs, we recommend supplemental tube feeds or enteral nutrition. When you're home, a lot of times what we'll do is cycle those tube feeds overnight. So you'll have this tube and then you'll get this slow infusion of nutrition overnight while you're sleeping. And that way, hopefully you can optimize your intake orally during the day. We also have a concern for something called refeeding syndrome. And refeeding syndrome occurs if you're undernourished for a long amount of time or hardly eating anything at all. And then all of a sudden you start to get nutrition again. And this can lead to a dangerous imbalance of electrolytes. So if we find that you're at risk for refeeding syndrome, we're gonna start your tube feeds very, very slowly and in the hospital so we can monitor those electrolytes frequently. If you're unable to tolerate any nutrition in your gut with tube feeds or oral intake, we're going to consider parenteral nutrition, or TPN, and that's when all the nutrition goes in through your veins, so it skips your GI tract altogether. And these estimated needs are based on a bunch of different factors. We factor in your height, your weight, your age, your activity level, and other stress factors that burn calories, such as surgery, wounds, and just the state of cancer, and many other things. So studies show now that it's actually beneficial to start slowly start titrating up your nutrition starting post-op day 1. So the Enhanced Recovery After Surgery Society recommends that if you are unable to get to 60% of your estimated needs by post-op day 6, that's when we start supplemental tube feedings. This is a hot topic being studied right now, the topic of immunonutrition supplementation, such as amino acids or omega-3 fatty acids, and supplementing with those pre or post-op. The evidence is mixed right now, so not really recommended at this time, but there is a lot of research that could be promising, but we will see. So before moving on, I want to revisit what occurs in a gastrectomy. And Dr. Blazer went into this in much more detail, but we're just going to review on a very basic level. So in a partial gastrectomy, the distal portion of your stomach is taken out, and that proximal portion is reconnected to the second part of your small intestine called the jejunum. In a total gastrectomy, your entire stomach is taken out, and your jejunum is actually stretched to meet your esophagus and is reconnected there. I want to point out that in both of these procedures, the duodenum, or some people call it duodenum, that first part of your small intestine is bypassed, and that's an important site for lots of absorption of certain micronutrients. So keeping those procedures in mind, these are some of the most commonly reported symptoms, which makes sense if you don't have that stomach reservoir to hold on to food and slowly infuse into your intestines, or if your stomach is greatly diminished in size, if you don't have one at all, or if it's just smaller. So moving forward, I know this has been touched on a few times today, but we really want to focus on small, frequent meals every hour or two, especially in the beginning, and chewing really, really well, or having soft foods. We really want to focus on high protein foods. We want to limit concentrated sweets, so those are things like candies and juices. Unfortunately, too, we want to avoid high fiber and dilute foods, so those are foods that have a lot of fiber, which unfortunately include lots of raw fruits and vegetables. Those can be really, really hard to digest right now. And the dilute foods, meaning foods that have a lot of volume but not a lot of calories. So we want to stick to those nutrient-dense foods. Hopefully over time we can start to re-implement those fruits and vegetables. Usually cooked is a little easier tolerated than raw, but that's just something we get to down the road. We also want to avoid sugar alcohols because those can cause GI distress, and limit fluid intake during meals. And that's because the fluid can fill you up, so you're not able to get in as many calories, and also it can push food through your intestines too quickly. Which brings me to my next point, dumping syndrome. Data shows that this occurs into up to 50% of patients, but I'm sure many of you could attest that it probably occurs a lot more. So this happens when especially sugary or starchy foods enter into your intestines too quickly. So because you don't have that stomach to kind of start that digestion process and pull in the juices and break things down, your intestines pull in water from your blood vessels, and therefore depleting the fluid in your blood vessels and causing vasomotor effects, so flushing, dizziness, and then also with the food moving through too quickly, you can get diarrhea. So in order to avoid that, we want to avoid concentrated sugars and simple carbs. So again, those are things like juices, candies, sweets, and that can include nutrition drinks such as Boost or Ensure that have a lot of sugar in them, so we want to stick to those lower sugar options. And there are some other strategies here to help with that. I also want to talk a little bit about fat intolerance, which is rare but can occur after surgery, and bring us back to this picture. So the yellow structure that you see here is the pancreas. And the pancreas secretes digestive enzymes. And those digestive enzymes are the main absorption point for where fat can be absorbed. The pancreas secretes into the duodenum, which is bypassed during surgery. So what happens is when the food comes through, the pancreas can get confused as to the timing of when to secrete those digestive enzymes, and it can alter how fat is absorbed. And it just takes a little while for your gut to kind of adapt to that timing again. So that can lead to fat intolerance and can lead to something called steatorrhea, which is fat in your stools. So if you see things like pale or very yellow-orange stools, really greasy or oily or floating stools, you definitely want to talk to your oncologist because you may need pancreatic enzyme replacement therapy, which is they're just enzymes that you take orally when you eat to help you better digest those foods. Lactose intolerance is also pretty common. That's gas, bloating, diarrhea with things like milk, cream, ice cream, or soft cheeses. Something I love pointing out to patients is that hard cheeses, yogurt, butter actually have very little lactose, so are usually pretty okay to digest, and we love that because those are also usually a really good source of protein and calories. You can also take a lactase enzyme that may help, so those are things like Lactaid that you see in stores. And you just take that when you eat as well. So I want to take a look at this diagram showing where different micronutrients are absorbed in our gut. So in the stomach, apart from just the gastric juices that start that digestion process, this is also the main site of intrinsic factor production, which is vital for absorbing B12 and preventing anemia. In the duodenum, which again is kind of bypassed during the surgery, that is the main site of absorption for iron, calcium, selenium, magnesium, zinc, and copper. So important to consider when we're thinking of how we want to supplement our diet. The most common micronutrient deficiency we see in this population is iron deficiency anemia. We can also see pernicious anemia from lack of B12, and that can be from lack of intake, decreased absorption, or blood losses from surgery or any other cause of bleeding. And it's important to prevent anemia because this can impair quality of life, performance status, and studies actually show that being anemic can impair your response to chemotherapy as well as radiation. So it's really hard to get enough iron and B12 in your diet after a gastrectomy, so we usually do supplement those. We want to take your iron supplement. I usually recommend taking it apart from meals so that nothing else competes for that absorption, or with the vitamin C source, which can actually enhance absorption of iron. So maybe some orange juice or some other vitamin C source that your dietitian can help identify what you like. B12, if you're at baseline, you can take that orally in high doses every day or do monthly injections. If you're deficient, you need to have more frequent intramuscular injections of the B12. So thinking back to that pancreatic rerouting that I talked about and potential for fat malabsorption, we may also commonly see malabsorption of fat-soluble vitamins. So those are vitamins A, D, E, and K that need fat to be absorbed. So if your absorption of fat is impaired, your absorption of those vitamins is also impaired. In addition to vitamin D, we know that calcium absorption can be impaired because of that loss of the duodenum, as well as calcium being excreted in more frequent stools. So we more commonly see osteopenia and osteoporosis, so we want to supplement those and monitor bone loss as well. So I recommend adding a multivitamin with additional calcium and vitamin D. This is a chart that I borrowed from our bariatric colleagues. There's a lot more research on micronutrient deficiencies in the bariatric population as opposed to the oncology and gastrectomy population. However, we know that these procedures are pretty similar and have similar long-term implications. So I just wanted to include this chart that kind of goes over what nutrients we're concerned about, why your body needs it, and the side effects of those deficiencies. So, what should we do? This is kind of just a baseline of what I will recommend to patients. So I recommend a chewable, complete multivitamin with iron, taking multiple times a day, or a bariatric specific multivitamin that has higher amounts of all those micronutrients, more than the general population would need. I also recommend extra calcium and vitamin D supplementation, the B12 injections, and additional iron in addition to what's already in that multivitamin. I also recommend getting these nutrient labs tested at baseline, 3 months and 6 months post-op if possible. Then every 6 months if you're losing weight, and every year if your weight has stabilized. I also want to emphasize the importance of optimizing your diet prior to surgery. All the studies show that that's really, really important for achieving good outcomes. So correcting any deficiencies before your surgery and really getting enough protein and calories to put yourself at a good nutrition baseline. And finally, working with the registered dietitian in your cancer center. That dietitian can kind of go through your lifestyle, go through your baseline nutrition status, go through what you like, what foods fit with your lifestyle and your culture, and kind of pinpoint what will work for you, both prior to and after surgery based on any symptoms you may be experiencing. And I also want to give another plug for that. I love working with my patients in this population, and a big reason for that is because nutrition is kind of maybe the one thing you do have somewhat of a control over, and it's something that you have the resources and have the supports, if you're able to access them, that we can really help you help yourself in the best way that you possibly can. And I hope you have gotten from this talk that it's very, very important as well. These are my references, and I'm happy to answer any questions at the Q&A session or send any of these resources. Here's my email if you want them after the talk. And now we will have Dr. Michael Myers, who is a professor of surgical oncology at UNC, talk about survivorship care.
Thank you, Lily, and I apologize if I move a little awkwardly. I injured my shoulder last night, so I'm trying to manage that. You know, in this circumstance, I think last really is least, because there's not much that I'm going to say that hasn't been mentioned by all the people in this session and the prior session, patients and caregivers in particular, and just by way of background, I'm a surgeon. I take care of a lot of stomach and esophagus cancer. In our place, people with early stage disease, we often are the ones following them as opposed to the medical oncology team, and I suspect that's true in a lot of places. And so we have some perspective on this aspect of survivorship that is probably a little bit different than the perspective that oncologists may have as they work through that in a different way. But we provide a lot of those same oversight and care. So what is survivorship? If you look around, and you can find a lot of different definitions. One of them that has become somewhat commonly used is the health and well-being of somebody with cancer from the time of diagnosis until the end of life. So starting from the time of diagnosis, not starting from the end of treatment, but thinking about that broadly and wholly. Navigating life experiences, challenges resulting from the cancer diagnosis. And so there is no one-size-fits-all for what that means, but I think what I would suggest it means is paying attention to the non-medical aspect of this. We can talk about surgery. You come see me for surgery, I'm pretty good at giving you a concise description of what to expect from an operation, what to expect afterward, what to expect long-term. But that's kind of the limits of what that conversation is. It's 12 minutes, and I know exactly how long it is, and I know exactly what I'm going to say. And I'm proud that most of the time people come with their list of questions, and really there aren't too many that haven't been answered, because we know what those things are going to be. But we aren't as good historically, certainly, at thinking more broadly. And that's something that really has changed in the last 15 years. In medicine, if we're interested in something, we're publishing about it. Academic productivity, academic publications in academic journals is a sign of interest in something. And if you look at this slide, this is 50 years of, if you just search for survivorship, 50 years ago, 4 publications, and last year 4,000, almost 5,000. And you can see that curve starting to tick up 15 years ago. When we got beyond the, okay, let's just talk about side effects of chemotherapy and what you're going to experience while you're getting that, how you're going to recover from surgery, we're thinking much more broadly and holistically. And so I just want to touch on a few kind of big bucket aspects of that, and maybe a couple of small anecdotes of my own patients, and then happy to answer questions. So it's been alluded to already. There's significant physical changes, particularly in the setting of stomach cancer. There's the recovering from treatment, which has been emphasized and talked about. My patients similarly start on a liquid diet. I send them home on a liquid diet. We learned some time ago that if you tell somebody to go ahead and start eating, they will, and that's all good, but that often sets back a little bit of that recovery as there is some back and forth there. Diet and nutrition has been emphasized, and I won't talk about that. Lifestyle is a huge one. I think that the descriptions of kind of that were wonderful, and that's probably would be me if I was facing somebody, if I had stomach cancer. But managing how and when to eat, what to eat, absolutely huge aspects of that. Changes in social life and how you live your life. A patient of mine who's several months out from a total gastrectomy, who I saw back recently, said, I'm really struggling because that was such a huge part of my social life. And now I go and I can eat a little bit, but I can't participate in the same way that I used to be able to. He's going to get better, and he'll get better. He won't get back to his baseline, but he's going to get better. And so there's a lot of support and encouragement that goes along with that. And then loss of function, particularly in older patients. And Dr. Blazer has the same experience as I do, that in our older patients, the recovery is much more significant, the barriers are much greater, and the potential for having a long-term impact on your function and getting back to your baseline is significant. And that's a conversation, it's something I spend a lot of time talking about, the impact of surgery, particularly with older patients. And what they value and what their goals are as they are closer to the end of life than they are to the beginning of life. And that's something that we are faced with in increasing numbers. And this is just a graph that suggests the number of survivors with cancer in the United States over time. You can see on the left, it starts at 1975 with about 3.5 million survivors of cancer. That second arrow, 2016, 15.5 million, five-fold increase of people who have actually survived cancer, and predicted to be upwards of 25 million 20 years from now. And the colors are different age groups, and you can see greater than 85 years old, the proportion of people who have survived cancer. That's a huge number of patients, 75 or over, that we are caring for. And the downstream side of that is significant. And there's no question that we'll see patients who, from a surgical perspective for sure, who we have that conversation, and Trudy knows the patient I'm going to refer to, who we recently saw who'd gotten some chemotherapy, and we had the conversation about what a gastrectomy looks like. And they are in that greater than 75-year-old category, have some significant underlying diseases. And he decided that wasn't going to be something he wanted to go through. His values were such that he didn't want to have to recover from that and live his life that way, and made a conscious decision. But again, I would put that in the category of survivorship and how we think about that globally. There are psychosocial aspects of that, and again, those have been highlighted. There are the emotional aspects of that for the individual. What's it mean for me? What's it mean for my family? Treatment-related side effects, we've certainly gotten much better at managing, but they're still significant. Depression and anxiety were commented on, and we see that in our surgical population, we see that in the long-term population, and everybody deals with that. And then the concept of distress, and that first bullet is just one of those definitions, kind of non-physical aspects of care. And that ranges from the normal fears and worries that you may have to disabling problems. You can't get out of bed because of the significance of this. And that's incorporated into a lot of the screening tools. This is one of those, a distress thermometer that are used in some centers, or screening problem lists like this. If you have greater than a certain number of these that you check positive for, then we start trying to work on providing support systems and support care. And that falls in that big bucket of kind of paying attention to the patient as a whole. And then lastly, life after treatment, which has been alluded to, returning to function, managing late side effects or sequelae. Fear of recurrence. What's the anxiety of going for a visit with your physician? What's that scan going to show? There was something written in the lay press a number of years ago that I read that stuck with me. It was written by a physician talking about going to a visit with their parent who had cancer and follow-up. And the comment was, the oncologist or whoever it was they were seeing comes in, and there's a conversation and chit-chat, and his comment was, all I'm thinking was what's the scan show, what's the scan show, what's the scan show? And that changed my practice. If I'm seeing somebody in follow-up for the scan, first thing I say is, your scan looks great, let me talk to you about how things are going, so that we can try and address that in ways that we can. Margot O'Neill is the PA who works with Dr. Uronis a lot, who I got to know the last couple of days. And one of the things she said, the patient that had surgery for an upper GI cancer, and the patient said it took them 2 years to eat without thinking, am I going to have trouble swallowing? Is that going to be a sign of a recurrence? So a lot of this, there are a lot of psychosocial aspects that go into this, not just short-term, but long-term. And then the caregiver challenges, I think, have been elegantly and eloquently highlighted, and I won't talk about those. This is just a publication that evaluated things from the caregiver's perspective and patient perspective from a couple of years ago. And it highlighted that in many respects, caregivers have a lot of the same challenges and issues that patients have, particularly when it comes to communication and understanding and helping patients understand that the patients have. So what's the goal? Well, a transition from treatment to recovery and thriving after cancer, and that probably starts from diagnosis. And a lot of resources, as I mentioned, have been developed. This is from the National Cancer Institute. There is an entire website dedicated to survivorship, a pamphlet of Facing Forward Life After Cancer. This is, I've forgotten how long it is, 70 or 80 pages as a resource. And then institutional resources. And again, I'm fortunate to work somewhere that has a lot of those, as does Duke. And these are the websites from our two institutions where we employ a lot of these. And that screening tool I mentioned earlier can be utilized to identify people who are having distress. We can employ some of our support systems and patterns to help deal with those, hopefully in as real a time as possible. So really what matters most, recognizing and holistically caring for the needs of cancer patients and their caregivers, regardless of when they happen, whether they're during treatment or after. Thank you very much. I appreciate it. It's a privilege to be here.
I guess we'll take some questions now if there's time.
I wanted to ask if lactose intolerance and fat intolerance are just side effects, and if they're long lasting, and if they're not long lasting, how long does it last?
That's a good question, and it really, from my understanding, just depends on the person. So from what I understand for the fat intolerance, it kind of just takes that however much time that gut to readapt to the timing of food and the secretion of the digestive enzymes. I'm not sure exactly how long. Maybe someone else in this room knows. And for the lactose intolerance, I do know that that generally does get better with time. But again, I'm not sure exactly how long that may take for it to come back.
Thank you.
I would suggest that just as Lily did, it's variable, and a lot of it's patient dependent. The majority of patients, 3 or 4 months after surgery, have, in our experience, have reached generally a threshold or a baseline, and it's not the same baseline they had before, but it's a new baseline and one that's manageable with regard to a lot of the side effects that you've asked about, and Dr. Blazer certainly has perspective on that as well.
I definitely don't have anything smarter to say than you. No, I actually was going to ask a question, I guess, to Lily. You know, I get more questions about nutrition than just about anything else, and so I was just quickly looking on the No Stomach for Cancer website, and I didn't actually see a link to a lot of nutritional. I may have missed it for sure, but I wonder, what sort of resources, you had mentioned it kind of cursorily, resources would you direct patients to? And then I might encourage us to just make sure, I mean, you could even potentially link that on the website and stuff. I mean, it's so important, and it is hard to find this stuff, so.
Yeah, I kind of gathered different resources from all over, and depending on what it was, that I did find some good resources on the No Stomach for Cancer, and then there's some resources from nutrition societies, specifically from cancer societies, specifically from surgery societies, specifically, and they all have different recommendations. And I gave kind of what I have gathered from all of those and my personal recommendations. But there are some good resources out there. And again, some of my resources were from the bariatric population. So it's really just from wherever you can find them. There's nothing really super concrete and straightforward that I could find, but there are some cancer centers and some resources that are more comprehensive that I have led patients to that I'm happy to share after this.
One of the most pressing concerns that a lot of survivor populations have is about the cost of their cancer care. And Kermit, when you talked about the 11 hospitalizations, that immediately came to mind. And I didn't see finances too much in your presentation, but I wondered if any of you had thoughts about the lasting financial distress in the survivorship years, what that meant for your family or for your patients.
I'll say I have 99 problems, but the financial distress isn't one of them. There's things that keep me awake, and it's not related to money. When it came to nutrition for us, we didn't have the resources in rural America. A friend of mine got breast cancer, and at the hospital, it's like, I need a nutrition plan. And so I went to the hospital, went and brought her back the pyramid of the nutrition pyramid as her plan, printed it off the computer, right? For every great resource that is out there, there's how many misinformation or misresources, and we need to get better information from the medical clinics to the doctor, from the medical clinics to the patients and caregivers, and we need to be able to measure and understand if they've done that or not, and then know the causations or outcomes, top 10%, bottom 10%, in order to make a measurable difference. I'm just absolutely obsessed with what, like the caregiver afterwards. I'm like, we need a path for that. Nutrition. I'm like, my God, we need a path for that. I didn't answer your question, but that's where I was.
Yeah, and you highlighted a critically important point, and one that is terribly important to patients, and I didn't talk about that from the caregiver side of things either, right? That's an issue for caregivers from a loss of income and job perspective, and it is a major issue. One that's really, really challenging to address, and I don't have any particular insights, but there is clear knowledge, and you are part of that knowledge, Dr. Wheeler. But that those things impact outcome. They impact survival, and I don't have a good answer for you. From a resource perspective, we try and pay attention to those things. From a support perspective, we're fortunate that we can support some of those things. And sometimes it's as simple as, how's the person going to come 2 hours to make it for their surgery? You come from the eastern part of the state and you have very limited resources. That's a challenge sometimes. And how do we make that happen? And so we try and pay attention to those things as early on as we can from a surgical perspective as well. I think Dr. Uronis has a perspective on that too.
I don't necessarily have anything profound to say, but I do think that just in thinking, I was at a different thing with Dr. Myers, and we were talking a little bit about this in the last couple of days. I think we need to, I can speak for myself, I need to do a better job of sort of having the conversation, because I was relaying something to him. I had a patient who was on full Fox Opdivo, and I didn't realize his copay for Opdivo was $1,000 each dose until I said, now you need to have more. And he was like, I can't afford more. I was like, wait, what are you talking about? And then he told me, I said, why didn't you tell me that? And he said, I just thought that's how much it cost. And then I felt terrible, because I probably should have asked or said something, but it's we as doctors, I don't know how much it costs. My son needed shoulder surgery, and he at 14 said, how much does it cost? And the surgeon said, I have no idea, which we don't. And so, but we've had other stories in like our practice at Duke where people have remortgaged their houses or things like that because they don't bring it up. And I think it's because it's kind of a taboo thing to think, and they don't want anybody to think they don't want to do the treatment. So I don't have an answer, but I feel like we need to somehow talk more about it, or make it more of something that people are comfortable talking about. And then the other part of it for us is making sure we know who to send them to for answers, because a lot of times we also don't have that.
And I think that brings up a great point. And one of my other hats that I from a disease perspective that I see a lot of is melanoma. And there's one aspect of melanoma care where there's some where we can have a thoughtful discussion about what we're going to do from a surgical perspective. And I've started incorporating the difference in cost for that, because it is critical to many patients. And it's from a medical perspective, if we're going to think about that, write something about that, we're going to publish what the cost is. Right? We're not going to publish what the burden of the patients are. And I think we lose track of what the copays are and how significant that can be for an individual patient.
Well, I just wanted, cost is a big thing, and maybe this would help somebody. I call every single pharmaceutical company, and my cancer center has a financial department, and they work with me. But I call, Opdivo, and they told me, if you can't pay for it, we will cover it. Sometimes they won't, but I do just directly. And I also get a lot of information from them. Once they have your name and address, they send you a lot on anything that they know. I get cookbooks in the mail. I get a lot of support from the pharmaceutical companies in different ways.
Yeah, and I think a lot of that for us, I think systematically is just identifying the need and being more systematic about that. I think is and intentional about that. And I think again, we here or for us in Chapel Hill here at Duke, we have a lot of resources and we have a lot of people who help manage that. We have the pharmacy. Oncology pharmacists who are a big part of that. We have financial coordinators and counselors who are a big part of that, but opening the conversation can be challenging. It can be difficult for patients to begin that conversation for sure.
Okay, looks like we don't have any more questions. Thank you so much. And actually, I think you were not the least, Dr. Myers. I think ending with survivorship care was really positive and good to hear. And I like that this is the last thing that you guys will see from us today. So just really thank you, everyone, for coming. I think those of us whose hearts or research or focus is on stomach cancer, this is a really special time to get together and talk about this and be together for all the different aspects. So again, thank you all so much. Thank you to every speaker for speaking and sharing. I think that I wanted to remind you that there is a reception tonight at the JB Duke from 5:30 to 8:30. I think Dylan mentioned it this morning. It's free. It's just a time to gather and chat if you'd like to. 5:30 at the Club Room at JB Duke, which is a hotel right here on Duke's campus. I have also been told there are lots of extra veggie wraps and salads or sandwiches. If you would like one or two or three, please take them home to your families.